PIO Congress here at the Andalusian Hall. My special gratitude to our foreign speakers who have come from all around the world to be here and to teach us here. And I'm really indebted in gratitude to Professor Mukhtar Ahmed Saab, who has kindly, in spite of his illness, has come here. Mukhtar Saab, हम इन्हें बाबाए of vitreoretina कहते हैं यहाँ पे. He is the one who held the flag of vitreoretina when nobody was practicing it. And I also welcome Professor Major General Mazhar Ishaq Saab, who is the chief guest here. And I welcome all the other distinguished guests here who have taken time out of their busy schedules to come here. I will now request, I think we have a national anthem coming up. I'll request all of you to kindly stand up in its respect. Thank you, ladies and gentlemen. Allah Ta'ala Hafiz Jalindri Saab ko करवट करवट जन्नत नसीब अता फरमाए. इतना खूबसूरत कौमी नगमा लिखा हमारे लिए, काश हम इस पर अमल भी करें. May I now request Mr. Arsalan Hashmani. He is the Chief Executive of the Hashmani Group of Hospitals, to please come on the stage and tell us about PIO and a brief history of the PIO. Mr. Arsalan Hashmani.
Hello, Assalamu alaikum. The beautiful thing about technology is it doesn't work when you want it to. Assalamu alaikum. Good morning, professors, doctors, our esteemed guests who have joined us from 7 different nations from across the world. Ladies and gentlemen, I formally welcome you all to this year's esteemed PIO conference on behalf of Hashmanis Group of Hospitals and on behalf of the PIO co-committee. My name is Arsalan Hashmani and I am the Group CEO of the Hashmanis Group of Hospitals. PIO was a thought, a brainchild, an ideology perceived around 7 years ago. The vision is to connect, collaborate, exchange best practices, share experiences, ideas, and enhance the overall standard of ophthalmology practiced in Pakistan. Over the years, we have hosted names like Dr. Steve Charles, Dr. Bernard Chang, Dr. William Sponsel, Dr. Rohit Shetty, and Dr. John Kanelopoulos, and focused on topics ranging from corneal topography to latest trends in glaucoma, to innovation in OCT, and to next generation ophthalmology. This year, at the 7th PIO, we host 7 international speakers from 7 different nations as well. We'll be giving out a gold medal. Today, Alhamdulillah, I'm also proud to announce that we are live on Facebook, and we're also live on Zoom. And we have ophthalmologists and people from the medical community attending over Zoom from Singapore, from China, and from Saudi Arabia. And as the conference progresses, we'll be taking live questions and comments from them as well. Let me talk briefly about Hashmanis as well. Hashmanis Group of Hospitals has been serving the profession since the past 5 decades. It was started by my father, the legend, Dr. Sharif Hashmani. Today, the seed, mashallah, that he had planted around 5 decades ago has grown into a network of 6 eye hospitals, a laboratory network of 20 locations, and a dental and aesthetics services setup at 2 locations. If I talk about laboratory services during COVID, the laboratory played a vital role in helping not just Karachi, but the nation fight the pandemic. Be it serving or offering vaccines such as the Sputnik vaccine, or offering PCR testing services, or antibody testing services. We played our role, and at the peak, we were doing anywhere from 1,500 to 2,000 tests a day. And alhamdulillah, today we have a network of 20 locations, and we have a test menu of over 1,000 tests. If I talk about our eye services, we have 6 hospitals, like you've already mentioned before. But I'd like to highlight one point here. We have a hospital that's one of its kind in Pakistan. It's a hospital inside a mall. And the concept is that the entire family can come and spend a day there shopping while the people that need their eye treatments get their eye checked. We also host medical and eye camps across the city. And today, alhamdulillah, we have a dedicated team that organizes anywhere from 3 to 4 camps a week. That's around 20 to 25 camps a month. And in each camp, we see anywhere from 500 to 1,000 patients, all free of cost. We also have a foundation by the name of Hashmanis Foundation that sees anywhere from 30 to 40,000 patients a month. And we perform around 1,000 surgeries free of cost every month. Alhamdulillah, we're known to have the latest equipment and the most services and treatments that are offered. And owing to that legacy, we'll be launching 2 new services and products today. I'll be showing you the video of both these products and services as we formally launch these services in Pakistan. Can we have the first video, please? Smile. So as you can see, the ad was about the refractive equipment and a refractive procedure. Alhamdulillah, this year we'll be launching the SMILE procedure. And the tagline, as you can see, is that we want you all and Pakistan to smile with Hashmanis, inshallah. SMILE procedure adds to our refractive capabilities. We already have LASIK and femto-LASIK and different product suites within the LASIK family. And now to add to the refractive family, we've added the SMILE procedure, which is a minimally invasive procedure. And it gives our patients the comfort and flexibility to come to us and to select the option that is best suited to their needs. Similarly, with this, there's another product that we're launching today. I'll show you the video and then we'll talk a little about it as well. So I hope the video was self-explanatory. Optos is a state-of-the-art equipment, something that was missing from the diagnostic imaging landscape of Pakistan, a wide field fundus imaging solution. And this is the top-of-the-line variant that comes equipped with the peripheral sweat source OCT. So with this, I formally launched these two products. We want you to smile with Hashmanis, and we want everybody to see properly. So with this, on behalf of Hashmanis Group of Hospitals, I mark the opening of the 7th PIO conference, and I formally thank all of you for joining us today. Let the conference begin. Thank you.
May I request now Dr. Noman Hashmani to kindly come and give a brief introduction of all the foreign and national guests who are here to speak and enhance our knowledge. Dr. Noman Hashmani, please.
Assalamu alaikum, everyone. So I'm not going to take much time. I just want to introduce the guests that have traveled all the way from all around the world here. So before we start, I'm going to want to try introduce the local speakers before we go to the international speakers. So I would like to first thank Dr. Professor Khakan coming all the way from Lahore. Please give him a round of applause. Then I think in Karachi, the next two speakers need no introduction at all. We've got Dr. Rahman Siddiqui, who works at Aga Khan University. Please give him a round of applause as well. And then the next speaker, everyone knows Dr. Idris Edi, who's a consultant ophthalmologist, works at Taj Medical Complex and Hashmanis Hospital. Then we've got someone from Islamabad, Professor Dr. Muhammad Amjad, who's working in Al Shifa Eye Trust. And finally, we've got one other person who couldn't make it, unfortunately, but we would like to remember him all the same, Dr. Abdul Sami Memon, who works in Aga Khan University as well. Then moving on to the international speakers, unfortunately, a couple of them couldn't be here, but don't worry, the best of the best are still here, and they're here to teach us and enlighten us all the same. So I would first like to introduce Dr. Tamer Mahmood, who is the professor of ophthalmology at Oakland University William Beaumont School of Medicine. Please give him a round of applause. Then we've got Dr. Walid Zabiba, who works as a professor faculty of medicine of Tunis. Please give him a round of applause as well. Then we've got Dr. Jose Antonio Roca Fernandez, who's joined us all the way from Peru. He works as a retina and vitreous macular cornea and cataract and refractive. Please give him a round of applause as well. And then finally, we've got Dr. Nicola Ghazi, who's the department chair and clinical professor of ophthalmology at Cleveland Clinic in Abu Dhabi. Please give him a round of applause as well. So that was my time. I'm just going to hand this over back to Dr. Misbah, and we'll start the session now.
Thank you, Noman, for sticking to the time. And after all the niceties and after all the wait, let's start. So first of our speakers is Dr. Walid Zabiba from Tunisia, and he's going to talk about two techniques, one goal. Dr. Walid.
Thank you. Good morning, everybody. It's my pleasure to be here, to be with you. Thanks for the huge hospitality and the and this beautiful country and the kind people. So my my presentation focuses on two techniques for one goal. We have to. This two techniques transform the landscape of aphakia correction. The first one is the modified Yamani technique, and the second one is the Carleval IOL techniques. So we will compare the two results of these two IOLs for the correction of aphakia. The main difference between these two IOLs is that the Carleval is made for this kind of situation. It's an acrylic foldable IOL, either hydrophobic or hydrophilic one. Within this 13.2 millimeters, it easily reaches the two sides of the sclera. Its 10 degrees angulation between haptic and optics avoids the contact with the cellular body. For the 3 pieces IOL, it's useful for other situations, but with artisanal maneuvers, we can correct the aphakia with this type of IOL. However, it's smaller than the Carnival IOL. So let's begin. We start with my first case. We start here with the Carnival one. We start with making the horizontal diameters. Then we mark the scleral pocket with 2 millimeters side square. Then we create the Hoffman pockets at 3 and 9 o'clock using a crescent knife. So we begin with the corneal side. Then we perform the pocket in the thinner of the sclera, 50% of the thin. Then we rotate the microscope to be more comfortable, and we attack the second pocket. After creating the pocket, we have to do whole vitrectomy. It's recommended by the manufacturer of this kind of IOLs. Then we place the IOL in the anterior chamber, and we take out anchor through the sclera, and we put gently this anchor into the pocket using Tortman forceps. And at the list we have a sutureless corrected of aphakia with this kind of IOL. In this picture, we can see clearly the anchor is intimately enclosed into the scleral wall. The second technique is well known, yes. I will share with you one of my cases. In these complicated cases with zonulopathy, so we start with surgical with scleral tunnel to extract the nucleus. When we place the IOL in the anterior chamber, we introduce the first haptic into the 27 gauge needle, and we take through the scleral 2 millimeters behind the limbus. We repeat the same maneuvers with the second haptics, and then we cauterize the extremities of the haptic to ensure the stability of the haptics into the sclera. So the second haptics. And at the list we have also sutureless technique for corrected aphakia. And we have button of the haptic under the conjunctiva that can irritate the patient. So our purpose is to compare the two techniques, functional results and anatomical results. So we conclude a monocentric prospective and comparative study in our department in the north of Africa and Tunisia between 20 and 23. Our study includes a sutureless scleral fixation. We exclude patients with posterior segment pathologists, and we enrolled 18 eyes with Carleval and 20 eyes with Yamani technique. The follow-up period for all patients was 6 months. We have no
there's a bit of hiccup in the IT department. I can invite a question if anybody likes to
Yes,
ask
if you have
anything
question,
from
Dr.
Walid. And there are 2 mics in the center. You can come here and ask a question. Just a short one, please.
Dr. Tamer, we discussed yesterday about vitrectomy in these cases when we place
Thank you very much, Dr. Walid. I've got a lot of experience with the Karle Wale, but your technique is so beautiful, the sutureless. I've always raised the flap from the other side, this clear flap, and put the sutures on the flap, but your technique is excellent, I think.
Thank you.
Some good points to learn. Thank you.
Would you like to add something? Yes, sure.
Yeah. Thank you,
Yes.
Walid.
Okay. We go?
Yeah, let's go.
Yeah, Walid,
Yes.
you brought the issue of vitrectomy in these cases, and I would like to comment on this.
Yes.
You know, specifically for the Carli lens, you showed that you use a forceps to pull the haptics outside the sclerotomy. So, you know, I prefer a full vitrectomy with a good peripheral shave in these cases to avoid manipulating the peripheral vitreous.
Yes, of course.
Yes, just to add to your point.
Yes.
I know it is a controversial point and it's not like this everywhere, but in our department, that's what we do. This procedure is done by vitreoretinal surgeons in our institution, the majority of them, in order to ensure a good vitreous shave to minimize complications, because vitreous-based manipulation can be risky.
Yes. Even for Yamani technique, it's recommended to do vitrectomy, or not, you don't agree with us? Okay. So, I turn back. So, we'll discuss our results. So there is no difference regarding data, age, gender, laterality between the 2 groups, and the most frequent etiology for the scleral fixated implantation was the complicated surgery, cataract surgery, as where we are a surgical training department. So also there is no statistically significant difference between the baseline spherical equivalent and the baseline best corrected visual acuity between the 2 groups. Also, no difference regarding perioperative complications. There is a low rate of complication into this surgery. At 1 month, 3 months, and 6 months, no difference regarding spherical equivalent was found. However, we have a significant p-value regarding the best corrected visual acuity with the Carnival 1 at 3 months and at 6 months. So we have best corrected visual acuity significant with the Carnival. This graph shows the evolution of the best corrected visual acuity over the time, with both groups, as we can see here, better with Carnival IOL. And the second graph shows the endothelium cells loss due to surgical maneuvers. This reduction was similar in both techniques regarding the maneuver in the anterior chamber. We noted a lower tilt with the Carnival group with a significant p-value. This anterior OCT picture shows how we can calculate and measure the tilt with the IOL. The first one is 1 degree tilt with the Carnival. The second one is 6 degree with the Yamani technique. Regarding post-operative complication, it's worth noting the positive outcome in the Carnival group. However, the decentration is more common with the Yamani technique. Regarding this chart, within this significant p-value, better initial vision lead to better outcome in both groups. Greater tilt was linked with poor visual results, and Carnival has lower tilt. So, in conclusion, our prospective and comparative study demonstrate that the Carnival won the battle with super functional and anatomical outcomes. Thank you for watching. So we discuss now, or yes? Yes. Yes. Yes, I will come to you to hear you more. Oh.
So sorry, but that was not working. Actually, we do Yamani technique over here.
Yes.
And we don't have cardival IOL, so we don't do that. And that was a very good video that you showed. My question was that we use MA60 AC, that is Alcon 1. But sometimes it break and
Yes.
you have to have a backup. So which lens do you prefer for Yamani, and what do you think, why do you prefer and which do you prefer?
So it's a great question. So it's a good question because with the MA60 of Alcon, the haptic is made with PMMA, and with thickness 3 pieces IOL, the haptic is made with polyvinyl, and it's very useful to use this kind of technique. We discussed this with Dr. Nicola yesterday, so it's useful to use the techniques, the Johnson & Johnson one.
Yeah, Walid, can I just ask one question? Walid, I think you have been, while doing these lenses,
Yes.
the eye gets very soft, and most of the time you struggle with a soft eye. Is it not a good idea to maintain the anterior chamber?
Yes, we can maintain the anterior chamber by the infusion.
Yeah,
we,
then
we put.
then it's become very easy. Otherwise,
Yes,
it's a very
in this case, I did a vitrectomy, so it's easy to maintain the positive pressure into the eye. So when we don't need to do vitrectomy, we have to put infusion in anterior chamber.
Thank you. Thank you very much, Walid, for your excellent presentation.
I keep my
Okay.
for the next.
May I remind the participants that we have a microphone on 2 sides of the hall. Anyone who wants to ask a question can kindly come there and ask the question. The next speaker now is Nicola Ghazi.
Yeah.
I think we have 29 presentations to listen to, so I would request all the speakers to kindly restrict to the time, and I request all those who want to ask questions to keep it crisp and short. Thank you.
Thank you very much for the kind invitation and for being here over a weekend. So far we enjoyed our stay here. We're having great time meeting you all, and I hope that you'll find my presentation beneficial. So thank you, Dr. Walid, for setting the stage for this talk. I'm going to build up on what Dr. Walid has just presented and present to you a new technique that we recently described to solve the issue or to deal with the issue of aphakia. As you know, aphakia without capsular support remains to be a challenging condition. There are many ways to address this, from ACIOL to iris fixated techniques to scleral fixated techniques. Each category has different versions of surgical techniques within them. But I have to say, and like Dr. Walid just showed, that even with a review from the American Academy of Ophthalmology, that there is no major differences really between any of these techniques. They all more or less lead to the same visual outcomes. Each one of them has their advantages and disadvantages and surgical tricks and complexities. But honestly, vision-wise, it's not a major difference. You could see from Dr. Wali's presentation that the Carnivale did a little bit better. The p-values were not very significantly different. So this has been our experience too, that there is no big difference between these two techniques. And hence, I think it's good to either know as many as possible or to surround yourself with people who know as many as possible, because it's not one technique that fits all. For example, in a case of trauma, where you don't have any iris at all, you cannot consider a CIOL or iris fixation. Scleral fixation is a must. In a patient with significant scleral disease, multiple tubes, multiple previous surgeries, scleral surgery may not be a good idea, etc. So it's not one technique that fits all. But I will focus on scleral fixated IOL. So the ideal technique in our mind should place IOL in the normal crystalline lens plane, as Dr. Walid alluded to, away from the iris and the ciliary body. It should allow at least 4-point fixation to minimize tilt. As you saw, tilt as it's an inherent problem to secondary IOL scleral fixation. Because we do the markings manually, it is impossible to come up with a perfect horizontal plane while fixing these IOLs manually, let alone the manipulation of the haptics, etc. So tilt is really an inherent problem no matter what we do. It should utilize a readily available, off-the-shelf intraocular lens in order to avoid bringing the patient back another time to surgery. That's a big advantage. And that's one of the disadvantages in my mind to the Carnivale lens, because if this complication happens, you have to stop the procedure, terminate it, and then bring the patient back. And that has psychological impact to both the physician and the patient. It should utilize a hydrophobic IOL. Again, the hydrophobic IOL minimizes the chances of opacification. Again, another downside of the Carnivale lens, as you saw, is that it's hydrophilic. There are several occasions of explantation of the Carnivale lens now. And now they're coming up with a version that is hydrophobic coated in order to avoid this problem. Uses a foldable IOL for a small incision. It should avoid peritomies, glue, scleral manipulation, and suturing in order to have an efficient and less time-consuming procedure. Again, these are issues with the Carnivale lens, big incision, scleral pockets, etc. And the ideal technique should also avoid the need for special material and equipment. If you can avoid the need for PVDF haptics to avoid breakage, you don't need a special 30-gauge needle to insert the haptics. These are all pluses to a technique. And finally, I believe it should avoid large suture knots, because these can lead to intra-op and post-op leakage and hypotony with significant problems. So none of the techniques really that have been described so far fit all these criteria. I think it's impossible almost to fit all these criteria, but many of these techniques have disadvantages. Like you heard, the most commonly used now is the Yamani and the Carnivale. The Carnivale needs special lenses, scleral manipulation, hydrophilic, opacification, etc. The Yamani technique, you need special haptics and special needle in order to be able to do it. I talked to all my colleagues who use the currently available 3-piece IOLs, readily available. They all suffer from breakage. They all have to have a secondary IOL, a second IOL standby in case they face breakage of the second haptic especially. So we adopted the technique developed by or promoted by the Wills Eye, which is the Gore-Tex fixation. The problems with this, the advantage is that it uses 4-point fixation, resilient sutures, but it uses these large knots that you really need to bury, and many times the sclerotomy gets enlarged and you develop intra-op and post-op leakage and hypotony. I many times have to suture over them. Also, you need a peritomy in order to make sure you don't get exposure of the sutures post-op. And I close these peritomies the way the glaucoma surgeons do it, with a mattress suture. It's time-consuming, really. And finally, it's a hydrophilic IOL. There are many cases of opacification, particularly in these eyes that are prone to need DSEC or retinal detachment surgery in the future with gas tamponade, where opacification is much more common. And sure enough, there are many reports of the literature of explantation of the aqueous IOL because of opacification. And really, this is the last thing you want to do after you have had implanted a scleral fixated IOL. You don't want to explant it. And explanting these is not a simple matter. So we wanted to develop on this technique. We wanted to use a hydrophobic IOL that allows 4-point fixation. We wanted to avoid peritomies and knot burial, which are, in our minds, disadvantages of the Wills Gore-Tex technique. Now, avoiding the peritomy and the knot was an easy task because Sergio Canabrava in Brazil has described the flange proline scleral fixation technique. He used it in PMMA lenses. He used it in the aqueous lens. He used it initially with currently available hydrophobic platforms like the Acrysoft, the CT Lucia, etc., but then abandoned it. We did the same thing, and I'll show you why. And then he has developed his own hydrophobic IOL for 4-point fixation, which he calls a shoelace technique. So it's, again, a special IOL. So finding a hydrophobic IOL was a more challenging situation for 4-point fixation. And like I said, we really tried many of the hydrophobic platforms using all the techniques described. We used creating punctures using 30-gauge needles, as you can see here. Whether you do it at the haptic-optic junction or in the optic, the same thing. We tried using BV needles also in order to produce these punctures to minimize damage to the IOL. But you can see it almost invariably damages the material of the IOL, and it cheese wires easily. So we gave up this. We also tried the flange technique, passing through the optic. That was also described by Sergio Canabrava. But again, you damage the optic, and then it cheese wires very easily. So we really abandoned this like Sergio Canabrava, and we think this is not an ideal technique to do, at least in our mind. So we use this hydrophobic IOL. It's currently available. It's made for in-the-bag implantation. It's called the Invista MX60 IOL. It's hydrophobic, it's biconvex, biaspheric, and aberration neutral, and I will talk about these advantages. This IOL, and I have no financial interest at all here, has an eyelet at each optic-haptic junction. So you can thread a 6O proline through this eyelet in such a way that the loop is towards the optic and the trailing ends are towards the outside, hence the term Lotto technique. So loop towards the optic, trailing ends towards the outside. There are several ways of doing this. We started with the technique shown on the top left, but now we move to the one shown in the bottom right. I will summarize it for you in pictures. You take a 6O proline loop, you pass it through the eyelet, you pass it through the eyelet, then over the haptic, and you retrieve the trailing ends through the loop in order to come up with the Lotto loop. It's different from the cow hitch technique by this last step of retrieving the trailing ends through the loop. And as you know, the Invista is a fragile lens. There has been many reports of Invista fractures during and following implantation. And this has been reported with many different suturing techniques, the simple pass, etc., and using 10O proline and Gore-Tex. But studies have shown that the simple pass technique is the most resilient to fracture. So we did a laboratory study to compare the load needed to fracture the lens using the simple pass versus our Lotto technique. And we were delighted to see that the load needed is the same in both techniques, suggesting that our approach does not compromise safety. There were other techniques suggesting that fracture is due to cheese wiring through the material of the IOL. These techniques use the cow hitch technique and 10O proline, very small sutures, and you can see on scanning electron microscopy the sequential waves of the line as it cheese wires through the IOL material. We did scanning electron microscopy in our cases in the lab, and we didn't find any evidence of cheese wiring, probably because we use a much thicker proline, 6O instead of 10O, with lower chances of cheese wiring. So we started this in the model eye. You can see here the old technique. You use a 30-gauge needle, 6O proline. You do the loop outside the eye, and you retrieve the trailing ends with a regular 30-gauge needle. And you have the loop on one side of the eye. You do the same on the other side, and you have the two loops. You can see them here, the two loops. And then you fold the IOL through a small incision, 3.5 millimeters incision, and then you flange the proline, and you get a well-centered IOL. Here it is from the back. you can see the 4-point fixation to the sclera. Here's the first case that I did. Patient had multiple previous surgeries, retinal detachment surgery, cataract surgery, followed by 3 attempts of scleral fixation because of continuous dislocation. Here's a Yamani. He came to me after this Yamani technique. You can see the IOL almost vertical to the corneal plane, exposure of the 2 haptics, and significant scarring of the conjunctiva from previous retinal surgeries. So we felt that a intrascleral technique would be the safer technique in this, and we applied our technique. You can see here we decided to amputate the haptics. We didn't want to push them back into the eye for the fear of endophthalmitis. We did this on both eyes, on both sides, and we removed the IOL. And I decided in this case to remove the capsular bag because there were lots of fragments of hardware from previous IOL implantation. You can see an acryos fragment there. And then we did our technique. Again, this is the old technique of doing the suture. You see one haptic, one loto loop here on one side of the IOL, and this is it over here. Then you do the same on the other side, fold the IOL, insert it in, and then you can see the loops on either side. You cinch them down, you center the IOL well, and you flange. No peritomy, no scleral tunnels, no scleral manipulation at all, and you end up with a well-centered IOL. Here's the post-op appearance. Now, you can see the flanges here in the subconjunctival space. These are much bigger than they need to be. We learned that over time and with the development of the literature. So now we do much smaller flanges that we can push into the scleral tunnel in order to avoid exposure. And you can see well-centered IOL on UBM here. Here's a second case that also had an epiretinal membrane, here removing VCRs, vitreous cortical remnants. And you can see here the new technique. So loop into the eyelet over the haptic, and then you retrieve the trailing ends through the loop. You use a regular 30-gauge needle to retrieve the 6-O-proline outside of the eye, the trailing ends, and then you end up with one loop on one side. You do the same on the other side, fold the IOL and insert it in, then gently cinch the loop in for well centration, small flange, about 0.5 to 0.75 millimeters, and then you really have to push it into the scleral canal in order to bury it under the conjunctiva. So the advantages of this technique: no peritomy or scleral manipulation, 4-point fixation, uses a hydrophobic IOL, and hence avoids opacification. We use an aberration neutral IOL, and these are very forgiving for decentration and tilt, and like I said, these are inherent problems to IOL scleral fixation. And it's readily available. So this IOL is made for in-the-bag implantation. So if the complication happened on the table, you can continue with the same IOL to fixate it to the sclera. You don't need to order any new IOLs. You don't need to bring the patient back. It's one procedure in and out. This is the initial report we had, proof of concept, 9 patients. The first patient really was our best patient, 20/25 visual acuity, but only 1 week of follow-up, so it was excluded. 4 patients had poor visual outcome, although all of them improved their vision. But these 4 had multiple comorbidities. The 2 I showed you the videos of, one had retinal detachment before, the second had chronic hypotony. I will show you this case later this afternoon in the challenging cases. And the other 2 had diabetic macular edema and penetrating keratoplasty histories. We looked at centration and tilt using UBM rather than OCT, like Dr. Waleed showed, and we found that the IOLs were well centered. The tilt was from 0 to 9.6 degrees. The median is 2.9, really very low degree of tilt. But like I said, no matter what you do, an element of tilt will be there. CME developed in 2 patients, and one of those 2 patients had a flange extrusion, which was the first case. And this is another advantage of this technique. If you have a flange extrusion, you can fix it in the clinic. All what you need to do is trim it, cauterize a little bit, and push it back into the sclera. Whereas if you have suture extrusion with the acryos or with the Carlivali, it's a much bigger deal. The patient has to go to the OR. And it's either a scleral patch or refixation, etc.
Dr. Ghazi, you are out of time, please.
So in conclusion, we propose a new technique called the Loto technique. Definitely more studies are needed to validate our results. Thank you very much for the invitation. The co-workers, I'd like to acknowledge them. Thank you so much.
Thank you very much, Dr. Ghazi. Very nice presentation.
Thank you.
And we are open for just one question. Anyone wanting a question? Not at the moment. Okay, then Dr. Ghazi will be here, so you can ask him later on. Our next speaker is Dr. Jose Antonio. He is from Peru, Lima, and is going to talk about dengue's retinopathy.
Good morning, and it's my privilege to be here with you. And thank you for the kind invitation. Last year we have a lot of dengue in Peru, so I didn't know anything about dengue, so that's why I bring this for you today. Let me check here. Okay, I'm going to present you 4 cases. This is the first case is a 40-year-old female that had 4 days vision loss in the left eye, and 4 weeks before she had diagnosis of dengue. Her visual acuity was 20/400. The intraocular pressure were normal. The anterior segment is normal. This is the right eye. You can see a normal eye, and in the left eye, in the left eye, you can see some blurriness of the posterior pole, some exudation and vascular tortuosity. This is a close view with the exudation, the vessel dilatations. The labs were within normal limits. You can see the normal limits. This is the fluorescein angiogram, some hyperfluorescence of staining of the vessels. You can see here some leakage around the fovea also, but it's not macular edema. No, it's not when you want to see the OCTs. It's not a cysto macular edema, but it has some leakage around the fovea and also around the vessels. This is the right eye, it's normal, and in the left eye you can see those. You have a pointer? No. And there's some hyperreflective forces in the outer nuclear layer, and some increased reflectivity of the outer plexiformal layer. You can see in the right eye, in the right side of the fovea. Thanks. Here you can see these changes in the fovea here. She had some you can see here some scotoma in the left eye. We tried this patient with some tinus triamcinolone, and then 1 week she had some improvement in her visual acuity and in her visual complaints. But she complains also of a grayish dot that limits her vision in the left eye. The vision improved to 20/80, and there was not more vitritis and some loss of the macular brightness. And in the second case, it's a 30-year-old male. He had 1 week decreased vision in the left eye associated with some pain. He was diagnosed with dengue 2 weeks before, and he received treatment only with some Tylenol. His visual acuity was counting fingers. He has some inflammation in the anterior chamber, 1 plus cells, and also in the anterior vitreous. The labs were within normal limits. This is the right eye, the normal eye, and in the left eye you can see here. You can see this hyperreflective foci in the outer nuclear layer and increased reflectivity of the outer plexiformal layer. And you can see here, there's some changes and disruption in the ellipsoid layer. Here you can see the disruption of the EC layer and the hyperfluorescence and the foci. So he was diagnosed with fovolitis, and he was given prednisone 50 milligrams per day. This is 1 week after. 1 week after, the vision improved to 20/400. This is the OCT 1 week after. The EC was a little bit better than before. 2 weeks after, the vision acuity improved to 20/100, but the patient didn't return after that, so we don't have it. This is the third case. It's a 29-year-old female with blurred vision in both eyes for 2 weeks. She had dengue 1 month before. The visual acuity was 2200 in the right eye, 20/400 in the left eye. She has some foveal changes in both eyes. The last were within normal limits, and this patient received prednisone, oral prednisone. These are the changes. You can see these changes in the right fovea, these white dots, and in the left eye she has some hemorrhage here, a little bit of hemorrhage and a cotton wool spot. This is, you can see here the disruption of the ellipsoid layer and this hyperreflective foci. Here you can see here, and this is the right eye, and also he had some disruption of the capillary plexus, the superficial and deep capillary plexus. And in the left eye, she had this ischemia. You can see here where is the cotton wool spot. She has some ischemia in the superficial layers, and also disruption of the ellipsoid layer and the nerve fiber layer. In this eye, the plexus were within normal limits. She was diagnosed also with fovolitis. And after 2 weeks, the best corrected visual acuity improved to 20/100, and the OCT improves. After 2 weeks, he had 2200, and he had some persistent parafoveal capillary occlusions. That's why the vision just didn't improve too much. And this is the last case. It's a 16-year-old female, 1 week progressive vision loss in both eyes. She had only half movement in both eyes, and 7 days before she had dengue. And this is the pictures. It seemed like purchre, a lot of cotton wool spots in both eyes. The last were within normal limits also. She had some scotoma in both eyes. And you can see here the subretinal fluid in the right eye with these changes in the superficial layers. The same in the left eye. In this patient, we injected subcutaneous beta-metasone both eyes and give prednisone or oral prednisone. And you can see here the vision at the beginning was hand motion. We apply a second subcutaneous 3 weeks before. The vision improved to 20/150 and 250. 8 weeks before, the vision continued to improve, and at 12 weeks, the vision improved to 20/20 in both eyes. These are the pictures 3 months after 20/20 visions. He has some brightness of the fovea, but the vision improves to 20/20. Yeah. So dengue infection is dengue is a fever. It's a mosquito-borne illness caused by an arbovirus with four subtypes. DV1 to DV4 affects millions globally, particularly in tropical and subtropical regions. The vector is a mosquito, the Aedes aegypti, and people had high fever, headaches, joint pain, muscle pain, petechias, mucosal bleeding, and thrombocytopenia. It affects 100 million people per year, and we have 500,000 hospitalized patients per year. and 20 to 25,000 people dead by this disease. It's endemic in America, Asia, Australia, and Africa. And in Peru, last year we have almost 25,000 cases of dengue. About 25% of the patients have some ophthalmic manifestation, but more than 50% have OCT alterations, even when they are asymptomatic. We have to do OCT to detect the disease in the eye. You can see almost 75% have maculopathy and 62% have foveolitis. So this indicates the vulnerability of the macula in dengue. Like it is because of immune-mediated vascular changes that we can only see it with OCT or OCTA. Otherwise, we're going to lose the diagnosis of these patients. 60% of patients have blue eye pain, changes in color vision, central scotomies, and floaters. And these ocular findings can be found from 2 days to 5 months after the dengue is infectious. 30% of these are bilateral, and it can affect both anterior and posterior segment. And we can have keratitis, anterior uveitis, intermediate uveitis, maculopathy, vascular occlusion, PAM, AMN, serous detachment, Purcell-like retinopathy, and optic neuritis. So the OCT and the OCT angiography are essential to diagnose this disease. We can detect the three main patterns of the dengue maculopathy: the diffuse retinal thickness, the cystomacular edema, and the foveolitis. Rarely the acute macular neuropathy is observed, and also the angular signs of Helen's fiber layer hyperreflective. You can see it here. No? You can see these changes in the Henle's layer. And the treatment is mostly resolved spontaneously, but steroids can be used. Especially when they have a loss of vision, a great loss of vision. The prognosis is generally good, but 90% persist scotomas at 3 months and 6% at 1 year. And 83% of patients had good results with visual acuity more than 20/40. That's it. Thank you very much.
Thank you so much. Anyone now wants to ask a question?
Hello. Thank you very much for this lovely presentation. My question is the choice of periocular steroids. Do you think there would be any particular advantage or disadvantage of using intravitreal triamcinolone instead of Subtenon?
No, you can use it intraocular steroids, but you have the complications of intraocular pressure or cataracts in these young patients. So we try not to use steroids. We can use it also probably, but this is usually these patients go well in a few weeks. So I think that also is too much for these cases. Maybe intraocular triamcinolone will be okay, but I would try to avoid the complications of those steroids, intraocular steroids.
That's great, thank you.
Yes. It's over there.
Thank you very much. Let's keep it short, please. We are running over time.
Okay, Dr. Jose Antonio, we are very thankful to you for this very beautiful talk. It has given us insight about the dengue's retinopathy. But my concern, which is I'm not very clear, in definition of dengue, you said there should be a thrombocytopenia. But in these slides, you told that the patient is having 294,000 platelet count. And in another case, similarly, the platelet count was very much normal. In definition of dengue fever, we have thrombocytopenia. Platelet count should be low, 100,000 or less than that. So how would you like to confirm that this was dengue fever in spite of the fact that investigation reports were all negative?
Yeah, because the
Thank
ocular
you.
symptoms are usually several weeks after or month after the dengue infection. So that's why the labs are usually are normal, not because it's several months after the acute infection. Yeah, thank you.
Thank you very much, Dr. Jose. Next in line is Dr. Tamer Mahmood. He's going to speak about epiretinal membrane with and without large macular holes. Thank you.
Thank you very much. Bismillah ar-Rahman ar-Rahim. And I would like to start by thanking my very dear friend Hussein Hakan for the invitation to Pakistan. This is my first visit, and I had a chance to meet so many Pakistani friends and others here, and hopefully it's not going to be the last. I'm looking forward to the great talks today and the discussion and knowing more friends in Pakistan. And I would like to thank very much Dr. Sharif Hashmani for his very kind hospitality and all the nice events that we had so far here. So my talk today is, we're going to have many talks about macular holes, but especially the first one that we will talk about today is about mainly the focus on when you have a large macular hole, but at the same time you have an epiretinal membrane. So when you see those cases of epiretinal membranes and we peel the membrane and then restain, why do we restain? So we can visualize the ILM. Because the concept that we have is that if we peel the ILM, we will be able to get rid of the epiretinal membrane completely. So what we did here is that we peeled the membrane, but I left it connected to the retina, and then I restained with the tissue blue, and I'm using the flex loop to see if there is any underlying ILM, but I didn't see any. And that's the problem when you have those very adherent membranes, you lose the ILM. So now you come and see a very large macular hole, and you're planning to do an ILM flap, but at the same time we underestimate the effect of an epiretinal membrane when we have a large hole. When you look at the retinal surface, you may see an epiretinal membrane, but you don't think it's significant, and you think, oh, this is not going to affect anything and I can do an ILM flap, and you get your surprise when you go in. So here, although this is a very large chronic hole, number one, the hyaloid was still attached, so we're detaching the hyaloid. And then we're planning to stain so we can do the ILM flap. But we get a big surprise that we have extensive negative staining, so we have a very adherent large epiretinal membrane. So instead of peeling it, we're getting to the edge where the ILM is, and we're inverting both the ILM and the epiretinal membrane over the hole. So we are actually using the epiretinal membrane to be able to close that hole. And you see how thick and how stable it is, unlike just an ILM, to be able to keep it and close the hole. Then fluid air exchange, and usually for those long-acting gas, and most of it is closed, there is still a small eccentric opening. But what I really like to do for those cases is do the retracting door or ILM and epiretinal membrane peel and reposition, because it retracts more. So this is an example. You see 50% of the negative staining in the foveal area where the epiretinal membrane is. So I start nasally close to the disc, and I peel both of them as one flap across the fovea. By doing this, we're completely relieving the traction around all the edges of the macular hole, and we go all the way peripherally. You can do the whole thing with the flex loop, but also because of the thicker epiretinal membrane tissue, sometimes it's good to switch between the flex loop and the forceps, and now we relieved all the traction around the hole, and all what we do is we reposition the ILM with the membrane, and you can see how much under the fluid, fluid air exchange it retracted to cover that area. This is another one who's a high myope, has also an extensive epiretinal membrane, and then we stain, we get the edge of the ILM, and then we switch, and with the forceps we can peel it all the way across the hole and then reposition it in place. How does this work? This is a diagram that we described way back when we initially reported this in 2017. When you start at the nasal edge of the disc and you peel all the way and have a temporal hinge and release, that whole flap is going to retract temporally, and it retracts more when you have a combined epiretinal membrane and ILM. While we all know that under the effect of the gas bubble, the retina moves from temporal to nasal, and this is the proof. This is the OCT angiography by Terasaki that showed that on the left with the white is prior to macular hole surgery, and then the red is after the surgery. And when you do the overlap, the retina moves from temporal to nasal, exactly the opposite of the movement of the flap, so it has to close. And this is exactly what you would expect post-op. I want you to look at two things on that graph. Number one, gradually when you close the hole with the epiretinal membrane, the reconstitution of the external limiting membrane and the ellipsoid zone, but also look at the edge. You look at the yellow arrow where the epiretinal membrane was peeled and released. My concern was over long term if it's going to contract and become more symptomatic. But once you peeled it and release it, it stays exactly in the same spot with no long-term recurrence of traction from the membrane. So we had a large series with very large holes, a long follow-up, and we had 5 eyes, 20/40 or better. One hole failed and we adjusted the flap. But more importantly, we learned that there is no long-term tractional effect of the membrane. So this begs a lot of questions now. Similar to fovea-sparing ILM peel for myopic foveoschisis, if you have a myopic epiretinal membrane and you want to avoid a macular hole, you should consider maybe peeling and releasing that membrane. How about regular epiretinal membrane? Should we peel and reposition instead of peeling those membranes outside the eye? This is the picture that I showed you initially, the video. This membrane, I didn't actually peel it. I put it back in place. And look at what happens over time. You see how the retina becomes less thick with gradual resolution of the edema because you remove the traction. And this is after 1 year or more and 20/25 vision. So there is no residual tractional response. Now, this is a case of just an epiretinal membrane without a macular hole. So what I'm doing here is that I start from the ILM to get to the edge of the epiretinal membrane, and then we're peeling gradually that membrane over the fovea. And gradually as we peel and peel, we see that it is actually more extensive, and it's getting beyond the areas of the arcades. But once we try to peel completely that membrane, I'm interested in the ILM. So in the old days, what we would do is that we restain. If there is no ILM, then we're done. If there is ILM, we completely peel the ILM. Here we have much ILM in the eye, but I'm not going to completely peel that ILM. What I'm doing to the ILM now is, even though there is no macular hole, I'm peeling the ILM like a retracting door, so peeling all the way across the fovea, and I will put that ILM even back and reposition that ILM over the hole, and it's nicely resolved the edema, and patients did great. This is a similar one, and you can see at 3 months 20/20 vision. So you are wondering, for large macular holes we can close it, but why do we do it this way? Think with me about the concept here. All of us are used to peeling ILM because if we peel the ILM, we reduce the recurrence of an epiretinal membrane. But when you look at the meta-analysis and all the studies that were done, actually there is a very minimal recurrence of the epiretinal membrane over time. So that statement is not really true. But also what I am saying here is that we're not going to leave the ILM, we're going to peel and reposition that ILM. So if you relieve that traction and you put it back in place, you still have much less reduced recurrence of the epiretinal membrane. The retracting door ILM was the basis of the peel and reposition that was described in other studies before. So the question that you have is, so what's wrong with me just peeling the ILM? instead of doing a flap and reposition, because many of the recent studies showed that if you reposition that ILM, you have less destruction of Mueller cells, you have better microperimetry and sensitivity over the macular area. That's why we would do it this way. So the take-home points, if you have a very large macular hole and a membrane, before you completely peel that membrane, restain. If you have enough ILM tissue, you can use it for a flap, you can peel the membrane. If you don't, use the membrane to close the hole, you're not going to have long-term retraction or contraction of the membrane. If you have a regular membrane with myopia, keep it in place. If you have ILM, peel and reposition that ILM. But a lot of that is also open to discussion. These are new concepts. And thank you.
Thank you very much. I'm sure there will be lots of questions, but please keep your questions very brief and crisp so that.
Hello. Very nice talk, and we have learned some new things. It's sparking, myself sparking. So, my comment is that if you don't have a macular hole with epiretinal membrane, peeling the epiretinal membrane and positioning the ILM is quite good enough. Do you think that even if you have a macular hole with epiretinal membrane, you peel the epiretinal membrane and then positioning a little bit, repositioning the ILM rather than peeling would benefit in the macular hole?
Yeah, that's what I do nowadays, because many of the studies now showing that repositioning the ILM have a much better sensitivity to the macula, better microperimetry.
Yeah.
So ILM peel is more damaging. So even with a small hole or just a regular membrane, if I can now, I peel the membrane, and if I have ILM, then I peel and release. I don't want to leave the ILM in place without peeling it, but once you disrupt that traction, the tangential traction, it doesn't come back long term. But repositioning in the correct orientation, so it's not an inverted flap, it's a repositioning, and it seems like it's exciting to have that with better sensitivity long term. So that's what I do nowadays.
And second concern is that the Korean group, they are just rotating the flap. They are repositioning and little bit rotating with the temporal nick, and then they rotate it. My concerns is, do you find any gliosis under the ILM in these cases, or any tissue penetration or any cells that are not originally originated there under the ILM when you reposition it?
Well, I don't know. So some have looked at the myofibroblast and the epiretinal tissue microscopically, and the concept is because they peel the ILM because some of the remaining cells on the surface can cause that long-term residual contraction. But if you already cut and release that tangential traction, even if you have recurrence of some of those cells, it's not going to be clinically significant. But it seems more logic and more exciting nowadays that keeping the orientation of the ILM and the Mueller cell foot plates and processes is good long term.
Okay, thank you. So, thank you very nice.
Excuse me, I've got two questions, if you don't mind. Dr. Mahmood, thank you very much, first of all, for your wonderful presentation. And I'm Dr. Fahad Khan, one of the ophthalmologists here working in Karachi at Al-Rahim Eye Hospital in retina service.
Can you speak?
Sure. Can you hear me?
Speak louder, please.
Sure. Regarding the ILM plus ERM peeling, I had a concern because some of the vitreoretinal surgeons actually do not peel ILM at all. Actually, they are the proponents of leaving ILM because they think or propose, in fact, that causing an ILM peel would rather cause iatrogenic macular holes rather than, swaying away from the baseline defects. And the second concern is, although you're using probably ICG in your part of the world, but here in Pakistan, we are readily being available for trypan blue, which is less toxic to the retina. So what's your take on that? You peel, it seems that you peel ILM along with ERM in all of your cases, and you're also using ICG, I believe, in all of your cases. So what's your thing? What's your take on that?
Great questions. And then to go to the first question is that before the year 2001, 2002, we didn't have good stains. So all what we would do is that we barve an MVR to get to the edge of the membrane, and we peel the epiretinal membrane without doing anything to the ILM. When we started having those dyes and we see the ILM, some of the studies showed that if you additionally peel the underlying ILM, you will reduce the long-term recurrence. I think that long-term, the number that I give to patients is that a meaningful or a significant recurrence to require another procedure is less than 5% within 5 years. So I think the recurrence is very slow, and definitely there is nothing wrong with just peeling the membrane and not doing anything to the ILM. But we are also finding with the newer technology and microperimetry, then when we peel it and reposition it, it's very similar to not peeling the ILM at all. So there is an advantage here to reducing the traction without long-term side effects. That's for the first one, but definitely we will know more in the future with longer follow-up. The second one, when we had the tissue blue approved by the FDA in the US, many of us switched to use the tissue blue. The problem is that it seems that if you do an ILM peel, it's not going to make a difference, but if you're designing a flap, it seems there is a chemical interaction between the tissue blue and the ILM, so it becomes disrupted and it's not easy to maintain a nice flap, even in my hands. So then I started switching back and forth, and I had much better flap with the ICG. So then the question of the toxicity, the way we dilute it with 4.5 cc's with the BSS plus, we don't have any problem. I don't do it under fluid air exchange, and it's pretty quick, and we didn't have any toxicity from doing it this way. So to be able to maintain or do a flap, I always use ICG now.
Thank you very much. Just one last question, okay.
Okay, it's a comment and a question. Tamer, thank you, great talk. You know, I think another advantage to the trap door, retracting door, rather than the ILM flap, is that with the retracting door, you put the correct surface of the ILM back where it is. This has two advantages. First, it is the right anatomical surface. You're not flipping, you're just putting it back. So the retinal surface of the ILM remains to be the retinal surface rather than the vitreal surface. The second thing is this surface is the unstained surface. So it doesn't have the particles of the stain when you put it back overlying the RPE. And I think this is another advantage of the retracting door. My question, this is the comment, the question is, you know, I just read a recent article that came up in Retina, maybe you're aware of it, that compared ILM peeling to flaps and showed that the visual acuity is actually worse in the flaps. This a little bit disturbed me because we know that the anatomic outcome is better with flaps, but the visual outcome is worse. So what's your take on this? Is it going to affect what you do?
It won't. And I think we have to look at the details of some of those studies, and I had a chance to review some of those. It's a very small group. When you look at the groups and what they are comparing, it's small groups and the follow-up is not that long. So yes, if you have a small group, it may tilt towards one thing, but long-term it's going to be different. So I don't feel this is the case. But we will know more.
Thanks.
Thank you so much. That was a brilliant talk. The next in line is Professor Idris Edi. I request Professor Idris Edi to kindly come to the stage. I will just remind again those who are asking questions to please keep your questions short and crisp. Thank you.
Assalamu alaikum, everybody.
While Idris is playing with his ID thing, I would like to welcome Professor Saeed, the president of OSP Karachi, who is here. Welcome, sir.
Thank you very much. I'm going to talk about the retinectomies and the redetachments. All the vitreoretinal surgeons most of the time deal with it, and we know the primary intent of the retinectomy is to restore the vision to its normal position, retina to normal position for visual improvement. And the commonest indication for the retinectomy in surgical practice, apart from the PVR, is retinal incarceration. And as you can see, there is folding of the retina, and the retina has to be freed from that incarcerated position. This is post-infection. The previous one was the skull buckle procedure complication. The commonest clinical indication for the retinectomies and extensive retinectomies is PVR, the proliferative vitreoretinopathy, and we know this is the non-vascular membrane proliferation on or under the surface of the retina with the associated vitreous changes. This results in the retinal thickening, wrinkling, folds, rolled edges with the fibrosis, and total rigid retinal folds and retinal shortening. So we need to do something in the way of cutting the retina so that all this fibrosis, we get rid of it. Now this is what we published in Saudi Journal of Ophthalmology. This is the single largest personal series of retinectomies reported in the literature. We reported 370 eyes of 337 patients and looked at the outcomes in the complicated cases. And now, a clear message to all those novices is that never cut the retina unless you have relieved the surface retinal fibrosis. These are few of the simple procedures. You will see the difficult cases. You can remove this fibrosis without using the PFCL, but under PFCL, the elevation can cause the problem, and you can redirect your traction forces and remove these membranes under PFCL as well. Some of the fibrous tissues that you see are thick. This is the era of 20 gauge vitrectomies that we used to remove these fibrostic bands. Some of these bands are subretinal, and you got to go subretinal to remove it as the thick fibrous bands that you see. Hemorrhage is the most common complication. This is what you see is the 360-degree retinectomy, and a thick fibrous band had to be removed. Until you do that, retina is not going to flatten. Some of the retinectomies that you see seemingly look easier as compared to the difficult one, and the edges have to be flattened, and we have very good tool nowadays which wasn't present in past, the PFCL, that helps us remove, flatten the retina on the table. But you do come across very difficult cases. This is a 12-year-old only-eyed young boy that I operated at the Civil Hospital, Karachi. Look at the state of the retina and look at the thick fibrous bands, but the tedious effort makes the retina flat and gives the patient navigational vision. This is the fourth surgery of a lady in an eye who had multiple severe sort of PVR. And here in this case also, you see the thick bands that need to be removed from the subretinal space. And this is the post-operative picture giving this patient navigational vision. If you look at the complications, the most notable complication in these kind of cases is the redetachment and that we saw in about 20% of the patients. So 1 in 5 of these patients would need, again, redo in these kind of cases. The changes and the fibrotic changes can be confined to the macula, and that could lead to macular pucker and fibrosis. Unfortunately, some of these patients have unexplained visual loss that is very difficult to explain, and the other problem is the secondary glaucoma. So I'll go into the bleeding, as you saw, was one of the complications that you saw in one of the videos, and that is comparable to what has been reported in the literature. If you look at the baseline data, the important baseline data that might interest us is we use the silicone oil in 82% of these patients and gases in 18% of these patients. And the extent of the retinectomy varied from 90 degree to 180 degree to 360 degree. And most of these cases, majority of these cases were 360 degree retinectomy. As I said, 20% of these patients had the redetachments, and 10% of this patient has macular fibrosis. This corresponds very well with the reported literature. Now, these are the redos that we do in retinectomies. The fibrous tissue, usually under silicone oil, is thicker, but that needs to be completely removed. As you see in these cases of the redetachments in the 180 degree retinectomies that we performed, the thick fibrous bands had to be extending in the previous scar that was produced by the retinectomy. These are the thick macular bands that causing localized retinal detachments, and that has to be dealt with after removal of these thick bands from the posterior pole. Now, it's very difficult to stop, where to stop retinectomy. I usually go up to the vascular arcade, and sometimes in this patient I had to go inside because this patient had 4 surgeries, and the ILM peel and the thick membranic fibrous tissue present on the posterior pole, like in this case, causing retinal detachment after 4 surgeries in the reproliferation, have to be removed. Retina had to be cut in. For additional membranes, the dye was put in, and that is the last desperate attempt that we made to go into the subretinal space for this patient, one-eyed young boy, and had to remove this subretinal fibrosis. Unless you do it, the retina is not going to flatten. Like in this case, the end of the surgery appeared good, and the post-operative period was navigational vision. The correlation studies was significant with the pre-operative vision, statistically significant both for anatomical and the visual outcome, and the extent of the retinectomy for visual outcome. The linear regression for the visual outcome was significant for previous surgeries, VA pre-op, extent of the retinectomy, but was not significant whether we use the silicone oil or gas in these cases. The binary regression for the anatomical outcome was significant for past vitreoretinal surgery, the post-operative visual acuity in this patient. The potential benefits of the silicone oil outweighs recognized disadvantages, and we used in 82% of these patients silicone oil and gas in 80% of the patients. In our analysis, gas or silicone oil no influence on outcome. The anatomical outcome was 84% first surgery and repeat surgeries. Final visual outcome, anatomical outcome was 92%, and we failed to attach the retina in 8% of these patients. Now this is the reported literature, and it corresponds with our results. 52% to 98% success rate has been reported anatomically in these kind of complicated patients. There is increasing trends toward the not using the scleral explants in these kind of complicated cases once you cut the retina. The explants were not used in our series in 76% of the patients. The visual outcome that has been reported in literature varies from 10% to 51%, 2200, that's 660. In our series, 660 visual acuity or better was seen in 57% of the patient. There was a significant statistical difference between the pre-op visual acuity and the post-op visual acuity. So in conclusion, the results are comparable in our series to what has been reported in Quorum, and their hypothesis was that the radical anterior base dissection eliminates the anterior PVR, and more than 90% of the anatomic success rate is attributed to this technique. The other important points are that we are getting good results, even in desperate cases, is the improvements in the techniques that we see in instrumentation, the availability of the wide-angle system, the base, vitreous base dissection techniques with the scleral indentation, the removal of the anterior flap that contributes to the success rate, and is a great operative tool that we have in the form of PFCL that we manipulate the retina whichever we want, and advanced vitrectomy machine. So in conclusion, retinectomies and the surgeries for reproliferations have better and comparable outcomes with presently available modalities of the techniques than what we had in past. Thank you.
Thank you very much, Idris. And we are open for just 2 short questions, please. Anyone would like to question? Okay, thank you so much. Next speaker is Dr. Hussain Khakan. He is going to speak to you about the giant retinal tears, and he's going to tell us how to treat them wisely.
So, good morning, ladies and gentlemen, and I'm highly thankful to Professor Sharif Hashmani and Hashmani Groups of Hospitals for kind invitation and arranging such an event. And moreover, I am thankful to our foreign guest speakers, Walid, Nico, Tamir, and Jose for joining us here. I know it's very difficult to participate in the meetings in the Pakistan, but I am highly thankful for gracing the occasion for us, and I am very thankful for the participants to joining us on this weekend. Can I have my presentation, please? So I will be talking about the joint retinal tear, and I would like not to let you sleep or play on your mobile phone. I hope I will be succeeded in this. So before I start, they are taking some time. So how frequently we get the joint retinal tear in Baltimore? How in the week you get Tamir? In 1 week, how many? In 1 month? It depends. Okay, and Walid, how you get frequently? 1 in month. And Jose? 1 in 3-4 months. So, and Nico. Can they have a microphone, please?
Yeah. So we see more often because we have lots of inherited retinal disease, including Stickler syndrome, Knobloch syndrome, and these are at a higher risk in our population. So I would say 1 a month at least.
So I'm asking because all of you people are from different continents of the world, and you are treating the different races, North Africa, America, South America, and the Middle East. So I was just looking how much cases you get for this disease. And we are still buying a little bit time. So if anyone has any question regarding the previous talk, so he can ask or she can ask. And if you want to ask any question before my speech, I am also ready.
You know, maybe
so they are getting a bit time. So can I have a mic, laptop if you want?
If we have time, maybe I can ask a question to Dr. Idris regarding Dr. Idris. So I noticed that a good proportion of patients who received retinectomies also received a scleral buckle. So was the decision made before or after doing the retinectomy, and what do you think the role of the scleral buckle is in these cases if you're cutting the retina? And the next is, did you look at heavy silicone oil versus regular silicone oil? Because I'm sure most of these were inferior PVR cases. Do you think it makes any difference?
Very good questions. First of all, the scleral explants. In the initial part of the series doing vitrectomies, thank you very much. Very nice question. In the initial part of the series, when we started retinectomies, our trend was to use explant in all the cases. But as we went ahead with the retinectomies, we realized that putting an explant in already cut retina would not make much sense, would not release, would not give any added advantage, because we were removing all the anterior flap and the vitreous base as we advanced with the surgery. So we gave up using, and I seldom use explants for retinectomies nowadays. And your second question, the heavy oil. Unfortunately, I'd seen more complications with the heavy oil as compared to the plain silicone oil. So my tendency was not to use it. When it started being available in Pakistan, before using it, somebody else used it, and I started seeing complications, especially the inflammatory response and the problem in removal of the heavy silicone as compared to the normal silicone. So my tendency has never been to use the heavy silicone oil. And if you look into the literature, there is not much difference between the results of using the normal silicone oil in these kind of desperate cases versus the heavy silicone oil. So my tendency is not to use it.
Any more questions? No, so we will start with our presentation. I am presenting the giant retinal tears, and I hope I will try to convey some message how to treat the giant retinal tear. So I will show the different stages and different types of giant retinal tear. Here you can see the giant retinal tear is 180 degree and folded over the retina. Can we switch off these lights a little bit so we can have a clear view? So for me, the giant retinal tear, when it is less than 360 degree, it is quite easy to manage it. Rather than, it's far easier to treat with a basic rheumatologist retinal detachment, because everything is under control and nothing is going. So here you can see I'm just doing the core vitrectomy over the flap of giant retinal tear here. So after doing the core vitrectomy, I will try to cut the anterior flaps of giant retinal tear. This patient was relatively young, so vitreous was not such much liquefied, and there was a posterior vitreous detachment was already there. Now you can see the very interesting part. This is a part of atrophic retina, and there is a lattice degeneration. Can I have a pointer, please? So this is the very interesting. If you leave this part, you are not going to get rid of this traction. So I am just trimming this part apart from the giant retinal tear. This is atrophic retina, and you see without even cautery or anything, there is no bleeding. So no meaning of leaving this atrophic or ischemic retina over there. So here you can see I am just trimming the anterior part of giant retinal tear, mean anterior flap. Because if you don't trim the anterior part of giant retinal tear, later on the eye may go in the phthisis and may have later PVR complications. So always I do the trimming of the anterior part of giant retinal tear, and that's the wise to do this one. Then as routinely, it's very simple to do the perfluorocarbon liquid over the macular area, and you see how nicely it's unfolding. But it's not always unless you don't get rid of all tractions, and all tractions doesn't mean that there's a PVR. The traction from the original retina at the 9 or 12 o'clock may have a much role. So you closely should follow the flap, how it goes unroll. So here I do unfolding of the margins of giant. Here you see even the filling with the PFCL, I cannot unroll the margins of giant retinal tear. So I am just ironing it. I name it ironing of the margins of the retina. So here I am just ironing it with the cutter, with the back flush extrusion soft tip, and whatever you name. So the ironing I'm doing, I know this is an ischemic retina and it wouldn't give any benefit. Even I unroll it. I can easily do the retinectomy of this area. But the logic here is that if I unroll this retina, I have a good enough healthy retina, and I will only lase this ischemic retina. So I will, if I do the retinectomy, I will have a less retina at the end. So here you see, I have just done the laser over the ischemic part that I have unfolded. So I have saved a bit of the retina that is healthy. So it's by the principle that the end you have to do the PFCL oil exchange. It's never been done that PFCL air oil exchange. So we do direct perfluorocarbon liquid oil exchange, and why it prevents the slippage of the retina first of all, and second, apart from the slippage, So apart from the slippage, you get an extra benefit that there's no migration of air, or else in these cases when you have direct perfluorocarbon liquid and giant retinal tear. So there is another case with 180-degree giant retinal tear, and he has a perception of light. Don't worry about in these cases about the vision. Even I have got the patient who have just perception of light, even projections was faulty, but after the surgery they got very good vision. So giant retinal tear has a totally different phenomena. So here you can see the giant retinal tear is with little bit of PVR. It's folded over the other part, and here I am doing the vitrectomy. You can see this is the bare choroidal area where I'm doing the vitrectomy. So it's easy, nothing is coming in cutter, everything is under control, and I feel it's one of the easiest surgery for the retinal surgeon to deal the giant retinal tear. So here you can see that giant I'm not touching this area. I'm not treating the folded area. I'm just treating the area with the cutter that is bare choroid. So I'm cutting it, and here you can see easily that I'm cutting the anterior flap of giant retinal tear. That is mandatory in all giant retinal tear surgeries. After doing my surgery and core vitrectomy and dealing with the flap, I am coming to the now tear area. Tear area, you can see here, it is folded. And in this tear area, I see a lot of ischemia at the edge. You see it's pale, it's folded, it's bubbly, it's corrugated. So not much life in this area. It was easy that to just go and do the retinectomy in this area and get rid of it, and you save the time. But I don't do this
in from the past few years. I even save all the ischemic retina for my laser. So here I am putting the perfluorocarbon liquid. Here you can see the retina doesn't have a very good health. But at the end you will see that we were succeeded to deal it very wisely and very nicely. So here I am injecting the perfluorocarbon liquid. So the only issue here is that the perfluorocarbon liquid may go subretinal if the retina is taut. So you should be very much concerned the retina shouldn't have the shortening. If you put the perfluorocarbon liquid in the shortened retina, the perfluorocarbon will go under the retina, and when it goes under retina, you have to repeat all the cycle once again. So it's wise to first deal with the shortening. All the shortening can be dealt with the peeling or extending the retinectomy and axillary incision. So here you can see I'm just flattening this ischemic retina at the edge and the margin with the same. But in this case here you see even I have flattened, but I am not happy at the end of the surgery, because this retina is flattened under the perfluorocarbon liquid. It will not stay flattened under the oil. So here you see. So here I am doing the relaxing retinectomy at the periphery. So I am extending the retinectomy. Joint retinal tear was from 3 to 9. I am extending it to the 11 to 1 o'clock. And now you see the area over here and here that was lifted even under the perfluorocarbon will settle down easily. So don't try to be hurried. Don't believe on perfluorocarbon liquid only. Believe on your sixth sense. When some things are flattened under the perfluorocarbon liquid, they wouldn't stay flattened for the long time. So just look for the shortening of the retina. If you are looking for the shortening of the retina, even under the perfluorocarbon liquid, your retinas will stay attached. Here you see now the retina is attached and it's nicely spreaded over. And then you can do laser on the giant retinal tear area, and then we do the perfluorocarbon liquid direct silicone oil exchange. I use 5,000 centistoke silicone oil, but it's the preference of anyone because I don't in rush of removing the silicone oil in these cases. So at the end of the surgery, you see we have ample good retina, and our giant retinal tear is more than 180 degree at the end, but it's quite nicely flattened. So this is just basic step of how we remove the perfluorocarbon liquid and how we do it exchange with the silicone oil. There's one more case I will try to share. These are the preoperative image or peroperative, whatever you say. So here the retina is folded again over. So this is little bit larger than 180 degree, but retina is healthy. This is bare choroid you see. The only issue that I have discussed before, the one retina flattened just with the perfluorocarbon, I didn't need any retinectomy. Second one, I need the retinectomy. Here the retina is fresh. And the same principle, I am doing the core vitrectomy and vitrectomy over the area of bare choroid. So after completing this area with the vitreous and dealing all the vitreous over the bare choroid and over the retinal area, you can see vitreous doesn't have a much strength. It is not much denser, so it was quite easy to deal with this vitreous. Usually I don't know what's the opinion of my seniors and colleagues and friends, but I don't find any issue with the vitreous in adult patient with the giant retinal tear. Obviously in pediatric case it's very difficult, but I don't find any issue with the PVD or else in giant retinal tears most of the time. So here I have completed my vitrectomy. I am injecting the triamcinolone to stain the posterior highlight. Usually I don't get any posterior highlight in these cases. And now I am just injecting the perfluorocarbon liquid to flatten the retina when I am sure that there is no vitreous and there is no schisis of vitreous that may end up in the posterior plate of posterior highlight. So at the end of the surgery, you can see it's a large giant retinal tear, and under the perfluorocarbon liquid, here the retina is flat, and then we did the direct perfluorocarbon liquid silicone oil exchange. So till I have shown you the different varieties of giant retinal tear. If we will have time, I can show you more. I have hundreds of them. So I would love to have the questions if you like. So I have all sorts of giant retinal tear like this beautiful one. This is my favorite one because I didn't do the retinectomy even in this. So I end my talk at this point, and if you have any question, I am here for you people. This is my YouTube channel. You can find any of these giant retinal tear on my YouTube channel. Thank you.
Thank you very much, Dr. Hossain Khakan. That was an excellent presentation, and I'm sure they would all have understood. You want to ask a question?
Yeah, just had two simple questions. One, is there a preference for which silicone oil that you use in GRT cases? And number two, you said that you don't hurry in taking out the oil. So how long do you leave the oil inside the eye?
It depends on the age and extent of PVR, extent of giant retinal tear. If it's no PVR like PVR A or B and it's an adult patient pseudophakic eye, I will keep for 4 months and then I will remove. And I usually take 5,000 centi-stroke silicone oil. I don't want to be in debate of why not 1,000. Okay, you get 1,000. If it gets emulsified a week before, then what? Why not 5,000? There's no harm of using 5,000. Emulsification is less, and even the viscosity and surface tension is better in 5,000 centi-stroke. So for joint retinal tear, by law, I use 5,000 centi-stroke silicone. For pediatrics age, there is a question that whether I do encircling buccal. From the last 10 years, I stopped doing the encircling buccal in giant retinal tear. I do only in pediatric age when I have a joint retinal tear less than 180 degree. More than 180 degree, no encircling buccal. I just do the vitrectomy and put the silicone oil with the 5,000 centi-stroke and the same maneuvers. The only thing is I don't like to sacrifice the crystalline lens in pediatric age, and I hate to do the base shape in terms of sacrificing the crystalline lens, because it gives hell of inflammation, and the end the eye doesn't behave in next 3 months and you are losing the eye or you losing the sight. That's my point.
Thank you.
Can I ask you a quick question?
Yeah, sure.
You did very well keeping us awake, by the way. Very nice talk.
I tried to
Yes.
keep you awake. Talk you can see on my YouTube channel.
Thank you. Just a quick question.
Yeah.
I know you mentioned about this slippage. Have you ever left PFCL in the eye instead of doing the PFCL oil exchange?
In giant retinal tears? Never.
Never.
Never in my life. I hate keeping. I left only once in PFCL in my life that I have shown the yesterday, with the suprachoroidal hemorrhage, detachment, and any complication that you can expect in the eye that happened in that case. And perfluorocarbon was left there for 2 weeks. For joint retinal tear, big no. If you are keeping the perfluorocarbon inside a liquid in the eye, in the joint retinal tear, and you think you have done right, no, wrong. It means you are not sure you have relieved all the traction. Your retina is not taut. So it means you have sixth sense that there is something bad that will lift the retina. If something is going to lift the retina, your PFCL not going to save you. So I don't keep the PFCL never. Yes, Tamir. You can keep the cat. Yes.
There are some situations where for superior giant retinal breaks, you can consider a gas bubble.
Yeah.
I mean, this is great what you presented, but what's your experience with that?
If you go to the defined joint retinal tear that I have shown like this one, if I get in the superior 5 or 6 clock hours, C3F8 is perfect. The only issue is when you are putting the PFCL gas exchange or PFCL air gas exchange, you cannot dry the lips of giant retinal tear. Because if the lips are wet and there is a fluid, there will be slippage. When the tear is small, less slippage, and you can easily dry the lips. For me, drying the retina is the only key to success in giant retinal tear. If your retina, why I use PFCL? I can do, believe me, 50% of these giant retinal tear under air. But under air, we cannot dry the retina as the PFCL gets away the fluid. I don't want any fluid under the retina. So when PFCL I'm using, I just want to keep the retina very dry. So this has been the slippage. For the superior I do see 3F8, not SF6. I don't want to take the risk.
This is exactly why I was asking, but I'm glad that you stressed on drying the edge of the, this is the key.
Yeah, that's
step.
the point.
Or you can avoid using PFCL and use a striker bed and go upside down.
I would prefer the death roll for the patient. I told you the story. In UK, they got the death roll, legs up and face down for 12 hours. The next day came with some macular hemorrhage. So thank you so much for having me.
Hakan, I have a question for you, if you don't mind, please. Rahman here. Just carrying on from what Dr. Amjad has asked, my experience in some patients where there is slippage of, in cases of GRT, is if you have tried once and if you have tried again and the retina is still causing slippage, I tend to leave PFCL for 2 weeks. And I've seen some excellent results because, the slippage is the disaster in GRT cases. So whatever it takes to avoid, slippage, if you can leave PFCL, it doesn't cause much inflammation.
But my question is why your retina is having slippage?
Just a
Why?
bad day.
PFCL is doing nothing. It means your retina is slipping because you are not able to dry it perioperatively. If you will keep it drying perioperatively 100%, it will never slip. You are keeping, what the PFCL does for 2 weeks is just keep the retina dry, just keep the fluid away. That you can achieve perioperatively if you spend 10 minutes more or 5 minutes more. Because doing the same surgery, for me, keeping the PFCL, no issue, okay? But doing the second surgery in a very inflamed eye with the giant retinal tear and removing the PFCL, putting and more inflammatory fluid, that is silicone oil, it creates more inflammation.
So after 2 weeks, replace PFCL with just a gas bubble. You don't put a silicone oil in there.
No, that's more wise. That's the more wise you can do. But if you have a limited clock hours giant retinal tear, but the main is that what you are achieving for keeping the PFCL in the eye, you can achieve perioperatively. If your sixth sense says that my PFCL is going to attack this retina, it's totally wrong. Nothing can keep attack the retina unless it's not attacked by itself. Thank you.
Thank you very much, Dr. Hakan. And next in line is Dr. Tamer. Dr. Tamer Mahmood is going to talk about autologous retinal transplant for macular hose surgery.
We're just going to take a second to connect. I didn't know that I was next. Okay, great. So, it's been about 10 years since we did the first autologous retinal transplant, and this is the first case that I did. And that day, I wasn't planning to do an autologous transplant. We didn't have any procedures except ILM peel and ILM flap and maybe getting peripheral ILM. And this is the first patient that I had. She was a high myope, had multiple high myopic retinal detachment before. And then she came because she keeps getting those detachment and subretinal fluid from that large hole. And the only option that I had is try to get peripheral ILM because she had all the ILM peel through the staphyloma. And I couldn't. And all what I could do is that the retina was very thin, so I said, I'm going to get just peripheral retina because it's very thin, because all my objective here is to close the hole to prevent a recurrent detachment, and this is what we did. But what was very exciting is that the follow-up, gradually that peripheral retina started thickening and developed some outer retinal layers, and with co-localization with multifocal ERG and microperimetry, as the vision started slowly improving, we started noticing increased sensitivity over the area of the graft. And the vision improved to 20/80, and we published that as the first case of ART. So what really happened since then, we made the procedure very simple and very easy. So usually I use the flex loop to get an idea of the size of the hole, and I get usually a superior graft because we're creating a retinal break, so we want to make sure that we don't get a detachment or a PVR. I do everything under PFO so it's stable, so we don't lose the orientation of the retinal graft. Do a few spots of diathermy. Nowadays, I do the laser at the end, and usually better even than the forceps, I use the flex loop under the PFO to slowly move the graft to the area of the macular hole and leave it in place, leave the PFO in the eye for 2 weeks, and then take it out, so you will never lose the orientation of the flap. Since then, multiple groups around the world have used different techniques using autologous blood and so on to try to keep the graft in place. And then Kazuaki Kadonosono and I started looking with more experience at primary very large and atypical macular hole, and we even got more and better vision with those with better microperimetry in primary large atypical macular holes. Then we did our initial surgeon study, me and Steve Charles, and then and Kazuaki, and then we moved to the global experience. Since many were doing it, we said we need to learn more about this new procedure, learn about the complication, learn about the global experience, because every one of us does it a little bit different. And we were able in that first global study to get 33 surgeons with 130 patients. There were cases of primary macular holes, 27%, refractory with multiple procedures in 58%, and 15% were the very complex macular hole retinal detachment. As you might expect, those were very large holes in their minimum linear diameter. And we were excited that with that initial global experience, 89% closed and 95% of the macular hole retinal detachment, we learned some new morphological changes. As that retinal graft heals, there is a better correlation with vision if you have recovery of the ellipsoid zone. And we learned something new, that with those grafts, you can see initially the vertical line on OCT between the graft and the host macula, and gradually there is alignment of the neurosensory layer with disappearance of the vertical lines with plexiform to plexiform and nuclear to nuclear, and those were correlated with better vision. It was very exciting to see that in that initial experience, 43% in those tough holes gained 3 lines of vision, 29% more than 5 lines of vision, and there was a group with 15 cases, 12%, 20, 50 or better vision. So we can achieve macular function from peripheral retina in some of those cases. So what happened to that first case now 9 and 10 years out? So this is a high myopic patient. So as you expect for those patients, there will be gradual progression of the atrophy in the posterior pole. But when you look at the scans of that lady, at about 10 months to 1 year in those transplant, in 50%, you see some inner vacuolation of the inner retina, but you don't need to treat this as CME. Gradually, that will fade away by year 4 or 5. And we were very excited initially to publish when she got 20/80 vision. Now, 9 and 10 years out, she's 20/50 in this eye. And this is her other eye, myopic foveus cases. She started developing subretinal fluid, and she doesn't want any surgery in that eye yet. Now, I'm going to show you some long-term follow-up of some of my patients. This is a lady that had a failed ILM peel, 793 minimum linear diameter, 20/40 vision, inner retinal vacuolation, and you see the ellipsoid zone. And then 2.5 years, you see some gradual resolution of that inner retinal modulation. Still vision is 20/40. She came, and this is her fellow eye. She had a chronic macular hole. So I went in and I did an ILM flap, but it failed because of the chronic. So I went in and I did an ART, and 12 months, 20/70. So one eye 20/40, the other eye is 20/70, and that's my first ever bilateral ART in those holes. This is another lady that myopic and had a very large macular hole, more than 1,000 microns after an ILM peel. 2 years out to 20/25 vision with alignment of the neurosensory layer and a foveal depression. This is another one with failed ILM peel, 3.5 years now, 20/25 vision, alignment of the neurosensory layer, ellipsoid zone, and a foveal depression. Humayun Tabande showed that there is partial revascularization by OCT angiography in some of those cases with large macular holes. Kazuaki did a study on his series, and he found that the vascularization by OCT angiography is about 35% in his series. he also looked at the long-term outcome for those cases, and in his series was 100% closure. There was significant improvement in vision, especially more than 50% of those that had recovery of the ellipsoid zone. John Thompson and I, a few years back, looked at the problem of those large macular holes. And the challenging is, what procedures can we do for those atypical and large holes? And this begs the question of, what is a large macular hole? Some of the studies, the large studies showed that the threshold is 500 microns. When you go beyond that in a non-myopic hole, this is the challenging. What to do for those cases? So if you look at the OCT-based classification of macular hole, it doesn't address that problem because it only goes to above 400. So a group of us led by Flavio Rezendi, we looked at amending the OCT-based classification, and according to the size and the results of some of those newer techniques, we added large, X-large, XX-large, and a giant macular hole, depending on the size. And we really learned a lot by looking at the results of those new surgical techniques. So if you are up to 500, 550, an ILM peel can work. Above that, we recommend an ILM flap up to 700 to 750. But above that, the success rate is significantly low, and you have to consider other procedures. What we looked at was macular hydrodissection, amniotic membrane, and the ART. And if you look at the results here, the amniotic membrane anatomical closure was 100%. It was 90% in the ART, and it was only 83% with macular hydrodissection. However, the only group that has significant improvement in vision was the ART. So there are so many hypotheses behind ART. There is no time to go through any of those, but it's probably a mix of many of those hypotheses. Recently, last year, we also introduced the concept in high myopic large macular hole with atrophy to reconstruct the macula, and then we did a combined ART with amniotic to work as a substitute or a substrate to the RPE, and then adding the ART on top, and we had some initial good results with those. Then we went for other macular holes in the second global study because we didn't have much information about macular telangiectasis and macular hole, so we thought a global study can help, and we were able to get 30 surgeons with 63 cases, and we learned that a primary ILM flap, although those are small, is the best way to succeed in those holes. 90% closure versus only 47% for appeal, although the group with flaps were much larger to start with, and if it doesn't work, then ART would be the next option. When we look at macular holes, we're lucky to have OCT, and we have to measure. We cannot just look at a hole and say, this is the procedure that I will do, because it's based on the scaling of the OCT. But we also learned that the measurements that we have might be wrong in high myopic patients, and this is the editorial that we wrote a few years back. So if you have a large macular hole or any myopic macular hole, you have to get the axial lens, divide by 24. Why 24? Because this is the standard that is set up in all the OCT machines, and then multiply by the measured side. This is an example for the table to your left about how the size of the hole changes by axial lens. And it is a linear relationship. And the larger the hole, the more we underestimate the size of the hole. So let's go back to the classification that I said, and you look at the size of the hole, and we apply this to the graph to your right. This is why historically it was very difficult to close those myopic holes, because we underestimate the size of the hole. And here, if you don't adjust for the size, you will be doing a different procedure that may not be successful. So you really need to go through that process. Now we are in the third global study specifically about macular hole, adjusting for the size, getting the axial lens. The study is closed. We have 57 global studies, over 500 cases of myopic holes, and the analysis is underway, and hopefully we're going to report this soon with secondary outcome about atrophy, also CNV, and the staphyloma. We're starting the fourth global study about macular holes for inherited retinal diseases, Alport, and so on. So I'm going to contact you soon. So if you have any of those cases, because it's very difficult to come across, treated by any technique, get in touch with me so I can add you to that fourth global study. Thank you.
Yes, Dr. Misbah, can I
Yes.
ask one question?
Please.
Right, yeah, Dr. Tamer, it's very nice talk, new innovations, and definitely new methods of treating these retinal diseases are there, now it's coming up. Just my one very innocent question, because we are doing a retinal surgery for so many years. Our hospital is a tertiary hospital, so we see a lot of post-op cases. So in real life picture, the improvement of visions are not that much high, because the retinal health and the optic nerve health also matters in giving them a good visions. My second question coming about the macular hole is, whatever OCT images you have shown, there is ellipsoid zones are missing. So the central vision is from the ellipsoid zone. Your acuity, your color vision, your sharp, whatever it comes from the ellipsoid zone. You have filled the hole with all sorts of tissues. But if you don't have an ellipsoid zone in the center, how can we claim, not you, we can claim that we have achieved this much vision, central vision. I'm talking about the central vision, not the periphery. Periphery, they have good peripheral vision. Please, thank you.
For the first thing about the procedures that we do, when we started this was an area of unmet needs. So my PhD was neurobiology. If someone would come to me and say, why don't you consider getting peripheral retina, I would say it doesn't make sense. But because we did it this way to close the hole, and then in hindsight we looked at the morphological changes in the retina and how it did, then we went back and talking to some of the neurobiologists when I was at Duke and so on, they said, this is what we call adaptive biology. So yes, there is no regeneration, but there are so many hypotheses, including when we get, for example, trauma. The peripheral Mueller cells get excited and they can change to precursors or stem cells for photoreceptors. The ectopic synaptogenesis hypothesis, the glucose hypothesis. So there are many hypotheses before this for the last 20 years that can explain some of the findings we see. We can't predict who's going to get better ellipsoid zone, who's going to get better alignment of the neurosensory layers. This is a process that we have been learning for the last 10 years. But what we also learned is, and what I did initially, I said, why can't we be more conservative? So ILM peel doesn't work, consider getting a peripheral flap, consider doing something, and this would be the last procedure. But we learned that this is not correct now, because in our experience, we have many large, for example, myopic macular holes, and say, don't start with just an ILM peel, or if you are in that size range, and this is what I did with Kazuaki, is if you have that large myopic hole and you know that ILM peel is not going to work, you know ILM flap is too large for that flap, don't waste time and months and go for a failed procedures, because every 1 to 2 months we lose 3 to 4 ETDRS letters as we wait for those holes. So when you come and give a 10-year-old chronic macular hole and everything is lost, it's going to be just anatomical closure of the hole. You're not going to get functional improvement. So what we are learning here is, in an algorithmic way, every hole is different, the pathology is different. Is it an idiopathic or MACTEL? That's why we're going with the global study with the different types of holes, to know how to approach each one of those holes by pathology and by size. What would be the primary procedure? What would be, if it fails, you go to the second procedure? So hopefully we can get better outcomes.
Thank you very much. And next we have Dr. Waleed here, and he's going to talk about my way to clean the cavity from silicone oil.
Hello again. Before I start, I will thank my dear friend for the invitation, Hussein, and the kind hospitality from our host. So now I will presenting my way to clean cavity from silicone oil. As we are VR surgeon, using silicone oil is for kind of difficult situation or worst situation with retinal detachment. But the big problem with the silicone oil is the side effects that occur when even after silicone removal. So if we assimilate the eyeball to the dish, and as a good husband, I wash the dish daily. So I share with you how this is a bowl, this similar to eyeball, this oil, movement eye. Now we remove the silicone and we do triple air exchange. And as you can see, droplets remain even after 3 air exchange. So now we use the soap to clean our dish, and 1 air exchange after soap, we have no droplets. So what I do is this kind of product, washout, called washout. Why I use washout? It's approved by our Minister of Health and the European Union. It eliminates even the smallest oil residues in the cavity, clean intraocular lens and retinal surface, and dissolve silicone oil. So, what is the washout? It's a biocompatible solvent. It's dissolved oil. It's amphiphilic properties. It allows effective interaction with both hydrophobic and hydrophilic surface. Highly safe profile for the eye. Its density, it's higher than the water, so there is a surface between the washout and when I inject washout in the cavity, so there is a surface, it's clear, and its viscosity is similar to the water. So as you can see here, the first picture before washout, after removing silicone oil, then after washout, as you can see the clarity of the interior chamber. Here, before washout in the cavity, without washout, and after washout use. So we expose shorts, and it's safe for endothelium cells, density and morphology. It improves visual outcome, reduce complication, and I share with you the videos. So it's a 27 gauge. We place the terminal infusion, and then we place the other cannula, transclear cannula, and then we clean the interior chamber for the emulsified silicone with BSS, and then we pass to the cavity. So we do liquid air exchange. As you can see, the lot of droplets and emulsified silicone. It's a high myope case. After the end of the exchange, we will add the washout in the cavity. Here, passively we absorb, eliminate the liquid. in front of the optic nerve. Then I pass to the anterior chamber to add and clean the capsular, and I add the washout in the anterior chamber, and then I put the washout in the posterior, and it remains 5 minutes. We take it, we add, we fill all the cavity with the washout, and then we left it 5 minutes, and then we clear the anterior segment. Here we aspirate the bubble of washout, and then we aspirate the bubble of washout in the posterior chamber. As we can see at the end of the procedure, the cavity is clean, anterior chamber is clean, and also I will take a look about the posterior chamber. It's very clear without droplets. So at the end, we did 580 patients with this product, and we try to change the quality of life of our patients. So they are 80% of our patients are satisfied, and without floaters at the end of the surgery. Thank you. Yes, yes.
Thank you. Thank you very much, Waleed. Finishing in time. That was an excellent lecture. And before I call the next speaker, I would like to welcome Dr. Akhtar Jamal. He is one of the pioneers of recent ophthalmology in Pakistan. I welcome you here, sir. Next is Dr. Ghazi. Sorry. Okay, hold on, sir. I'm sorry. Just wait. I'll call you a little bit later, okay, Ghazi? I'm sorry about that. Professor Idris Edi, please.
Yeah, इसको join कर दे, please. Bismillah ar-Rahman ar-Rahim. I'm going to talk about a very practical issue, and that is the head-down positioning after silicone oil injection. I have not been practicing this practice since 2009 and done hundreds of these patients without posturing them head down. I always posture them head up. And I try and convince the audience today why I do it. Now I'm trying to get rid of the myth of the face down position after silicone oil injection and start thinking about face up position. And this is the way we actually inject the silicone oil, and this is a direct exchange that we do. This is the exchange with the air, and this position, patient is lying flat on his back. The patient is lying face up position while we do the procedure in the operating room. We flatten the retina by relieving all the surface traction and remove all the membranes. We do complete drainage of the SRF and seal all the breaks that we find with the lasers, and silicone oil fills the cavity, maintaining the retina attached on the table. And retina seldom redetach on the table intraoperatively unless it is firm and is stiff. We have to do something to flatten it. And it looks strange to ask the patient to change his post-operative procedure, posture, from a secure supine position face up to the uncomfortable prone face down position post-operatively. Zivanovic, if you are aware, all the seniors would know him, but for the juniors, Zivanovic was a pioneer in silicone oil use. He's written a book on it, and just to tell you the importance of this great man, the two great names here in the present surgical retina world are Eckert and Carl Claes, and both of them were trained by Zivanovic. Now he says no special positioning is needed in post-operative period after silicone oil injection with normal I stress, normal intraocular pressure at the end of the surgery. And if you look at the textbooks, 10 millimeter or so is actually the aim pressure at the end of the procedure. But in practice, what we do? I've been talking about this positioning in several meetings, but I thought I must document it in literature. So what we did was, we carried out, first of all, the pattern of the positioning of these patients in surgical practice in Saudi Arabia and in Pakistan. So we conducted a survey. And the survey was responded by 71 practicing vitreoretinal surgeons from both the countries. And the results are very interesting. The question was, what was your tamponade of choice in advanced PVR? Tamponade of choice was silicone oil. Now, we were just talking about the use of the PSCL. Rehman Siddiqui did ask a question, relevant question. And there are about 3% of the patients who use PFCL as tamponade of choice in these kind of situations. So 75% of the patients use silicone oil. This is the practice that we do in these two countries. We follow the Europeans as against the USA practitioners who use the gases most of the time. The second question, do you put this patient in face down positions? The response was 79% of these patients, these doctors, asked the patient to put the face down in post-operative period, but there was a significant number of 13% who do not ask the patient to put their face down. Which patients need the face down positions? All the patients. All the patients, we inject the silicone oil in vitreoretinal surgery need to be in the face down position. That was the response by 63% of the retinal surgeons. Now this is interesting, and this point is very, very disturbing. We asked the patient to put the face down for 6 to 10 days after the surgery, and 50%, more than 50% of the vitreoretinal surgeons do this practice. Some less, some more. But look at the other responses. 15 days, 14 days, 15 to 20 days, 2 weeks, 21 days, 2 to 3 weeks, and 3 weeks. Now, this is the pattern of the practice in these two countries, according to the survey published in Saudi Journal of Ophthalmology. There is no, I mean, it's everybody's choice. Any surgeon would like to say 5 days, 3 weeks, 2 weeks, 3 weeks, 4 weeks, not 4 weeks, 21 days at the maximum. Okay, don't sleep flat on your back. Yes, your head should be down. And why do they do that? So I asked my colleagues, locally as well as internationally. And the fear was that the oil would come into the anterior chamber and will cause macular problems or could cause glaucoma and associated corneal problems. This is the macular fold that you see on side. They try to avoid it by letting the patient down. Now this is the silicone oil in the anterior chamber. It can occur during the surgery. It can occur late migration of the silicone oil in the anterior chamber, and this is commonly due to the recurrent redetachment or hypotony. In fact, the lens, pseudophakic lens or the natural lens is a barrier, and unless we have the zonular problems and the problem in the posterior capsule, the oil doesn't migrate in the anterior chamber. The problem associated, the apprehension is glaucoma, and there are different types of glaucoma. Chronic open angle, secondary open angle glaucoma, secondary angle closure glaucoma, pupil block glaucoma that causes shallowness of the anterior chamber. This is easy said than done. The patients is, for patients it's an ordeal. It's not very easy to go face down, especially for the mentally impaired patient, children, elderly, neck problem, back problem, cardiac patients, patients with breathing issues, and obese patients. The documented in literature, there are problems, ulnar palsies, pulmonary embolism, thrombophlebitis in head-down position. The compliance is also a problem. Look, it's very interesting to look into this literature. There are only 30% of the patients comply. Especially, compliance is poor in males, in sleep, and the real-time compliance is only 5 to 6 hours per day. And 50% of the cases refuse to go face down, refuse the surgery because they didn't want to go face down because it was an ordeal, very difficult. Now, this is the position that I nursed my patients ever since 2009. And I avoid this position. And I tell you the results of the study that we carried out. So first, the documentation of the pattern, what is being practiced. Then we come up with the results and document the study. So if you look into the literature, there are several studies available, head down versus no head down when we use the gases. But the literature is very scanty as far as silicone oil goes. And this is the first ever study that directly compares, although retrospective, it directly compares the positioning head down and positioning head up. Now, when I was working in Riyadh, there were 3 retinal surgeons, and I continued my practice of head up position in the same department, while the 2 surgeons that included Dr. Zazi, who was supposed to be here today, 2 surgeons would put their head down. So we decided to look into the results of the complications related to the silicone oil injection in 2 different positions in 1 center. We identified 157 patients in 7 years that I was staying in that department. We identified 185 eyes and looked into the complication. Now, overall complications were not many. Silicone oil in the anterior chamber, epiretinal membrane, pupil block glaucoma, very few in numbers. And overall complication of 185 eyes. When we looked and the group of face up position and face down position, the complications were more in face down position as compared to face up positions, but no statistically significant. It was not statistically significant. We looked into the macular folds, silicon oil anterior chamber, epiretinal membrane, and pupil block glaucoma. And interestingly, the face down positioning was more in group A, the face down positioning. Face up positioning, the complications was less, but statistically non-significant. The post-operative intraocular pressure, who needed the medications on these patients, there were 23% in one group, 22% in the other group. So the first ever documentation that directly compares the patient head up and head down from one single center, although retrospectively, this study found no significant difference in sinocondylar-related complication between face down position and face up position. Both physiological and anatomical outcome measures also did not show any difference between the two groups. Both groups showed post-op rise in intraocular pressure with no statistically significant difference. As per results of this study, I can safely say that adopt the face up position. You can safely give up the face down position. And the take-home message, this is a paradigm shift. With normal intraocular pressure at the end of the past planar vitrectomy with silicone oil injection, no special positioning is required, except, I see stress on this point, except in aphakic patients, including pseudophakics with ACIOL, where endoiodectomy has been done to prevent the pupil block glaucoma. I thank you very much for your listening and patience. Thank you very much.
Thank you very much, Idris. You will get a lot of prayers from the patients.
Yeah.
बहुत दुआएं मिलेंगी. Anyone wants to ask a question? No. Okay. We are just preponing our program. There is some technical issues to be settled, so we are taking a 10-minute tea break, and we'll join after 10 minutes. The tea registered for the hands-on workshop. May kindly go there. All those who are standing in the lobbies are requested to kindly come to the hall and have their seats so that we can start our program again. All those in the lobbies, please come inside the hall and be seated. And I now ओ यार बस करो भाई.
We are starting the next.
We are just starting now. I can see Professor Manzoor Mirza is here. We very warmly welcome him here in the PIO 7th Congress. Thank you very much, sir, for coming. May I request all of you to kindly be seated, please. There will be ample time for photographs later on. यार आप अभी तस्वीरें ले लेंगे तो ये सब भाग जाएंगे बाद में. Okay, thank you very much. Cameraman. Okay, thank you very much. We are about to start our session now, and I'll request now Dr. Nicola Ghazi to come and give his presentation. Dr. Ghazi is going to talk about long-term outcomes of gene therapy in the United Arab Emirates. Welcome, sir. Please take your seats, sir. Please take your seats. The speaker is about to start his presentation. All those standing around, please take your seats. The speaker is waiting to start. Please take your seats. You can start, Ghazi.
Start? Okay. Thank you very much again for the invite. I appreciate the hospitality and being here again. So I will talk about long-term outcomes of gene therapy in the UAE. As you know, Voretigene Parvovac has been approved for treatment of RPE65 inherited retinal dystrophies. Gene therapy has been long in the making, but it wasn't really until 2017 when Luxturna was approved. And since then, there are now many clinical trials going on gene therapy. There are several approaches to gene therapy, and gene replacement or augmentation is one of them, and this is where Luxturna falls. So in gene replacement, we really replace the missing gene or the defective gene. So Voretigene Parvovac is designed for treatment of RPE65-associated inherited retinal disease. So what is RPE65? As you can see here, it's one of many genes that can lead to inherited retinal dystrophies. And it is a gene located in the RPE cell that is involved in the visual cycle. When the RPE65 is missing, the visual cycle is disrupted, and hence visual function is affected. In addition, there is accumulation of toxic metabolites or byproducts that lead to atrophy of the RPE cell and the photoreceptors. This primarily affects the rod system, at least in the beginning, and this is why most of the symptomatology is related to rod dysfunction. So we get decreased light sensitivity, diminished visual fields, nyctalopia, poor adaptations to suboptimal light situations, etc. So it's mainly a rod system disease. And here's curves from a natural history study on RPE65 associated retinal dystrophy. It shows you on the graph on the left that initially the vision is maintained, although it is poor, but it's maintained over the 2 decades of life, and then gradually it starts to decrease. And by the 3rd to 4th decade of life, these patients are hand motion to light perception. So it's a really progressive bad disease. Visual fields, on the other hand, the visual fields start to deteriorate early on in the 1st decade of life, and then by the 2nd decade of life, patients are left with a very small visual field, very restricted visual field, tunnel vision. So this suggests that the earlier the intervention, the potentially better the outcome. It makes sense because we really want to interfere when there are viable cells so that we can salvage as much as possible functional vision. And that's what voretigene neparvovec is designed to do. It's a gene vector based on adeno-associated virus type 2. It's designed for subretinal injection, so it's a gene replacement approach that is injected subretinally in the hope of transfecting RPE cells and generating the protein of RPE65 gene. This was, the efficacy of this was proven in phase 3 clinical trials. These pivotal trials had to come up with a new concept for measuring outcome, which was functional vision. As you know, visual function has several parameters listed on the left. The ones we're familiar with: visual acuity, visual fields, contrast sensitivity, dark adaptation, etc. Functional vision is the way the brain integrates all these parameters in order to allow a subject to navigate the environment and to read and write. So functional vision is a collective output of all these visual parameters that we are used to. To measure this, what is called the multi-luminance mobility test was constructed. It's basically a maze, as you can see on the picture on the right, composed of obstacles and arrows. The patient has to follow the arrows and avoid the obstacles as much as possible. And the performance is measured before and after treatment under different light conditions, as you can see over here. From the left is the lowest light condition, and on the right is a normal, well-lit office condition. The pivotal trials had 2 arms: a control arm in which both eyes were treated, and then, the treatment arm in which both eyes were treated, and the control group followed up for 1 year, and then at 1 year the control group was allowed to switch over to the treatment group. And these are the inclusion criteria over here. The primary outcome was the MLMT, which is the multi-luminance mobility test that I showed you. And here are the outcomes. So over the first year, if you look at the control group, there is no effect at all. Their performance navigating the maze does not change. Whereas the treatment group, you can see a significant improvement. 65% of these patients were able to pass the 1 lux, which is the minimum light condition that was allowed in this study. And then the effect was maintained for 2 years. And then at 1 year, when the control group was allowed to receive treatment, a similar improvement was noticed and was maintained for 1 year. And notice that the majority of the improvement occurred over the first 30 days. So it is a very quick response, and now we have data to show that it lasts for 4 years. So 1 injection, 4 years outcome. And here's a video on the left of a patient before treatment, and on the right, 1 year after treatment. And look at the amazing difference. On your left-hand side, the patient cannot move, hitting every obstacle in the maze, whereas on the right-hand side, navigating the maze very easily after treatment without a single mistake. So pretty great outcome. A secondary outcome was what we call the FSC, or the full field scotopic threshold testing. It measures the entire light sensitivity of the retina, and similar outcomes were noticed. A very quick response over the first 30 days that is maintained for 2 years, and now we know also for 4 years. It's really a safe procedure. The majority of the complications are related to the procedure itself rather than the medication. One complication in the study was felt to be related to the gene vector, which is retinal deposits. It was seen in 3 patients. You see this arc of yellowish subretinal deposits away from the bleb. It was noticed within a week of all the patients, but it resolved within 8 weeks with no effect on the functional outcome. The procedure also is not difficult. Now, these are inherited retinal dystrophies. You can see the degenerated retina. I always use triamcinolone to try to peel the hyaloid. In my experience, the hyaloid comes up easily in these patients. It's not difficult, but in this case, it was a little bit more difficult than usual. You use different techniques to create an edge, whether you use a finesse loop or a Tano scraper. The aim is to create an edge and try to lift it up as a single piece. And once a reasonable edge is created, then you go to the regular peeling technique using the cutter, as you can see here. And then we go to the subretinal injection. So we choose an area along the superior arcade per the protocol. It doesn't have to be this. And then we inject very slowly under the subretinal space, the gene vector. You can see the bleb forming. You really want to avoid detaching the macula if possible, but it is very hard to control the bleb. There are many different surgical techniques to do this, but really it goes wherever it wants to go. And you can see the bleb here. Now this is an elevated bleb. Now we know that it is better to try to form a shallow, wide bleb rather than a small, elevated bleb, and you end up with air fluid exchange, as you can see over here per protocol. Now, following marketing, we became aware of this entity, which is progressive chorioretinal atrophy. As you can see on the left, it was divided in a study to 4 categories: touchdown on the panel A, nummular chorioretinal atrophy, panel B, perifoveal chorioretinal atrophy, panel C, and a combination of all in panel D. What is interesting is the paper on the right-hand side that showed that actually patients who benefit the most from treatment with the most improvement in FST and in functional vision are the ones who develop the atrophy more than the others. And this has implications to the mechanism and the pathophysiology of this atrophy, which remains so far unclear, but it is felt to be due to overexpression and overactivation of the visual cycle in these cells. So we treated 18 eyes so far. All except one had real vision, real life evidence of improvement in vision. They tell me they can reach to their utensils on the table easier. They can see the bulletins on the road as they are in a car much better. They can see their phone if they lie down on the bed at night in their room. They can reach out for it without having to feel for it. They see where it is and they grab it. So multiple signs of real-world evidence of improvement. We have also objective evidence of improvement. 7 patients improved in their FST and 2 of them were stable, so nobody had deterioration in their light sensitivity following treatment. Vision was stable in most of them except 1, and as I said, vision is not the primary outcome in these patients. It's really the functional vision rather than the visual acuity. The treatment is not designed to improve visual acuity. And finally, look at this, the chorioretinal atrophy. We saw it in 77% of our patients, or 72% of the eyes. And in 86% of those who developed it, it was bilateral, again suggesting maybe a predisposition to chorioretinal atrophy. And this has been the experience also of other colleagues in other publications. Here's a few examples before I close. On the left is the pre-op. On the right, 44 months post-op, you can see touchdown atrophy and choreo and nummular chorioretinal atrophy with stable vision and FST, so it was not affected. Here's a patient on the left. On the right, 41 months after treatment, touchdown and nummular atrophy, but the vision improved and the FST improved. The retinal sensitivity improved despite the chorioretinal atrophy. And finally, here's a patient who developed all kinds of atrophy, touchdown, perifoveal, and nummular, yet the FST and the visual acuity were stable. It did not lead to worse, it did not compromise the visual gain, the functional gain from these patients. Now we're looking at segmenting these atrophic areas to try to establish topographic relationships as far as the risk of progression over time. So to conclude, gene therapy for inherited retinal disease is a rapidly expanding field. There are so many clinical trials on. So far, RPE65 is the only gene defect that can be treated. This is why increased awareness of it is very important nowadays, because we can offer treatment to these patients. But really you need a full team of ophthalmic expertise, but also pharmaceutical expertise. Really you need a pharmacy that is capable of taking care of this expensive medication. Chorioretinal atrophy remains a serious concern, although it is not very well understood. But I think it's a major concern for the entire field of gene therapy. I want to acknowledge all my co-workers and colleagues in the program, and thank you for your attention. Any questions?
Thank you very much, and a ray of hope for the IRD patients.
Is there gene therapy
Great lecture, yes.
in Pakistan?
No one.
No.
Thank you so much. Next we have Dr. Jose Antonio. He's going to talk about vision loss associated with silicone oil use.
All right. Well, I want to tell you about the unexplained visual loss after silicone oil extraction. You know, the silicone oil in vitro retinal surgery was introduced in 1962 by Paul Savis, and in Europe for Scott and Hyman. And following a collaborative study, the FDA approved its use in 1994. Silicone oil has important properties. It's inert, it's transparent, and it's permanent. But since the beginning of the use, there have been controversy regarding safety in the use of silicone oil. Silicone oil provides long-term tamponade, but that is beneficial in tough situations. We use it in PBR, young retinal tears, tractional retinal detachment, trauma, viral retinitis, uveitis, and tumors, and in the elderly and children. And usually it's well tolerated. And there is no association between the time the eye is filled with silicone oil and the rate of redetachment. However, there are studies that postulate that having silicone oil less than 3 months could increase the rate of redetachment, probably to the PBR pathophysiology. 29% of eye that has silicone oil removed improved their vision versus only 2% of eye that stayed with the silicone oil inside the eye. That's why we try to remove the silicone oil. That's one of the reasons. And the complication that silicone oil have is because of the prolonged tamponade are listed there. Most are because of the emulsification of the silicone oil. Cataract, glaucoma, keratopathy, choroidal thickness, and the silicone oil migration to all the eye, to the anterior chambers, to retinal, extraocular, optical chiasm, brain, and also optic neuropathy. And the vision loss related to silicone oil could be where the silicone oil is inside the eye or after its removal. And vision loss, we consider vision loss 2 or more lines of loss. These are not some of the known causes of the vision loss after the silicone removal. The principal is redetachment, but optic nerve damage secondary to glaucoma, hypotony, vitreous hemorrhage, and keratopathy. But there are some reports the vision loss after silicone oil removal, while the retina is still attached, when everything is fine, and the patient lose vision. Newsom reported 7 cases in 2004. Casabon, Williams, and Parker Van, some of them report some cases. This is a paper by Laura Sherlinky comparing unexplained vision loss in patients with silicone oil versus patients with gas. And she had 0.7 cases of loss of vision in gas, while 29% in silicone oil cases. So much more cases in the silicone oil. This is a paper by René Moya. René Moya, he did his fellowship. He did a residency with me in Lima, but he did his fellowship at Moorfields. And they reported a retrospective cases of 421 consecutive eyes with silicone oil removal, and 3% of them had an display vision loss. 50% of these cases was giant retinal tears cases. And this is the paper we published several years ago. A retrospective analysis of 355 eyes with silicone oil removal. 9% had vision loss because of redetachment, because known causes, redetachment, vitreous hemorrhage, and glaucoma. But almost 6% of the patients had unexplained visual loss. The only association that we got was the intraocular pressure more than 17 millimeters of mercury, and the duration of tamponade more than 8 months. These are some of the studies that are in the literature. You can see the duration of silicone oil and the intraocular pressure and emulsification as the causes of this vision loss. The clinical features of the display vision loss after removal of the silicone oil includes thickness reduction of the inner retina, central scotoma, visual defects, visual field defects, and abnormal electrophysiological responses. These are some of the hypotheses why the patient experimented visual loss. It could be because of the limited potassium clearance after the vitreous cavity, the higher concentration of fibrogenic growth factors in the retro oil fluid, phototoxicity, and the duration of silicone oil and intraocular pressure that we've already seen. Neuronal apoptosis can be triggered by sudden changes in the flow through the retina. But the Mueller cells dampen the extracellular concentration of potassium on the retina by siphoning excess of potassium into the vitreous cavity. When we have long-term the silicone oil in the eye, this can alter the ability of the Mueller cells to perform this action, leading to increased potassium into the subretinal space. Once the silicone oil is removed, the potassium undergoes sudden changes that trigger apoptosis of the neuronal cells. But with this paper, Loresh Linked compared the composition of the fluid behind the oil in the eyes with and without vision loss after the silicone oil. And she proved that the potassium was not elevated in the space behind the silicone oil. Another hypothesis is the phototoxicity. High energy blue light transmission is increased in silicone oil filled eyes, particularly in those with aphakic eyes. Also, silicone oil may dissolve the macular pigments, the lutein and the zeaxanthin. But light absorption by the lens and the cornea mitigates this potential phototoxicity, and the perioperative photostress is limited because now we are doing shorter procedures, and there's no difference between the phakic or the pseudophakic A's. And with this paper, they do the surgery with direct lighting and under blockage of the direct light or the direct light. And they found no significant loss between both groups. 4.5 in no blockage versus 1.3 in the blocked eyes, but it was not a statistical difference. The data obtained from enucleated eyes showed that silicone is impregnated in all the tissues inside the eye, in the iris, the ciliary body, the trabecular measurement, in the retina, in the optic nerve. But this doesn't explain the abrupt changes in visual acuity after the withdrawal of the silicone oil. It could explain the chronic visual loss, but not the acute, the abrupt silicone visual loss. The OCT reveals microcystic macular changes in the inner nuclear layer with loss of the nuclear nerve field layer, and these changes similar to what occurs in the multiple sclerosis neuritis. And you can see here the vacuoles in the inner retina. Packer-Brown reporting 20 eyes with an display vision loss, 62% of eyes while the silicone oil was inside the eye, and 38% after the removal of the silicone oil. And the cause was this thinning of the ganglion cell in 55% of these eyes. And the spade group reported these vacuolas of oil inside an optic nerve and inside the retina using adaptive optics. This is one of my cases. You can see these vacuolas inside the retina. Also, in this paper, that they performed OCT before the silicone oil, during the silicone, and after the silicone oil removal. They found that the tamponade with silicone oil causes flattening and thinning of the inner retinas of the inner layers of the retina, and most of these changes were reversible after the silicone oil removal, but not all. And with OCTA, they found damage at the superficial retinal microvasculature and apoptosis of the ganglion cells. In this paper, Jun Lee, performing OCTA, found that in the deep capillary plexus, the foveal vascular zone was larger and the vascular density lower than in the control lateral eye. And this has to be with the duration of the tamponade. That was significantly correlated with this enlargement. So she concluded that silicone oil tamponade may develop vascular insufficiency. This is a very, very recent paper from December 2024, and to compare macular versus density in eyes with macular off rheumatogenous retinal detachment after vitrectomy with gas or with silicone oil. The visual acuity, you can see in the silicone oil group was 20 over 2,000 before, and after 20 over 178. And in gas tamponade, from 20 over 2016, 2,636 to 20 over 100. So the gas tamponade group achieved significantly better postoperative visual acuity compared to the silicone oil group. And the silicone oil group exhibited lower vascular density in the superficial capillary plexus, in the deep capillary plexus, and also in the choroid capillary plexus, suggesting toxic effects in the macular perfusion while the silicone oil is inside the eye. So in short, there may be vision loss during and after the silicone oil tamponade. The silicone oil emulsification plays a very important role in silicone oil complications. The intraocular pressure and the length of the time that the eye stays with the silicone oil may play an important role maintaining, so the best is to maintain the silicone oil between 3 and 8 months and to maintain the intraocular pressure less than 17 millimeters of mercury. The prolonged maintenance of silicone oil inside the eye can lead to damage to the inner retina, and this patient may develop vascular insufficiency and ganglion cell apoptosis. Some of these eyes regain some vision after the silicone oil removal, but not all the eyes. I think, thanks.
Thank you very much. And is there any question? If there is, then it should be a very short and crisp one. Thank you so much. Next speaker is Professor Hussain Haqqan. He's going to speak about optic disc pit and serous macular detachments, novel classification and outcomes.
Good afternoon, ladies and gentlemen. The second talk is about a topic that is very near to my heart, and I'm working on this topic from last 15 years. So this is about the optic dispute and serous macular detachment. I have no financial disclosure for this. Can I have my pointer, please? So I will like to present a couple of cases with the optic dispute and serous macular detachment. So here you can see, if I can use the cursor, no. So you can see the optic dispute here, you see here. And this is the serous macular detachment. So there are a lot of theories, lot of discussion and lot of conversations about how to treat these PIT cases. But believe me, from the last couple of years, I don't believe none of them. I believe on some very factual treatment options that we should consider. So this is the preoperative OCT. You can see this is the serous macular detachment about, you will keep on moving the slide. So it's serous macular detachment. You can see about 1,000 some hundred micron meter. So, and what we do, I tried all the way of possible to refine. So here you can see the typical posterior highlight. As you see in optic dispute cases, this is the cisterna-like posterior highlight. I do complete the vitrectomy. I don't go for the vitreous-based shave and whatever. So I choose, this is the punctal plug that we use for the punctum. This is a silicone plug that is one-way closed. So I choose this one. This is a 23 gauge system where I am putting this punctal plug, and so I am going through with the end grasping forceps. So here we are inside the vitreous cavity. The only, sorry, where it is going. Sorry. So here I am near the optic dispute, and I am holding within the plug. So I'm just focusing to hit the bullseye. I don't want to touch the surrounding tissue, so I am getting it inside. It looks like a little bit terrifying, but it's okay. When I am in the space, I just have to feel it. As you feel the ILM flap or something, you have to feel it. Then I put it there, and then I have to plug it deeply. So now I am pushing it little bit deep. Okay, so you can fix it quite tightly. So at the end of the surgery, you can see how it is nicely fixed over here, and the pit is closed. So I will share how we followed this patient. So this is actually the post-operative images. If you can easily see, the arrow is showing the punctal plug, and it is nicely placed in the post-op, and serous detachment still persists. So it doesn't go away within a day or week. It takes sometimes much more time. It depends how longer it stays. So we followed this patient. So here is the post-operative OCT on the first day. So if you see here, this is the punctal plug actually. And it is closing all the layers along the retina. Here you said there is no connection from here to here. So we have closed all the source of fluid that is coming in the intraretinal surface. And we closely follow this patient for a couple of days, and then for the months, it started decreasing with the passage of the time. And at the 3 months follow-up, I got complete resolution. It was little bit more than 3 months. We got the complete resolution of serous detachment. This was after 2 months, 2.5 months. So if you go and compare it, just immediate post-operative period, here we will start it post-op, okay? And here we are very near to our good results. So here you can see the punctal plug is lying over here, and the serous detachment is almost gone. And the patient navigating from counting finger reached 612 at this stage. And then at the end, little bit more than 3 months, it was decreasing with the every passing day. And it was little bit quick at the end. So here we have at the end of the treatment, if you see there is even very little fluid over there. Punctal plug is staying there, neural tissue is healthy, and how we got. And this patient got 6/9 vision after 3.5 months. So this was a case that present our understanding of this disease. on the basis of this treatment and all the treatment, people are stuffing with the amniotic membrane. Amniotic membrane is not going to stay in pit, never. If it is a functional pit, we have to understand two things very important, whether the pit is functional or not, whether the pit is rudimentary or gone into involution. There is always serous detachment from the pit, but there is not always the pit functional. This all else is a myth. All the people are hypothetically they are thinking. This is true that there can't be serous macular detachment without a pit. When the pit is there, it may be functional, it may be non-functional. It may be functional and gave the serous detachment and when become the rudimentary or involutional. So you have to judge before the surgery whether your pit is functional or not. So on this basis, I made this classification and hopefully I will publish it soon. So if you go to this classification, so I have divided it into the four types, type A, type B, type C, and D. So type A is the optic is functional and serous macular detachment. What I have planned, I did the vitrectomy, PVD, plug the pit, and leave the eye with the balanced salt solution. No oil, no gas, nothing, okay? And next, this type B. Here, I tried with the patient how I confirm nowadays that a pit is functional or not. Pit is there, but how you know that it's functional or not? You go under the air, put little bit dye, BBG, and if the dye spreads out within the 3 to 5 minutes, it's mean pit is functional. So then you have to plug it. In this, the class B case, I tried to plug it because dye was spreading, but I tried to plug it, but I couldn't plug it. I left this case with the plug, and next day plug came out. I had to remove that plug, and you will not believe the patient here was hand motion. He was young, 18-year-old. And after 3 days, he was 6'6", without plug, without anything. Why? Because the pit has gone to the involution and there was no functional pit. And this serous detachment was just persisting because of the taut posterior highlight that we usually get in optidisc cases, optidisc pit cases. Now I get to the third case, where the optidisc pit and primary hole due to the edema. Patient got the optidisc pit and end up the serous macular detachment in the macular hole. So advanced. So what I did, so in this case, luckily, when I did the surgery, whole vitreous was plugged in the pit. So I didn't plug with anything. It's mean pit was functional, it gave the serous detachment, it converted into the macular hole full thickness, and later on plug was so adherent that it plugged the optidisc pit. And what I did, I left that plugged vitreous and did only the temporal flap in this case. And the macular hole closed, and patient is still on the follow-up from last 9 months. She is navigating on 630 VN. VN is not much improved because in the literature, I didn't encounter this macular hole. There is no literature that is presenting the macular hole that has been associated with the pit, and pit is closed with the plug. It's never been mentioned in literature that the pit can be plugged with by its own vitreous. So it's all the other things that we are reading are myths, people are on hypothetical meanings. So there is one more. I put the D1 and D2. These are the surgical complications that we get in the optidisc pit surgery. The first one is the surgeon did the ILM peel in optidisc pit and closed the pit with the homologous whole blood. Pit didn't close, and the serous detachment converted into the macular hole. So here we did the temporal flap, or you can plug it with the amniotic membrane graft and plug the pit with the punctal plug. D-type is a surgical complication that I encountered. Pit was functional, I plugged it. Serous detachment was too much, it was okay. Later on decreased, but we got a partial thickness or full thickness macular hole at the end. And I did the temporal flap in this case, and the hole is closed. So type D1 and D2 are surgical complication with the wrong procedure of the optidisc pit. Type A and B, C, this is the most rarest. I didn't find this type in any literature in the world. So these are most common. So I have classified them according to the management of these pit cases. This is a rare disease. You hardly find a case in 3 months. So in the early stage, we published this as a novel technique, and now we have more than 13 patients, so if anybody is interested to join us in this study, so we can do it. So I'm going to have any questions, so ask me the questions so I can improve to remove all these myths that have been here in the 60 years of retinal surgery. Yes.
So, first of all,
thank you. I can present more, but there's no logic of showing the same surgery all the time. You can take mine.
So first of all, excellent talk. Just a very simple question. You said that before the surgery you have to judge whether the pit is functional or not. So how do you judge whether the pit is functional or not? You have a serous macular detachment, but how do you know that it is an involutional pit or not?
This was difficult in the beginning in 2015 and 16 for me. At that time I was plugging invariably. Every pit I plug. But later on knew that there are the one cases that opened my eye. The pit was not plugged. Plug came out next day. I went in the OR, brought out the plug. But the serous detachment gone within 3 days, far quicker than. Then I realized not all the pits are closed, open. So there are pits that are closed after giving the disease. So then I do the air fluid exchange, and under the air I put brilliant blue over the pit. I wait for 3 to 5 minutes. If it spreads out, it means the pit is functional. Otherwise, it will stay like a bubble over there. So this is the only tool that I am trying to use it for as functional or not. Otherwise, OCT doesn't help you to get it functional or not, because it's a physiological process, not an anatomical process. Anatomy is there. If you go for the pit size, pit are all like funnel. You wouldn't find a fibrosis in it. Fibrosis only attached. This is the pit. You will find the fibrosis between the layers of the retina. Not here, not in the funnel. Fibrosis is here between the pit connection and internal layers of the retina. So here it can, and no OCT cannot pick this change. It's very difficult till the day. I couldn't find any OCT where you can pick it. So that's the only method where I choose whether the pit is functional or not, because there are my seniors and my colleagues. There are many pit cases where you do only vitrectomy and serous detachment goes away. They are group B. They are group B. I don't say that it doesn't work. It works. But this is the one part of this disease. You cannot say my 100% cases with the pit goes away with just vitrectomy. And it doesn't happen. Everyone in the hall knows. How you can get the 100% serous detachment goes away, identify whether pit is functional or not. If it is functional, plug it with a silicone plug. If it is not functional, just do the basic vitrectomy, leave the BSS, 100% result. It may take from the 3 days to 1 year to resolve. It depends how old it is. I had the patient, in the evening patient comes with the 6-9 vision and he say, I got the blurring of the vision. He was 35. I said, that's serous detachment and pit. I said, it's from last 10 years. You didn't identify. Go home. No need. Sit. I mean, he was 6'9". What to do with the 6'9"? Next day, patient coming. The day I did the OCT, next day patient coming with the counting finger vision. Will you believe in 24 hours, this detachment from 300 micron meter raised up to 2000 micron. Pit was not functional till the last night. It became functional in 24 hours. It gave the disease, maybe involute. So then I did the surgery and put the plug in it. So it is totally a natural procedure. So you have to understand whether the pit is functional or not. If you know it, then all the surgical complications, I told you how to deal with it, how to do the temporal flap with or without, whatever it is. So that's my understanding in last 10 years plus. So people talk weird thing. I don't like these weird thing to plug it with a sclera, to plug it. I don't understand how you people can have a water bottle. So how you people can plug the pit with the ILM. ILM is a stiff membrane like it. Can you open it for me? Put this over it and try to push the fluid from it. Push it. You will get your clothes dirty. How this membrane? But if you put your thumb in it, now push it. Push it. Push it. Nothing is coming out. So this is the simple explanation. Your stiff ILM cannot close. Your lazy amniotic membrane cannot close it. Only the plug can close it. Now push the water. No. So this is the simple explanation of everything. So whatever you think,
you keep on thinking. That's my understanding. Thank you.
Thank you so much. I think Noman would have understood it very well now. Our next speaker is Dr. Rahman Siddiqui. He doesn't need an introduction here in Karachi, and I'm sure he doesn't need an introduction in Pakistan also. He's such a well-known person in vitreoretina. He's going to talk about utility of preoperative SSOCT in patients undergoing diabetic vitrectomy.
Assalamu alaikum everybody, and thank you Hashmani group for the opportunity. I think that should be okay. Yeah. My talk is quite a brief talk about what we are doing in our patients with advanced diabetic eye disease. As you know that sometimes planning is the most important part of the surgery. So we have access to swab source OCT, and what we have done is swab source OCT on all patients undergoing advanced diabetic vitrectomy for advanced diabetic eye disease. These are my financial disclosures. So the purpose of this study was to determine the benefit or utility of preoperative swab source OCT to detect ocular pathology, particularly in the presence of vitreous hemorrhage in patients undergoing diabetic vitrectomy. This was a prospective cohort study done over from 2017 to 2022. It was done at Shahzad Eye Hospital in Karachi, Pakistan. As a routine, we performed all the things, vision, IOP check, and fundus examination where it was possible. The swab source OCT was Topcon Triton OCT machine. The inclusion criteria was patients with vitreous hemorrhage secondary to advanced diabetic eye disease, but only those patients who were actually undergoing vitrectomy surgery. The fundus photos and swab source OCT scans were done between 1 and 7 days prior to surgery. We performed vitreous haze scoring to identify various groups and what was the severest diagnosis on fundus photograph and the diagnosis on swab source OCT. We used a modified BIO score of vitreous haze where the classification was used as per the slide. And this is a BIO score of 5+ where there is really no view of the fundus. Here you can barely see the disc. Here you can see the disc and blood vessel. This is bioscore 4. This is bioscore 2 that fundus details can be seen, but they are hazy. And this is a bioscore 1. There's just mild vitreous haze. Most of the details are visible. This is the demographic characteristic of the study. We had 41 patients included in this study. And we started with 61 patients, but a couple of patients did not consent for the surgery at all. There was insufficient view for the fundus photo and the OCT in about 11 patients, so we had 41 patients in the final analysis. These were the bioscore. Most of the patients were with the severe bioscore. That's why they were undergoing vitrectomy surgery. So this is one example of a patient who had this kind of vitreous hemorrhage where there was no clear view, but when you perform the swab source OCT, you can see that there's a nasal TRD, but also you can see that there's macular thinning. So I think it helps in counseling the patient prior to surgery what sort of expectations you have. Similarly, this is another patient where you are seeing that the most of the hemorrhage is just under it's the pre-retinal hemorrhage. There's no significant pathology visible, and you know that the likely outcome for this particular patient is going to be good. Similarly, we had patients who had macular holes and vitreomacular tractions. One of the patients had age-related macular degeneration under the vitreous hemorrhage. So it was easy to counsel those patients. So this is a table showing diagnosis based on the fundus photograph, the worst diagnosis. And some of the numbers don't add up because patient had more than one diagnosis. Similarly, on the swab source OCT, you can see that there were more patients diagnosed with tractional retinal detachment because you were able to visualize under the retina, and you can see that your patient had, for example, diabetic macular edema, and you can counsel that patient that even though I'm performing this surgery, you will be requiring injections after the treatment. So basically, other authors have looked at the utility of intraoperative OCT and found it beneficial in vitreous hemorrhage patients. And authors have looked at the fundus photos and on-fast spectral domain OCT in the evaluation of patient undergoing ERM surgery to see whether those are useful. We have also looked at the value of swept source OCT in patients undergoing cataract surgery, and we have shown that unlike spectral domain OCT, because of the particular characteristics of the swept source, that it penetrates media opacities, we were able to see more pathology, and we recommend that patient undergo some form of OCT examination before cataract surgery, particularly if they're receiving premium IOL. The strength is, this is a first, as far as we know, using swept source OCT for preoperative evaluation of patients undergoing diabetic vitrectomy. We have a small sample size, which is a limitation of our study. In conclusion, we can say that swept source OCT, with its unique characteristic of penetrating, laser penetrating the media opacities, it may be beneficial in patients undergoing vitrectomy for diabetic vitreous hemorrhage, advanced diabetic vitrectomy, particularly for diabetic planning and counseling. And this should be considered as an adjunct to an already thorough clinical examination. Thank you. Any questions?
Thank you very much, Rahman. I think it seems there's no question. So next to speak is Dr. Noman Hashmani. He's going to speak about the OCT angiography.
Okay, so after all of these surgical retina talks and difficult topics, I wanted to do something simpler, something that benefits a lot of people. And we've talked about all of this technology, all of these new techniques, but if we don't know how to use this technology, I mean, we cannot effectively use it to help our patients. So this is a talk on how, this can be applied to any machine, but how you can enhance your visualization in OCT angiography. Because if you don't know how your machine software works, you're never going to be able to elucidate what the pathology is. So just before we start, you have to understand what the basic of OCT angiography, it works on motion. So it's not actually picking up any anatomy, it's picking up the flow from one point to another. And whatever flows, so the only thing flowing inside the retina is the blood, and that's what it picks up, and that's where you get your OCT angiography pictures. But remember, if there's something floating around in the vitreous, it may pick it up as well. So, but you also have to understand the way OCT works. So the way OCT works is that it has a finite light source, and that light source needs to be concentrated around an area. Now, if that concentration is on a larger area, it's not going to pick up minute details. But when you condense it to one particular type of area, that light source is going to pick up a lot of minute and small details. And this is very important for OCT angiography, and even for OCT for that matter. Now, as physicians, we get this printout. And on this printout, you can't really tell if the segmentation segmentation was done properly, or if whatever you're seeing in the top 4 portions of the angiography is actually truly representative of what's actually happening in the retina. So you have to know, and you have to have access to the software. And what the machine does is it provides this automated segmentation for outer and inner retinal layers and choroid, but then you have to trust the machine to do it correctly. And the catch here is that if the retina is normal, it'll do it very well, and it'll do a very good job of it. But the minute your anatomy goes a little bit off, all of this the machine will be confused, and it will not be able to pick up the exact layers it's supposed to. And that's where you as a physician then come in to pick up where the pathology is. Now, in all of these cases, I'm not providing a lot of history because this is primarily a talk on OCT angiography. So this was a 74-year-old male, and he came with metamorphopsia. Now, we can see the flow, and on the OCT, you can all pick up what it is, but then we did the OCT angiography, and we didn't pick it up. There's no CNV, there's nothing, so now we're thinking that maybe that there's some scarring or there's some inactive lesion. But then we did a second scan, and now we've picked up a CNV, and not only in the choroid, but in the outer retina as well. Why is there a difference? The huge difference here is that the first one was a 6mm scan, so the light source was actually spread around a bigger area, and then the second scan is actually on a 3mm area, so that finite light source is now focusing on a small area, so it picked up more details. Then the second case that we have is a 62-year-old male, and again, he's complaining of decreased vision, very similar picture to what the previous one was, and now you've got this kind of picture on your OCT, and you've got this scan. Now, this is very simple to pick up. You can see the horizontal scan lines that you can see on almost every image, and this is motion artifact, and you don't even have to be at the machine. You have to just send the patient back to your technician, and you have to get another scan, because the patient moved his eyes, and that's why you can't really see anything. And you correct that out, and you get a CNV. And now you can start treating this patient. Then we followed this patient up again another 6 months later. We did this scan again, and with this segmentation, again, we got this CNV-like picture once again. But then if we go back and then we look at the video of this patient, now you'll pick up that what type of CNV is this? Is it a type 2 CNV? Is it a type 1 CNV? Is it a RAP lesion? To figure that out, you need this video. So if you see very closely, these two blue areas is where the segmentation is happening, and this is your CNV. And if you look closely here, when I'm going down on the scan, so right there, actually there's an anastomosis with the inner and outer retinal plexus. So this is actually a RAP lesion. It's not a simple CNV. So why does that matter to the patient? Because now you're going to have to treat him extensively. His entire prognosis changes because a RAP lesion is a lot more difficult to treat. And his vision prognosis also sort of goes down. Then we followed this case up again. This is the same case 1 year later. And now, if you see, this RAP lesion was actually not exudating. So there's no subretinal fluid. There's nothing there. But we know that there's a RAP lesion. 1 year later, it sort of exudates. And now you've got this huge exudation in the retina, and the retina is getting spoiled. And we, again, did a scan, and now you can't see a CNV. And part of the reason is because there's no flow through, there's a lack of flow between that vascular network. But then we go back and check the segmentation, and we've got a segmentation of the choroid that's actually just, it's very superficial if you actually look at it closely. And then when you look at the outer retina, it's only looking at the cystoid edema space. Then when you go back and you do a custom slab, so if you can see, I've gone way under where the machine was doing the segmentation, and because of that, now we can pick up a network of CNV. And we know it was a CNV because we had this patient and we were following him through, but if you get this patient as a first instance, you would be confused as to what it was. And it was just a segmentation error that you could fix. Then just as an introduction to, this can be used in diabetic retinopathy cases as well. So there's several use cases for it. One of it is, if you can see, this is a 26-year-old female with diabetes for 10 years. And yes, it's a 26-year-old with a extremely bad fundus. And you can see neovessels and all over the retina. Now, what layer are these neovessels in? So, of course, as a seasoned retina person, you can actually pick out where it was, but you can actually go into the OCT angio, and you can pick out that these vessels were actually, they're spreading on a scaffold of vitreous, and they're surrounding the entire optic disc. So these neovessels are not on the retina, they're actually in the vitreous. And this then becomes important in retinal surgery and bleeding complication and all of that stuff. And then You've got innovation of a couple of years old now, and you've got wide field angiography techniques that you can use to pick up, especially in those people that can't undergo FFA, and then you can pick up ischemic areas in the periphery of the retina. And this was actually taken on the Triton OCT, and all the other images that I showed before was on the OptoView machine. And again, another instance of actually montaging and getting wide field angiography. So thank you very much for your attention. If there's any questions, I can take them now.
Thank you very much, Noman, for sticking to the time. And now I have Dr. Jose Antonio. Methotrexate in the management of complicated PVR cases.
All right, thank you. I'm going to talk about some methotrexate in management of complicated retinal detachment cases with PVR. The vitreoretinal surgery has significant advances in the recent years. We have more small gauge vitrectomies, faster cutting rates, we have adjunctive agents, and the visualization also has improved a lot. Now we have wide field contact and non-contact system with the digital assisted vitreoretinal surgery. So our surgery are much better than they were 10 or 20 years ago. But despite these advancements in safety and efficacy, PVR remains a significant challenge. PVR is a complex pathology that occurs in about 5 to 10% of patients after retinal detachment surgery, and it involves the migration of retinal glial cells or pigmented cells that results in pre-retinal and subretinal membranes and complicate our cases. The increased odds of PVR development are listed there. There are systemic factors, younger age, female gender, smoking history, and hypertension. And ocular factors, poor baseline visual acuity, history of ocular trauma, choroidal detachment, uveitis, giant retinal tears, pseudophakia, aphakia, and ophthalmitis. PVR has shown to be associated with multiple cytokines, chemokines, and growth factors, as well as extracellular matrix proteins. This complex pathophysiology makes the development of pharmaceutical treatment very challenging. The surgical intervention is a cornerstone for the management of retinal detachment complicated by PVR. You have to do a very, very precise surgery to rule out this PVR. But if we could prevent the primary onset of PVR, it would be represent a significant leap forward in the vitreoretinal surgery. And several pharmacological agents have been investigated, including those listed over there: corticosteroid, retinoic 5-fluorouracil, platelet-derived growth factors, VEH, VEF inhibitors, heparin, and others. But despite some reports suggesting the potential efficacy of some of these, the evidence was insufficient to support the adoption, the widespread adoption of this specific treatment. In 2011, Dean Elliott and Thomas Strivensky conducted a phase 1B clinical trial to investigate the safety and tolerability of weekly repeated intravitreal injection of methotrexate in high-risk eyes for developing PVR. The justification of use of intravitreal methotrexate that methotrexate suppresses inflammation and inhibits cellular replication. These are both the principal components of pathogenesis of PVR. And given that the PVR typically can manifest weeks or months after 3 months also of the retinal detachment surgery, the treatment is administered repeatedly over the entire period of risk, rather than as a single injection or during the end of the procedure. This is on our paper that we published several years ago in 2021, using intravitreal methotrexate in these complicated cases. It's just a small report, only 16 patients. All patients have retinal detachment with PVR C5. The patient was offered the surgery with the use of the methotrexate. And the methotrexate has to be injected weekly postoperatively. All the patients the surgery was done by myself. And the retina was attached during using the conventional retinal surgery that we have right now. 7 eyes received 400 micrograms of methotrexate at the end of the surgery on a weekly basis as adjunctive postoperative therapy. If the retina redetached during the follow-up, the patient was offered further surgery if the retina could be repaired. Of the 16 patients, 9 patients refused to go on with the methotrexate because of the injections every week. So the 9 patients were our control group, and only 7 eyes were the treated group. These are the results before the surgery. They were very balanced. In the methotrexate group, 3 eyes didn't have any prior surgery. 4 eyes had previous surgery repaired that failed before the methotrexate. In the control group, 5 eyes have no prior surgery before the diagnosis of PVR. 3 eyes has prior surgery. 1 eye had 2 previous surgery with PVR. But there were no statistical difference between these 2 groups. Well, after a mean follow-up of 18 months, 86% of the eye in the methotrexate group had complete retinal reattachment at the end of the follow-up period. Retinal reattachment was obtained after 1 surgical procedure in 2 patients, after 2 surgical procedures in 4 eyes, and after 3 surgeries in 1 eye. In the no-methotrexate group, after a mean follow-up of 21 months, 22% of eyes had complete retinal reattachment. This difference was statistically significant. The mean follow-up postoperative visual acuity in the methotrexate group, there was no statistical difference with the before and after the surgery. The same occurred in the no-methotrexate cases. The visual acuity was the same before and after the surgery. The intraocular pressure was 11 in the post-op period in the methotrexate group versus almost 15 in the no-methotrexate group. Patients received a mean of 6 injections of methotrexate. We have no cases of epitheliopathy in this group. This is the GUARD trial. The GUARD trial begins in December 2019. It was a phase 3 multicenter randomized controlled trial to investigate this agent ADX2191 is 0.8% of intravitreal methotrexate for preventing recurrent retinal detachment due to PVR. They enrolled patients with star folds over at least 3 clock hours, and the exclusion criteria were no light perception, pretysis or ptysis, severe non-proliferative diabetic retinopathy, severe dry eye with corneal diseases, glaucoma or intraocular inflammation, and patients 16 years or younger, or patients with more than 6 surgeries before the treatment. Patients were randomly assigned 1-to-1 intraoperatively or operatively to either the ADX or to control group. In the treatment group, ADX was administered intravitreally at the end of the surgery or the postoperative day 1, and followed by weekly injections 8 weeks, and then every 2 weeks until week 16, for a total of 13 injections. This is at the end of the surgery, 8 more weeks, so 9 injections, and then every 2 weeks for 4 times more, so 13 injections in a row. The surgical procedure includes what we do every day, with the removal of all the membranes, epiretinal membranes, supraretinal membranes, or epiciliary membranes. The use of intraocular dyes, sclerobuckling, relaxing retinectomies was determined by the investigator. The retinal breaks were sealed with a laser. All eyes received silicone oil, 1,000 or 5,000 silicone oil. The steroids were not prohibited, were not allowed in the surgery. The study participants were required to use lubricants to avoid the keratopathy, and silicone oil could be removed after 24 weeks. The primary outcome was the rate of retinal redetachment due to PVR requiring operation within 24 weeks after randomization. The secondary endpoint was best corrected visual acuity changes. Vitrectomy was using a small gauge system. If the eye was phakic and with the clear lens, the lens was preserved. If he had cataract, you can do it was allowed to do the surgery with intraocular lens. If the patient were aphakic, they were not allowed to put intraocular lens inside the eye. It was not permitted. In the GERD trial, neither the physicians nor the patients were blinded. So it was very difficult to get patients for the control group because both patients and doctors prefer to be in the treatment group with the methotrexate. Therefore, these results have to be compared with those obtained in previous study, not in the control, but in previous study. But these are the primary endpoints. The rate of recurrent retinal detachment requiring reoperation with 6 months was 24% in the methotrexate group compared with 39% in the historical control group. The methotrexate group experienced fewer adverse events, less hypotony and less epiretinal membrane formation. And the primary results show that methotrexate reduced the degree of membrane growth epiretinal membranes. So in final reflections is that PVR remains the leading cause of failure of primary retinal detachment. 5 to 10% of our patients are redetached. The pathophysiology of PVR is complex with multiple targets contributing to the development of PVR and the progression of PVR. Several drugs, including those listed there, were studied, but unfortunately none has to be proven to be effective. All these prior trials have been characterized by only one-time injection, and that's probably why they fail. PVR, as we know, PVR is a dynamic biologic process that initiates shortly after retinal detachment, and it continues for at least 90 days, picking up about 2 months. Therefore, it's not a surprise that one-time drug infusion or injection is not enough to start the development of PVR. Any effective PVR treatment will need for at least we have to give in for at least 90 days post-operative. In our study and in the GERD trial, have been demonstrated that repeated injections intravitreal methotrexate during the post-operative period led to a superior anatomic outcome. And although the treatment burden of 13 injections over 16 weeks is intensive, these results may lead to development of sustained release devices like maybe like Osurdex or something like that, or other drug delivery methods to keep methotrexate inside the eye for at least 16 weeks. Thank you very much.
Okay, thank you very much. Next to come is Dr. Walid Zabeba. Going to speak about post-vitrectomy and ophthalmitis.
Thanks again. So I will talk about post-vitrectomy and ophthalmitis when the treatment leads to the problem. So until now, there is no appropriate treatment guidelines available for post-vitrectomy and ophthalmitis, even in EBS. So also there are very few studies about post-vitrectomy endophthalmitis compared to the other causes of endophthalmitis, post-cataract surgery, or after intravitreal injection. So let's move to our case. In whole work, I have 3 cases of endophthalmitis, so it's a very rare issue. So in this case, it's high myop patient, pseudophakic bilaterally, dropped IOL in the vitreous, epiretinal membrane, so I decide to do vitrectomy, explantation, membrane peeling, and Carleval scleral fixation. So let's move to the surgery. As I present in the previous talk, so I show you the lens in the back with his bag. So I begin with making the Huffman pockets at 3 and 8 o'clock. And then we place the trocar and we do vitrectomy. Before that, I prepare the scleral tunnel to remove the rigid IOL from the back. It's a PMMA IOL. As we can see, the lens with his back is back of the retina, behind the optic nerves. So then I remove the IOL through the tunnel, as we can see. Then I dye the back of the retina, and we do membrane peeling. I place the Carleval IOL. It's a long surgery, around 90 minutes. So we close the wound and we remove cannula. As we can see, 90 minutes. Few hours later, the patient with eye pain, blurred vision, hyperemia, corneal edema, hypopain. So we decide to do TAP, intravitreal antibiotics, closure the incision, and antibiotics oral. So 1 month after, I am lucky, and the patient was lucky also. So according the last publication, the risk factor for endophthalmitis after vitrectomy, there is wound leakage, sutureless, but I am not very sure with that, absence of endotamponade, and immunodepression patients. In our patient, we have wound leakage, absence of endotamponade, and for me, the main cause is long duration of surgery. To resolve this problem, last publication talked about vitreous wash, TAP, intravitreal antibiotics, and steroid. For our patient, we close all the incision and we add a caruncular injection of vancomycin and steroid. Now the question is, should I have used silicone oil in my case or not? According to studies, silicone oil tamponade has many benefits: better visual acuity anatomic outcome, less need for additional surgery, and decrease the risk of retinal detachment. But when we have endophthalmitis in eye filled with silicone oil, is not our case, but it can be seen. So authors of few studies talk about removal silicone oil, washing out the vitreous cavity, use antibiotic, and reinjection oil silicone. So outcome for these cases with a poor final visual outcome. So yes, post-vitrectomy endophthalmitis is rare, fortunately. Multicentric study is needed to identify risk and codify the management. So I ask you and ask my colleague and friends, have you faced post-vitrectomy endophthalmitis, how did you manage, and what do you think about silicone tamponade? Go.
I have encountered only one case in my life where I did the vitrectomy, everything went well, and I put the silicone oil. And next day, patient got the cloudy cornea, and he got raised intraocular pressure and endophthalmitis. This was the only case. The reason was the infected or contaminated silicone oil. Otherwise, till the day I have done thousands vitrectomy, I didn't get any endophthalmitis in oiled field eye. So that the only cause was the contaminated silicone oil.
Okay.
In that case, I did remove the silicone oil, but I think that silicone oil was contaminated with the fungal growth, and I couldn't salvage the vein and just barely salvage the eye wall. So I don't know. I mean, after the silicone oil, it shouldn't be endophthalmitis. The only cause is if the silicone oil itself is contaminated.
Okay. What about? Yes.
One of the things that I remember before is I was in the era when we had small gauge vitrectomy, the beginning of the 25. I was sitting beside Robert Makmar, and someone was presenting the higher incidence of possible endophthalmitis after the sutureless 25 gauge vitrectomy, because they were not suturing and so on. And one of the things he commented on, he said, the vitreous is a very good culture media. So if you don't have a suture and you have by chance colonization of the conj and it gets in the eye and you still have a lot of vitreous, it's so easy to get endophthalmitis.
Yes.
So in vitrectomies, usually we don't get it because we removed all that vitreous. And the endophthalmitis is usually very bad because if the bug is that bad and you don't have vitreous, that means it's already a bad situation. But that's why the prognosis is very bad for those, but also it's why we don't have many of those.
Okay.
You know, probably around 1 month ago, I have my first case of endophthalmitis after the vitrectomy. 3 days after the vitrectomy, I saw the patient and he has a hypopion, so I went again to the OR and do again a vitreous surgery to take out all the material and put vancomycin and ceftazidime inside the eye. 2 days after that, I have to put again the antibiotics, just injection and antibiotics. But it doesn't resolve. So 2 days after, I put again the antibiotics and povidone. And with the povidone, the eye went well.
Okay, thank you. Good. You have a question? Yes?
I wanted to say, in the past month, I saw two, actually. One, I operated on to treat, and another one my colleague operated on to treat. The one I did, the culture was negative, even though the eye was full of pus. The second eye grew Enterococcus faecalis. And when you looked at the literature, these are very rare, but the bugs, like Tamer mentioned, they're a little bit unusual and very virulent. So these eyes usually don't do well. I think you were lucky in your case.
Okay, as you can see, it's very rare situation, so go.
Very interesting. With the invent of the povidone, the intraocular infection has gone down overall.
Yes.
Now, in the all series of my experience of doing vitrectomy, I just showed you there was not a single infection in 370 retinectomies that we reported. I can recall 2 infections very clearly in my life. One was the pseudophacus that I operated for the cataract surgery, and he had the pseudomonas identified, and he responded very well, alhamdulillah.
Alhamdulillah.
The infection with the vitrectomy, I faced just one in my life, and that was filled up with the silicone oil. I went in, removed the silicone oil, did a good washout, whatever I could, and injected with the routine antibiotics and Dexa, Venco, and Septa. And Interestingly, no organism was identified on culture as it may happen. And this patient, I did not put any tamponade.
At the end, you put silicone or
I
no?
did not.
No.
I did not. I just did the partial fluid air exchange and came out, and I was lucky to salvage this eye. It went all okay. That's the only infection I recall. But overall incidence is, as all our colleagues say, is very low.
Thank you. Thank you for listening.
Okay. Thank you so much, Waleed. And next speaker is Dr. Tamer Mahmood. He's talking about nano-vitreoretinal approach to the subretinal space in 2025.
Yeah. Do you want the HDMI? No. Here. I hope everyone stays awake with me before lunch. So there's a lot to cover here, so hopefully we can go through this. So just to make this a little bit easier, when we think of the subretinal space, the first thing as vitreoretinal surgeons that come to our mind is subretinal hemorrhage. So I'm going to start with subretinal hemorrhage and then move to the topic that we want to also mention something about today. So when I think about submacular hemorrhage, I have a very simple classification that I like to go through. If the hemorrhage is large, extending to the arcade, or thick in the fovea, these are the indication where we consider a surgical procedure. And the more we wait before the procedure, the worse the outcome, because the blood becomes dehemoglobinized, fibrin cross-linking takes about 2 to 3 weeks, then we have more damage to the photoreceptors, and we cannot get better visual outcomes. So we have to move pretty quickly before that. And this is the main historical milestones that we went through over the years about how to deal with submacular hemorrhage. So the first step back in the 80s and early 90s was removal of the hemorrhage. And we thought that we can do that. So Kamei and Tano injected PFO, and then they used a small retinotomy to squeeze the blood out through it, which was not easy. Zivanovic and Kleiss, what they did a large retinectomy, injected TPA, but they had to wait longer for the effect of TPA. And they found that, yes, you can remove the hemorrhage, but also you're going to lose vision because the hemorrhage is very sticky to the photoreceptors. And a breakthrough came when Wilson Heriot at Vail in '96 presented the concept of displacement and not just removal of the heme. And he can do that in the clinic by injecting TPA in a gas bubble. Then Brooks McEwen and the Duke group presented the idea of reaching the subretinal space to displace the blood. You can have a better displacement. Then Kirkpatrick group showed that if you inject a larger volume, you may get a better displacement, avoid the toxicity of TPA by injecting a smaller concentration. Then in 2013, we introduced the concept of using subretinal air for a better displacement. And then recently, we used the nano-vitreoretinal device to be able to reach the subretinal space even without vitrectomy. So if we are able to displace the blood, we have to understand the forces acting on the blood and the subretinal space. We have buoyancy, friction, and gravity. We need to increase gravity, reduce friction and buoyancy for a better displacement. So we can reduce the friction by the effect of the TPA and a larger volume to be able to displace. And the gravity is best when the patient is in a sitting position to increase the force of gravity while the gas bubble is being bathed by that gas bubble in the vitreous cavity. The value of the subretinal air is to significantly reduce the buoyancy, but the patient in the sitting position, you still need that gas bubble in the vitreous cavity so that the subretinal air doesn't go all the way superiorly, so it has to displace. So if you think about, if you are in a swimming pool and you see all those bubbles going up, air has to go up. So if it reaches a point where it cannot go up anymore, it has to displace the blood inferiorly. And according to the Archimedes principle, the heme is roughly 830 times less buoyant in air than in fluid, so it has to displace. So this is an example, step by step, how we do that procedure. I use the automated infusion through the machine. It's much easier and more controlled, so you don't get any complications from the procedure. So this is an example where we do it through pars plana vitrectomy initially. Once you finish the vitrectomy, you can go to the side, and this is the silicone oil injection. I use filtered air and get more air in the syringe, and then we inject the TPA, and then inject the anti-VEGF if you want to increase the volume. You can inject any of those except Eylea, because Eylea inhibits the effect of the TPA. Once you have it, then you can connect your subretinal cannula. So here, this is the nano cannula that I'm connecting, and then you move it upside down. So when you move it upside down, the air will go up, and the fluid will be ready to inject. You prime the cannula, so we go over the eye, and then extend that subretinal curved cannula. Make sure there is no air in the system initially, it's only the fluid. Then we go in, stay away from the fovea to avoid a macular hole, and we start very slowly injecting. Usually 6 to 8 psi of pressure is good enough to have a very nice bubble. Once you do that, you come out, inject all the remaining fluid, so you are now not injecting too much of the fluid like TPA. Once you're ready for the air, you go in and inject your bubble of subretinal air, and then just a slow fluid air exchange, and you can get a fantastic, better displacement. So this is another case of one of the initial cases, and you see the fluid going in to create a space for the air, and then it makes it easier for the air to enter the subretinal space with the fluid air exchange. This is what I like to see post-op day one. And you may think this is crazy. This is the retina detached? What's going on? This is exactly what you want to see, because in the patient in the semi-sitting position, all the hemorrhagic detachment is inferior. That means it's displaced. You have air, as you can see in the image, in the macular area, and you have partial air fill 50% to prevent the subretinal air from going superiorly, so it has to displace, and you get that fantastic wide field view where you don't even get just slight displacement of the fovea, you gain that central visual field for a wide displacement. It's just lagging behind a little bit. It's not moving. No, it's not moving now. It's stuck. Here, this one is stuck. Hold on. No, this one. Yeah, thank you. So after we did that initially, Kazuwaki had a prospective study, 100% displaced. He only had a macular hole once because he injected very close to the fovea. And then we did the US-based study, and we also had 100% displacement, but not only the displacement, we had 75% beyond the arcades and 20% beyond the equator, so you can have a very wide displacement. The way to avoid a macular hole is to inject away from the fovea. Here we're injecting very close to the fovea, and you see instantly that that air bubble is going through the fovea. Then the blood is displaced, we still have a macular hole, then we went in and did an ILM peel and continued injection. The patient did well. How to avoid a macular hole with any case of subretinal injection? You always have to go close to the inferior arcade, because the highest risk is at the time of injection if we are superior to the fovea or we are close to the fovea, so the fluid goes in and then the air goes in after the fluid. Sub-RPE hemorrhage can also be displaced. So this is a monocular lady that had dropped vision, had a large hemorrhagic PED. We did an injection, it didn't help. Then we went in and displaced, and you see instantly after the displacement how nice it is. And then we continued the injection. So we can get 100% displacement, 74% in the US study in sub-RPE hemorrhage, wide displacement, no additional complication. The key is we're reducing the density of the hemorrhage, keep the retina detached for about 3 to 4 days, and then that interaction and liquefaction helps more displacement. The air creates a lock to prevent the TPA and the anti-VEGF from going into the vitreous cavity, and air may provide some oxygenation to the deprived photoreceptors. Now, there has been an extended indication for acting in the subretinal space for the last few years. Not only submacular hemorrhage, but now gene therapy, stem cells and RPE cells injection, drug delivery, biopsies of tumors, and removal of PFO. So there are two ways to approach the subretinal space, either through the pars plana approach that all retina surgeons are familiar with, or the suprachoroidal approach, but it still has a lot of complications but potential. So a few years back, we developed a device, very simple, called the Nano Subretinal Gateway device, where you can reach the subretinal space through pars plana without even doing vitrectomy. And this is huge in, for example, babies and kids. So when you extend it through the side port, then you can have a flexible tip to reach the subretinal space. It is a little bit beveled, so it's easy to penetrate, and 6 to 10 PSI is enough. So this is a lady that didn't respond to the injection, and I'll show you how to do the procedure. It is in the OR. We still need light, so we use the chandelier to put it in, and then we try the device outside the eye, and it has a tip like the needle that you use in the clinic for intravitreal injections. So you can go through the pars plana without vitrectomy. So once we prompt the device, it is connected to the machine through the automated infusion, go through the sclera exactly like pars plana. When we get close to the retina, then we extend the tip and enter the subretinal space. And you can inject anything that you would like to inject in the subretinal space, whether fluid or air, and then retract the tip, and then come out of the eye, and then just in that area do a depressed exam because we enter the vitreous cavity. Think about it like an intravitreal injection, but you're reaching the subretinal space. And then the pressure is usually slighted up like a buckle when you pull on a buckle. So you do a paracentesis, close the chandelier, and inject SF6 100% and position those patients. So we can reach the subretinal space, and you see how nicely it's displaced, and you can continue your injections. One injection reaching the subretinal space, one port, no vitrectomy, and this is the code that we use. We improved the device over the years, and now we have a curved one that I showed initially. And with the bevel tip, we can really reach that area of the subretinal, especially for gene therapy, because with gene therapy, the retina of inherited retinal disease is very thin, exactly like Dr. Ghazi had showed. So you inject your bleb, and then you can direct it to have a large bleb gradually. And we also arrange so that the knob of the device is at the same orientation at the bevel, so we know exactly where we are. And we can, because of the curve, thread it in the subretinal space to inject the gene therapy away from where we enter the subretinal space, so we can prevent any egress in the vitreous cavity. Now we're using it for tumor biopsy that I mentioned, and the advantage is when you take a biopsy with the vitrectomy probe, you can get a lot of complications, vitreous hemorrhage, you create a large retinal break. So here we're going in and trying it through a suspected nevus or a melanoma, where we are gradually going in and out of the tumor, and we can get a very steady, we can get a very good sample with a very small port. We're doing a randomized study now to compare this with the vitrectomy probe, but we can get in every one of those cases gene expression profiling, minimal heme, no breaks, no laser is needed, less cellular spread, and it's very also advantageous in the very anterior ciliary body tumor, so you can reach with the curve of the device. So in 2025, we can really access in all those indications the subretinal space without vitrectomy to reduce the complication, and hopefully this is going to open the door to more innovation in that space in the future. Thank you.
Thank you very much, Tamer. Anyone?
Just one question.
Anyone would like to ask a question? Or are you all tired?
When you do the biopsy, do you aspirate manually? I mean, this is a very small gauge, I'm assuming. Do you connect it to a manual aspirator, or you use the same, like when you inject, but you put the machine on the extrude mode?
We've done it both ways.
Okay. Any recommendation? One better than the other, or?
No, you just have, because it's very small, we have to be just patient. And when we go in close to the tumor, so we go in and out within the same area multiple times. You can go in different locations, but the opening is very small. So the tip of the device is 25% smaller than the 41 gauge.
Thank you for the lovely talk. My question is about management of these kind of submacular hemorrhages. There are various reasons for the submacular hemorrhage. So in macular degeneration, we know that what to do. But what about patients who have had these kind of massive submacular hemorrhages secondary to anticoagulants? So does that hinder you actually going inside the eye, or you do exactly what you have done here?
Yeah, it's working. Yeah. So we looked at this in the US study for the subretinal air. Many of those elderly patients are on antiplatelets and anticoagulants. So it doesn't increase the chances of a new bleeding, but if they bleed, the bleeding is usually worse for those patients. And I have some that had multiple recurrent bleeding, and we don't have a choice. We have to go in and displace. All those patients now, there is a very good reason they need to be on that systemic treatment. And since we use small gauge, we don't stop any of that prior to the procedures.
Okay, thank you.
Yes, with the cutter biopsy that we use for malignant tumors, the rate of the negative results for the biopsy are somewhere around about 10% reported in literature. In your technique that you just demonstrated, how often do you get negative results? The common sense says the way you do it, the incidence of the negativity should be much higher.
So it is a great question, because there was a debate about the size of the port of the vitrectomy to get a sufficient biopsy before. So far in the randomized study, what we know is that we do the gene expression profiling, and we're doing the PRAM. And using the vitrectomy probe versus the device, there were only two situations that disagreed about the monosomy and stage 1 and 2. And one time was in favor of the nano, one time was in favor of the vitrectomy probe. So at least we can say that it is non-inferior at this point, but we need more information.
Thank you very much, Tamer Mahmood. And next to speak is Dr. Ghazi. He's going to talk about the approach to diabetic fractional retinal detachment repair.
Thank you very much again. So this is something that is very common to all of us. And you will see that there is really not much development in the realm of traction retinal detachment. It's mostly surgical approach. But I decided to divide this talk into three main categories that represent our approach to patients. First is the pharmacological preparation of these cases with anti-VEGF, which I think is important in some cases, not all cases. Then the advantage of small gauge cutters. I used to do all these cases with 27 gauge, and then for many reasons, mainly financial, now we're using 25 gauge. And finally, this may be something that you like, maybe, is highlighting what I believe is a misconception in the traditional teaching for managing cases of traction retinal detachment. So let's start with anti-VEGF preparation. As you know, anti-VEGF has several applications in the realm of diabetic retinopathy. For the sake of this talk, I'll demonstrate its use in selected cases of traction retinal detachment preoperatively. Now, why do I say selected? Because not all cases need it. For example, a case like this was completely involuted fibrovascular membranes. You don't need anti-VEGF, and you can do the surgery without any major complications intraoperatively. In other cases, cases like these, where you have active fibrovascular proliferation, no place for PRP in these cases, then anti-VEGF becomes very handy. And we have laboratory evidence, we have histopathology evidence, we have clinical experience and human studies that show that anti-VEGF in these cases is beneficial. Here's just an example of a Cochrane database study as well as meta-analysis that show that the preoperative use of anti-VEGF in these cases reduces surgical time, reduces intraoperative and postoperative bleeding, facilitates surgical maneuvers, and improves surgical outcomes. And our experience is the same also. As you know, in our area, we have a lot of patients that are poorly controlled, type 1, multiple comorbidities, poor access to care. So they really present with very advanced disease with no prior ophthalmic care. Here's an example, a patient who came first presentation, hand motion, for 2 years, posterior pole completely covered by fibrovascular proliferation. We did bevacizumab injection, and the patient's activity quieted down really well, and then after surgery, uneventful with a very good visual outcome. Here's another case. Again, the first presentation, combined traction rhegmatogenous retinal detachment with significant pre-retinal and subretinal hemorrhagic complications, poor vision, no prior treatment at all, no care before. We did surgery and again ended up with a very surprisingly good outcome. Here's also a third case, first presentation, very advanced disease, similar story. So our personal experience also suggests that anti-VEGF is very helpful in these cases. Now keep in mind that there is a major concern with that, which is progression of the detachment while waiting to perform surgery. And Fernando Arevalo and the Pan-American group, as well as other colleagues, have done beautiful studies on this. They published several papers, the largest one on about 700 patients. The incidence of progression was not high. It's only 3%, so the majority really do not progress. But keep this in mind. And what they found, really two important findings that guide our practice, is that the majority of these detachments that progress do so if the surgery is delayed more than 5 days from the injection. So the recommendation is to try to interfere within 5 days after the injection. This is why we don't do the injection until we are sure that the patient is cleared for surgery. You don't want to inject them and then find out that the surgery is canceled. And finally, use a low dose of anti-VEGF. There are several studies that show that these membranes are extremely sensitive to anti-VEGF. All what you need is 6 micrograms, yet we inject 1.25, 2.5, etc. So use a low dose of preoperative anti-VEGF. So timely surgery and a lower dose of anti-VEGF to prevent progression of retinal detachment. Now the second part is the use of the small gauge cutter. As you know, we've been getting smaller and smaller with the gauge of the cutter over time. And I'm going to demonstrate to you, hopefully, how the cutter can be used as a pick forceps for plane establishment, as a vertical scissors for segmentation, and as a horizontal scissors for delamination. Really, all what you need is one instrument. Here's a case of combined traction rhegmatogenous retinal detachment, 27 gauge. You can see the hole here, and you can see how easily you can insert the cutter to use it as a pick forceps. And then here for segmentation as a vertical scissors, and then delamination with fold back vitrectomy. Once you relieve the traction of the retina, look, you can fold the membrane back without any movement of the retina. Here you see how easily it goes into a groove between two retinal folds. And here it goes easily into a tight plane between a plaque of fibrosis and the retina. Vertical action scissors for segmentation, and then end port vitrectomy for delamination. So really, it's a multifunctional probe, and the smaller it is, the easier the access to the tight planes. I find that I don't have to use bimanual surgery a lot in these cases. Sometimes we do. This is a case that was left with this plaque that is causing folding into the posterior pole. I use scissors first with the forceps, and once I established good planes, I switch usually to the cutter. I like to thin the tissue before removing it in order to minimize the risk of creating breaks. And I feed the tissue with the forceps into the port of the cutter, as you will see, to try to thin it. You'll see I'm not decreasing the area of it, I'm just thinning it so that it's easier to segment. And I keep doing this until I find that there are no safe planes for further dissection with the cutter. Then I move back to the scissors, as you will see in a little bit. The scissors help me create better planes when the tissue is completely adherent to the retina. Here I go back to the scissors, and once I establish the planes, you know, you have to be very careful not to create any breaks. Then I go back to the cutter to use it as a vertical scissors and horizontal scissors. So here you'll use me switching back to the cutter in a little bit. And once you have the cutter, it becomes very easy to segment. So I segment it into 2 parts, and then I use the shaft many times to peel the tissue of the retina. And then once it's free, you just fold it back very easily. The last bit, I had to switch hands and use the cutter in my right hand and the forceps in the left to remove it, and then at the end you can end up with a good outcome. This is 2-3 weeks after surgery. The patient improved to 20/40. He did really well. So this is an old video. It's 23 gauge, but it shows you the steps of surgery that are familiar to all of us. I like to truncate the hyaloid first, to truncate the AP traction. Then you trim as far anteriorly as possible the hyaloid, and then you trim as far posteriorly as possible until you reach the membranes. Then you start membrane dissection with all the instruments that you have, uni-manual, bimanual. As I said, this is all 23 gauge. But most importantly is to identify vitreous schisis, which is really the rule in these cases. I always use triamcinolone to try to identify schisis and remove all what is left of the vitreous. And then you can use the small gauge cutters for easier access into these membranes. Now I'll close with what I think is a misconception in our traditional teaching for the approach to retinal detachment. If you read our book, the chapter on traction retinal detachment recommends surgery when the detachment involves the macula for less than 6 months to 1 year. They don't recommend surgery for chronic cases because it is felt that chronicity precludes recovery of meaningful vision. We looked at 96 such eyes, and to our surprise, by the way, the median duration for the detachment in these eyes was 12 months, so really chronic cases. And to our surprise, we found that the proportion of patients that improved, had 20/200 vision or better, improved from 17% to 40% postoperatively. So they doubled. And those with ambulatory vision, 5/200 vision, also doubled from almost 35% to 70%. So this really showed us, at least in our experience, that even the worst group of eyes can retain useful vision if well treated, and that really the traditional teaching is not accurate. It needs to be reconsidered. So in conclusion, preoperative anti-VEGF is a very helpful adjunct to diabetic vitreous surgery, particularly traction retinal detachment. It allows intervention on aggressive, sometimes previously considered inoperable cases. It allows for prompt intervention without the need to wait for PRP effect, etc. And this may be specifically helpful for uniocular patients or for patients with bilateral severe presentations. It decreases intraoperative and postoperative bleeding, facilitates maneuvers, and improves outcomes. Beware of progression of traction retinal detachment after the injection. This is why it's recommended to interfere within few days from the injection and to use a lower dose. Small gauge cutters, I think, are very helpful in these cases for the reasons I demonstrated in my videos. And finally, I believe that the traditional teaching of avoiding vitrectomy in chronic cases is inaccurate and needs to be reconsidered. Thank you very much.
Thank you very much, Dr. Ghazi.
Any questions?
None.
Okay.
So, seems they're like getting tired.
Very familiar topic.
Next is Dr. Amjad here, and he's going to talk about the ROP. Dr. Amjad. The price and price of treatment.
Assalamu alaikum, everybody. Hashmani Sahab, Dr. Hashmani, Numan, Arslan, thank you very much for inviting me. And thank you for organizing such a lovely conference and the Qawwali night and the lovely dinner. Just for the sake of record, I'm not a professor, but it feels very nice to be called professor. Thank you. So I work in one of the largest tertiary eye care hospital. So what I'm going to do is I'm going to give a small introduction of the ROP, the burden we have got in Pakistan. And then we set up a new service in Al-Shifa Eye Hospital, the Surgical ROP Treatment Center. And I'm going to go through different cases, what we did. and what we have achieved so far. So when I was searching online last night about if there is any ROP society in Pakistan, I came across this one. I wasn't aware of this. I don't know if Dr. Khakan or Janna Sahab is aware of this. But a few doctors came along in 2014, and they gave us the criteria for ROP screening. Interestingly, every time I was doing the Google search, this website was coming up again and again. And they claim to be one of the greatest wrestling event organizers. But I don't know if they are the greatest, if they are organizing the greatest event. But what I can tell you in the next slide is the disease burden we've got in Pakistan. We are very good in producing babies, so we produce 6 million babies every year in Pakistan. And we need to do the screening of 180,000 babies every year. So in our center, we are doing the screening of 1,000 babies every year, which means we need 180 more centers similar to that, the level we have. And unfortunately, 9,000 to 10,000 babies, they are at a risk of getting blind every year. So this is the disease burden. And as Claire Gilbert from the UK, she has said that we are going through, the Pakistan is going through the epidemic at the moment. So the ROP service in the Al-Shifa Eye Hospital, we've got a multidisciplinary team. We alhamdulillah, are providing the free of cost treatment for the ROP treatment. We've got two different departments. The pediatric team, they do the screening, they do the anti-VEGF treatment, they're doing the laser treatment. We, as a VR team, we have developed, we invested heavily, and we developed the anesthesia team. We recruited few pediatric anesthetists. We invested heavily on the machines, the imaging machines, and I'll show you the examples on the further slides. So the pediatric team, they are doing 3 clinics in a week, 7 to 10 babies every week, and makes around 800 screening visits annually. So coming to the surgical team, I do 2 clinics per week, 2 theaters per week, and we've got the imaging team, anesthetic team. We don't have the neonatologists, unfortunately. It's a standalone eye hospital. We've got the pediatrician. For any neonatologist, we send the babies across the road to one of the other hospitals. So imaging, we've got the access to the optos, to the red cams, we've got the access to the fluorescein, OCTs. Anesthesia team, we've got 2 pediatric anesthetists. We did, in last 18 months, we've done around 190 surgeries, and all the babies, they were able to go home, except one baby who needed the NICU stay overnight. And we are doing around 11% bilateral surgery, simultaneous bilateral surgeries on these babies. So if you see, this is a typical start of the list. The anesthetist is happy. Suddenly something goes wrong. All the research team, they come in. The baby gets stable. And when I tell the anesthetist that I need to do the bilateral surgery, he really gets pissed off. So the surgical audit, we did around 199 cases in last 18 months. Initially, the first 6 months, we were having all the stage 5 cases, but luckily the stage 4 cases are now growing, and we're getting the early referrals. We do buckles, lensectomies, indirect lasers, PPV, everything. So coming to the audit, very interesting slide. The first one, the Wong Patel, it's from Great Ormond Street, London, where I used to work. They were doing 23 gauge with the endoscope vitrectomy, 82% success rate, while the lensectomy was only 0%. In our center, our success rate is 85%, but the lensectomy rate is very high. That is because we don't have the access to the endoscope at the moment, but hopefully we'll be getting that very soon. Coming to the second row, Kapuni from the USA, their results are 73%. Alhamdulillah, we are better than the USA team. So I'll go through the different examples. I'll start with the easy cases. I had this one case referred to me for the second opinion for having the laser treatment. If you see temporally here, there are some blood vessels which are dilated, and they were concerned it's a plus disease. We just waited, and after a few weeks, the baby was growing and there were no risk factors. You can see the blood vessels, they got better over time, so baby didn't need any treatment. We are aware of the recurrence cases, especially with the Lucentis or Petisra. So this baby had the first Patizra at 36 weeks PMA, and then came to me after 4 weeks with the recurrence. The disease was still in zone 1, and he was advised to have a laser. I opted for the second Patizra, and you can see the blood vessels, it pushed out in zone 2, and we were able to do the laser later on, but at a smaller area, not a bigger area. And I'm very impressed by our imaging team. They managed to get the OCT on this little baby, 6 months old. A few cases from stage 4. So you can see on the top left, very aggressive disease and started to develop the tractional detachment nasally. We did the vitrectomy, the ridge started to settle down. The blood vessels, if you see the blood vessels, they're pushing out now. Case 2, again, aggressive disease. You can see the blood vessels looping, tortuosity, and this time there is a more disease nasally. And I went in pretty soon because the macula wasn't dragged. If we leave it longer, there's a risk of the macula being dragged. Another case, the other eye was absolutely fine. This eye had a macular hemorrhage, premacular hemorrhage. Our pediatric team waited for a couple of months. It wasn't settling down, came to me, and it was a very difficult dissection. The blood becomes the part of the retina. It's very difficult to find the plane. So I think the sooner vitrectomy would have been a better option. So more complex cases, stage 5. So if you see, the right eye had a shallow detachment, the left eye is almost closed. Decided to go in and do the buccal. Good results, patient is doing very well. You can see the B scan, you can see the color images. Another case, baby Hussein, bilateral disease, stage 5. If you see, it's already closed up posteriorly, anteriorly open. So went in and did the lensectomy and vitrectomy. Post-op, there was a partial attachment, and the fluorescein did show a good vascularization of the retina. So I would like to share the video the mother sent me a few weeks ago. Don't look at the target. It's not a safe target to show to the baby. But look at the smile on the baby, the focusing, the fixation, and the following of the target. And a lovely smile this baby gives. So remember, this retina is not fully, it's very difficult to get the full attachment in the stage 5. Despite a partial detachment, this baby walks into my room actually, and if I show the target, follows the target. Another stage 5 case, you can see this is posteriorly closed. I went in, did the vitrectomy, lensectomy, vitrectomy, pre-op. The top left is the pre-op B scan. This is few weeks after the lensectomy, vitrectomy. You can see the funnel is opening up. Partial attachment on the red-free Optos images. And over months, you can see the retina is flattening slowly and gradually. And this one is the last image, 6 months post-surgery. Unfortunately, this baby didn't have a good fixing and following, and I wasn't sure what's happening. So we did the fluorescein, and unfortunately, if you see, the blood vessels are only very localized. Unfortunately, somehow there was a shutdown of the blood vessels, and the baby didn't have a good fixing and following. So every baby who comes to me is referred as a ROP. So not every baby has got the ROP. If you see this one, this looks like to me a syndrome. It doesn't look like to me as a typical ROP. This is probably Norris disease. So the other eye was completely gone, so I offered them the surgery. And to my astonishment, there was a very good result. So the blood vessels, the retina, you can start to see the retina, the blood vessels started to push out, but this big area is still ischemic. So the plan is to do the fluorescein and do the laser in this baby. Very interesting baby. This baby was referred to me, one eye stage 5, the other eye was stage 3 with the plus disease.
referred by the pediatric team, and I spoke to the parents, and there was no history of prematurity. The baby weight was above 2 kgs. So what is this? So we did the extensive testing, and luckily I came across one of the papers from Kikesh, from Suleiman, last month in Retina. And he presented a case with the protein C deficiency. We did the same test, baby came back as protein C deficiency. So what did we do? He's been referred to the hematologist, and we did the Avastin and laser, and the retina is holding well at the moment. So the other eye we couldn't save. Last few slides, I know you're coming. Late presentation, the babies, we do get the babies now who had the history of prematurity, didn't require a surgery, but you see this 5-year-old baby, child now came to me with blood vessel proliferation. We did the OCT, looks like intraretinal, so I have not done anything. I'm just closely monitoring this baby. Had the similar thing in the other eye. Unfortunately, another case came a couple of weeks ago with a previous history of laser, but the laser marks looks like to me as a cryo. I don't know whether it was a cryo or the laser, but the blue lines, the arrows are showing the large break, and the black ones are showing the scar tissues. Very nice paper. If you see this one, it's the life history of the babies who had the prematurity but didn't require the surgery. 50% of these children, they were having some kind of retinal issues, or latest degeneration in 54, 40% babies were having the retinal detachment. So that's a very heavy disease burden. We have to follow these babies apparently lifelong. So take home messages, screen, and please refer early. And talk to each other. We in Islamabad, Rawalpindi, we have started to get the early referrals for the screening and for the surgical, for the surgery. I never knew, I used to listen to Stevie Wonder, but famous musician with ROP, I never knew that he had the ROP and got blind because of this. Happy to have any questions.
Thank you very much, Dr. Amjad. Doing a great job, a very difficult one.
Thank you.
Very few people would put their hands in it. Thank you so much. Dr. Aman Siddiqui. You want to ask a question? Please make it short and crisp because we are running very short of time.
It's a khane ka time ho raha hai, you're right.
Can I have a mic, please? Oh, okay, it's working. Good talk, thank you. I was aware of Propera. I was part of Propera, but it actually was fading away because it depended on just one person coming from USA and then reactivating it every so often. I've done a lot of work. This is just not a question, but an awareness thing. I've recently delivered a lecture on epidemics of ROP, and I think we are still suffering from, we are passing through epidemic of non-awareness. And unless we increase this awareness, I've been in Karachi in different hospitals, maternity units, and people, well-educated people, well-aware people, they are not aware of what ROP is all about. Some people got even aggressive coming from AKU, how dare you come and say this. So unless we do something for awareness, not only in general public, but also in physicians and pediatrician neonatologists, we are going to continue seeing these unfortunate babies. And mind you, that mother was very dangerous sort of mother who was lighting a match instead of lighting a torch. And I think I was scared sitting there. So yeah, we need to, it's a message for everyone, we need to increase awareness, otherwise we will continue seeing these blind children. Thank you.
Thank you very much.
I'm sorry.
I'm sorry, we are running very short of time.
It's just a continuation of this question. Before he answers that question, I'm sorry. This is the awareness that is very important. The Propera awareness program have outlined the guidelines for the screening process. And we are trying in Karachi on an individual basis. Recently, we published a awareness brochure, 3 languages on PMA. So this is very important that we make the public aware about ROP.
Thank you very much. There was one question from Dr. Hakan. Sir, आपका सवाल था क्या?
So I just a quick comment regarding all this PROPERA. We made the organization, we start working, but nobody follows. Just for the making the organization, making the guidelines, making the awareness doesn't end. Because I am following the ROP kids that are very badly treated, and they are just treated by the name of they are getting treatment. I am very happy that you have shown very good cases, you did good lasers. I have seen the cases very bad. Every preterm kid is getting anti-VEGF. For what? So every preterm is a ROP case. So it's nothing about PROPERA or making the guideline, making the awareness. First we have to train our people how to treat the ROP. It's nothing about the organizations. Thank you so much.
Thank you.
Thank you. This is a very interesting subject, this retinopathy of prematurity, and a neglected one. And all the participants who have come here, they will find in their bags a book written by Professor Idris Sethi about retinopathy of prematurity, and they will find it in their books, in their bags. Thank you.
Assalamu alaikum everybody again. I'm going to talk briefly about the changing paradigm in the management of diabetic macular edema. So I'm not going to talk about macular degeneration because I think we are short of time, and Dr. Misbah would be pleased to know that. He's smiling. These are my disclosures again. The question is that why do we need more intravitreal therapy? We have so many injections. Why do we need another one? The thing to remember that the adherence to intravitreal therapy is very, very low, and we cannot extend treatment even on treat and extend regimen beyond 3 months in about 50% of the patient. So here comes the angiopoietin pathway. I don't want to bore you with basic science thing, but remember that Ang1 is the good guy. And what they do is that they allow the tightening of the endothelial cell junction. They recruit parasites which wrap around blood vessels, prevent leakage, and they result in maintenance of vascular stability and homeostasis. Then comes the bad boy, the Ang2, which actually blocks Ang1 pathway. And that results in the parasite loss, leakage, and the problem. The angiopoietin discovery happened back in 1996, where the molecules were identified. Their role in tumor was discovered a couple of years later. And then their role in inflammation and parasites were discovered in 2004. In 2016, Ang levels were found to be elevated in patients with retinal diseases. As many of us know that if you look at Ang1 levels in various diseases, they are relatively similar, but Ang2 level are higher, particularly in patients with vein occlusion and diabetic retinopathy, which has been the case with VEGF as well. So elevated Ang2 contributes to vascular instability, as we have discussed, loss of parasites and all, which results in vascular leakage. Faricimab is the first bispecific antibody designed for intraocular use. And it has, it's one molecule, but 2 functions. So if you look at the molecule, it is something like this, which has an anti-Ang Fab and then anti-VEGF-A Fab, and then it's a modified FC fragment which prevents, which causes less inflammatory process in the eye. So compare faricimab with aflibercept, which is mostly used to be the standard of care. If you look at it, that Ang2 together with VEGF2 improves the anatomical outcomes during head-to-head studies. And when we look at these PTI algorithm, and I'm not being political, but in this study there were 3 arms, faricimab 6 milligram, which was given every 8 weeks. Then there was a treat and extend regimen, but this was protocol-driven treat and extended regimen, and then there was aflibercept every 8 weeks, as we do in most patients. And what they have shown here is that it is 53% more likelihood of reducing the median macular leakage in patients who have received faricimab injection. When you evaluate USMITE and RHINE, faricimab demonstrated durable efficacy. So you look at the results, they are very, very similar. And there is mean central subfoveal thickness is also reduced. But what is interesting is the durability. So when you look at the data, that in patients who have received treat and extend regimen, up to 60% of the patients were able to extend to 4 months. So they were receiving 1 injection every 4 months, which is currently not possible with other anti-VEGF treatment. What is interesting in this slide is to note that the time to achieve median absence of intraretinal fluid was 9 months earlier in faricimab group, comparing to aflibercept. And I think we all know as a retinal surgeon that the aim is to dry the retina as much as possible to reduce visual damage. The first faricimab injection was given in Pakistan back in June 2023, but back then it was based on a special request, on a special permission from DRAP. But now it's easily available as a choice for patients who require this injection. Now, the question that we have is that does giving more or higher dose of anti-VEGF improves outcomes in patients? We know that in READ-3 and PHOTON trials that 4 times higher dose of ranibizumab and aflibercept was given, but the treatment were not hugely different. The last 2 things that I would like to mention about faricimab is that its effects of ANG2 inhibition on biomarkers. So the hyperreflective foci that we see in diabetes have shown to be much less in patients who have received faricimab compared to patients who have received other anti-VEGFs. And I think it has to do with the effect of faricimab, that it is dual inhibition. The new vascularization and vascular leakage effect is the VEGF effect, which is inhibited by other anti-VEGF as well. But the elevated ANG level also cause inflammation and fibrosis. And what it does is the faricimab, it actually blocks inflammation and fibrosis. And the effect of blocking fibrosis is actually particularly important when you look at the epiretinal membrane formation. I think many of us have actually dealt with these patients who have developed epiretinal membranes in diabetics after getting multiple anti-VEGF injections, and I have found them particularly difficult to remove because they are quite adherent. But what has been shown here, if you look at the graph, is the patient with faricimab Q8 weekly and the patients who have received the aflibercept Q8 week. There's a 52% reduction in formation of the epiretinal membrane. So this is really, really important because many patients in diabetic patients actually develop epiretinal membrane. And the risk of epiretinal membrane without diabetic macular edema may prevent anatomical improvement in some patients in which there is a presence of epiretinal membrane, but because there is edema, we keep injecting. And of course, that would also cause reduce improvement in the vision. The epiretinal membrane, because of its tractional effect, may also result in limiting the extent that we can extend the duration of the treatment. And this is the first phase 3 evidence of anti-fibrotic activity of any intravitreal treatment. So to conclude, we can say that faricimab demonstrates greater improvement in clinical biomarker activity in diabetic macular edema compared with aflibercept 2 milligram, and it causes faster drying and reduces eyes with hard exudates. It also results in reduction of hyperreflective foci, and we have also seen that it also causes reduced epiretinal membrane formation. Thank you.
Thank you so much, Rahman, for sticking to time. So our next speaker is Professor Khakan. He is going to speak about failed macular hole surgery.
So give me.
USB किधर है तुम्हारे पास है? So, good afternoon, ladies and gentlemen. This is my last talk today. So, I will be presenting a continuation of the talk that Tamer did about the macular hole surgery and grafting. He talked about the retinal grafting, so I will not touch that topic, but I will touch the other maneuver, other techniques, how we treat the failed macular hole surgery. So I will be going to talk about the amniotic membrane graft. I am going to talk the massage of the hole, and I am going to talk about the hydration of the hole. So let's see how it goes. Where is Karachi? Karachi. So if the primary macular hole surgery, we learned that there is a new classification that tells you what is the large, extra large, double XL and giant retinal tear. But what about the failed macular hole surgery? What options you have? One is obviously the retinal grafting. So here are the options that I know till the day, but people are trying. Recently a new option is subtenon tissue for filling or covering this gap. So I am more about the amniotic membrane grafts, hydrodissection, massage, and retinal graft has already been discussed. So I will not talk about this. I will just share a case of a female, that 55-year-old female. So I did this surgery. I did his macular hole surgery, and the hole was not big. So I did conventional ILM peel, but unfortunately I was not successful in her surgery, pity. So later on you see how much big hole, it's almost the size of optic disc. So it was big macular hole, so, and because I did the surgery, so I knew that there is no ILM. So it's the minimum diameter is 1062, so it's it comes in the giant or double XL, Tamir. It's double XL or giant? Giant, okay. So here are, so I choose the amniotic membrane graft. I will share you my technique, that how I do. The people have a different technique. So this patient got the cataract, so I did the cataract surgery and 23 gauge vitrectomy system. So here you can see the large macular hole. Even I did myself, I injected little bit of blue, so maybe I will get little bit ILM, so I will cover the ILM with this, the hole. But you see, there is no staining of ILM even up to the major vascular arcade. So there was no ILM. So when I do conventional ILM peel, I usually peel from arcade to arcade. But from last few years, I am not doing conventional ILM peel. So here you can see there is no ILM actually, and then I planned for air fluid exchange, and I do the amniotic membrane grafting under the air. I don't use the perfluorocarbon liquid or anything. So here I am drying the retina, and it's just under air, and my technique is not to fill the hole. If you fill the hole, it will never close. You are just plugging it. Let the hole lips be open, and you get a centripetal movement of the hole. Unless you don't get a centripetal movement of the lips of the hole, this is not a closure, okay? So here you see, I just drop near the hole, and then I will cover it, because my understanding is that every hole in the world will close if it gets a scaffold. So I am just giving a scaffold with this tissue. This tissue has not much to do, although we know that these have a placental-derived growth vector that helps in regeneration. But here you see, I just dragged it, little bit of fluid, not to harm the retina, and soft tip extrusion, I am just putting it over it. So here is a surgery. So at the end of this is the post-operative OCT, and here I couldn't get a better one closure of the macular hole, but it's still closed. But I didn't plug, it's just covered. So why it happened? Later on, we got the biggest publication about the amniotic membrane graft that we published in 2022, and we concluded that you can get even type 1 closure with the amniotic membrane graft. Only the situation is when you operate within 3 months of primary surgery. If you delayed the failed macular hole, More than 3 months, then you get the secondary macular hole. So try to do the second surgery, whether you are going with the amniotic graft, whether you are going with the retinal graft, within 3 months as early possible after the failed macular hole surgery. So there is one more case I'm going to show. 60-year-old female underwent temporal flap, SF6 macular hole didn't close. And I will show you this, our technique, how we do it. This surgery was, patient was referred to me. This is not a very large macular hole, but you see where I'm showing that this has a deep excavation and a lot of xanthophyll. Surgery was not done by me, so I stained the posterior highlight. Maybe there is a vitreous that is hampering it to close, but there was not any vitreous, so I just flushed it and got it out. You see the macular hole is quite big there, so I just aspirate it, and after doing the staining the ILM, I just make sure that if there is ILM, then I will do superior or inferior flap. But you see the surgeon did the temporal flap, but the flap was very small and it dislodged. So then I planned to peel the rest of the ILM. I could have two choices. Maybe I could have done another temporal flap, but I didn't choose this time. So I just peeled the ILM because they're recurrent surgery, and I did the hydrodissection. So I just brought out my extrusion needle with the soft tip, and here I bulb it up. Just break the adhesion of the macular hole lips that are with the retina. Massaging the macular hole, and just I am doing this little bit massage of these holes with the soft tip extrusion. Even in the holes that are less than 800, 900, those even are recurrent hole. They are even peroperatively with the massage, they are already closed. Unfortunately, we don't have intraoperative OCT, but I am sure that they are closed during massage. So here it is that we see in the post-operative OCT, so there is a complete closure, type 1 closure in these cases. So my two preferred options are amniotic member grafting or hydrodissection or massage in the failed macular hole surgery, and obviously retinal grafting. So thank you so much for kind attention. If you have any question, I am here. Thank you. So I take the opportunity. So I got the opportunity to come to the Karachi and this big event. Recently, I have edited one ophthalmology book. And this book is very different and very rare idea that I got. I have 13 books in ophthalmology, but this book is even non-ophthalmologists will enjoy. So I will request Professor Sharif Hashmani to come on stage with me for the launching. Professor Mazhar Ishaq, please. Professor Fawad Rizvi. So I got the opportunity to launch this book. So I got 5 minutes for my presentation. So I finished my presentation in 5 minutes, so I have the 5 minutes. So I will get Nico, come. Professor Adi, please come. Please join. You should. Nico, come. Waleed, Tamir, Ravi, come. So can I get my presentation, please, about my book? So this book is not a typical ophthalmology book where you get the text and theory. No text, no theory. Not a single word of ophthalmology, but it's the book of ophthalmology. Can I run the presentation of? This idea just came very quickly when I was traveling to the Karachi. So why not to use this forum? All my teachers and my colleagues will be there. So I got this idea. So if we can run that PowerPoint for the meanwhile, I will. Can I have somebody to take photograph, because it's one of my very rare idea that I got it. So actually this is the eye of the world. This is the island in the Maldives actually. So I name it Eye of the World. Next, please. You can press it. Next. Next. So next, this is me. So this is total hyphema resembling a blood moon. So this is hyphema, how is the blood moon resembles. So the undercoat is not from the ophthalmology. This is from the literature. Next. Ecchymosis. So the underworld in a world of light, dark eyes shine with a unique brilliance and reflecting stories untold. So there is nothing about ophthalmology, but it's about the ophthalmology. Next. So morning glory anomaly. Morning glories with their fleeting beauty remind us to cherish the moment that brighten our lives. Next. So it's the whole book is like it's a talk show. Fog, we learn the trust of our intrinsic findings, our way not to be sight by the intuition. So this whole book is like it. So I would love to Professor Sharif to open it and just to launch it for the, everybody can join me here. Yeah.
It's surprising that you get time to think about such things also.
The only difficult thing was to get the codes for these every disease. The other things were very easy and it's fun. When you love something, you find the way. Thank you, sir. So this is for you. Thank you, sir. And I will honor everyone. So this is for you. And this is for you. This is for you. And this is for you. And I will get a little bit more. Come here. This is for you. Yes. For you. And this is for you. So thank you so much for having me and giving me the opportunity. Have a nice day. Thank you.
Ophthalmologists for the services of ophthalmology. So I have the honor of reading the citation of this year's gold medal recipient. And I say honor because I really feel very honored in reading these lines. The recipient of this year's gold medal was born in Karachi on the last day of the year 1952. His early education was in Karachi, and he did his graduation in medicine and surgery from the Dow Medical College in the year 1979. He later moved to the United Kingdom and worked at the Birmingham and Midland Eye Hospital and did his fellowship in ophthalmology from the Royal College of Surgeons of Edinburgh. He later moved back to Pakistan and worked in various capacities as a teacher and the faculty member in Jinnah Postgraduate Medical Center, the Liaquat Medical College, and the Dow Medical College. And finally, he retired from the Dow Medical College as the chairman and head of the Department of Ophthalmology. He later moved to, after some time, he later moved to Saudi Arabia, and he worked in Riyadh in the King Abdulaziz Medical University. And he was the head of the ROP department there. He is an able teacher, and besides teaching so many students, he has a lot of papers to his account also. He has had 113 scientific presentations in different ophthalmology conferences, and he has to his credit 33 papers published in national and international journals. He has been the managing editor of the Journal of Pakistan Medical Association, and he has been an active member of all the medical associations, and he was the president of the Pakistan Medical Association Karachi branch in the year 10 to 15. He has been the president of the Ophthalmological Society of Pakistan Karachi branch, and then later the Ophthalmological Society of Pakistan Center. And he has been the supervisor and the examiner for the membership examination, that is MCPS, and the fellowship examination, that is the FCPS, and the vitreoretina fellowship examinations of the College of Physicians and Surgeons of Pakistan. He has been the projector director of the Prevention of Blindness Cell, Government of Sindh, Pakistan.
Dr. Professor Nicola Ghazi to present his challenging case. And during the case, you have the opportunity to stop the speaker and ask the question how it dealt the difficult situation. Professor Nico, please.
Thank you again, Hussein, for and
कराची की
also
बढ़ती हुई आबादी को मद्देनजर रखते हुए मेरे पास जो मरीज हैं वो दूर दराज से जो आ रहे हैं
okay. So thank you very much. This is the final talk. I want to thank you, and I want to thank the Hashmanis, Dr. Sharif, Dr. Nauman, and the CEO for the kind invitation and hospitality and for including me. Thank you very much. It was a pleasure to be here. So I'm going to discuss with you a rare complication of a very common procedure. Basically, it's a hypotony case. This is the case. A 59-year-old lady had a complicated cataract surgery in 2019 and then had an IOL exchange in 2021. I saw her in 2022 after a full year of hypotony. The eye was soft when you touch it and the vision was counting finger. You can see here the haptics of the scleral fixated IOL. Now I wanted to ask some questions, but for the sake of time, I'll keep going. You can see here right away that this is maximum 1.5 millimeters posterior to the limbus. So this is in the ciliary body, number one. Number two, this is a technique. It's called the bridge technique. I didn't do it, where the haptic is brought outside one sclerotomy and pushed directly into the other sclerotomy under the conjunctiva. So you can see the hypotony effect, papillopathy, maculopathy. So how would you approach this? Again, I'm sorry because we cannot take answers. If you need anything at the end, just for the sake of time. But basically what I did is an OCT of the anterior segment and a UBM, and you can directly tell that the haptic of the IOL is in the suprachoroidal space. It's causing a cleft-like effect. So that's at least what we thought. And we felt that the IOL is really the cause of hypotony. Now, definitely we needed to make sure there is no leakage around the haptics. So we theorized that this is a hypotony caused by alternate aqueous pathway, and this pathway needs to be closed. So here's the surgery. First, we needed to make sure that there is no leakage around the haptics, and definitely there was none. So this also supports our theory. We decided to look inside, and you can see here how there is tinting of the ciliary body. The same thing here on the other side, tenting where the haptic is. So this also confirms our theory. We marked the area where the haptic goes by endoscopy into the ciliary body so that we can come back to it later and laser it or cryo it. And we removed the IOL. We had to remove this foreign body. It was like a stent, like an eye stent or the modern glaucoma surgeries that you have. We're removing the haptic ab interno rather than ab externo, as you can see over here. And then we went back in, and this is why we lasered the area initially to mark where the entrance is. And we lasered the whole ciliary body area, hoping for an adhesion between the ciliary body and the sclera. And this was the end of surgery. You can see here, 6 weeks later, pressure came up from non-recordable to 16. A phakic, definitely 2150 with +10 lens, and the resolution of the papillopathy and maculopathy, as you can see. We let the eye rest for 9 months, and then we came back. This is the video I showed you in the morning, so I will skip over that. But we did our technique for secondary IOL insertion, and she ended up with a very good outcome. Here you can see the IOL at the end of surgery. And this is the OCT 6 weeks later and 3 months later with a 20/80 vision and IOP of 12. So what I want to emphasize here is that the retinal effects of hypotony can be reversible. There is literature about that. My experience also supports this. Even up to years after hypotony, you can reverse the situation and expect visual acuity improvements as long as there are some residual photoreceptors and you don't have ticicle features or hemorrhagic choroidals. So thank you very much. Any questions?
Thank you, Professor Ghazi. Anyone have any questions? Yes, please. You can go to the mic and so we can listen it.
Yes, it was a nice presentation. I was wondering that you said that the loop is damaging the ciliary body. Is that right?
The what, sorry?
The loop,
Yes, the haptic.
Haptics, yeah.
Yes.
So it means there is a cyclodialysis has been happened.
That's true.
If there is cyclodialysis, usually the pressure rises. It's not the hypotony occurs if you have a cyclodialysis. Am I right or?
No, it's the opposite.
Is
if
it?
you have cyclodialysis, the pressure goes down.
Down, okay.
Because of the alternate pathway.
Any other question, please? Yes, Tamir.
A great case. When I looked at it, I thought of a scleral cleft first time. So we used to use a gonioscopy lens and try to put a suture to close the cleft. You think it would work or it wouldn't work because the haptic is keeping that space open?
Exactly. We thought about doing cryo alone. We thought about suturing it. The thing is, as long as this foreign body is in the supraciliary space, we felt that it's going to continue to channel fluid around it. It would be very hard to, with a suture, zip the whole area through which the haptic passes in the suprachoroidal space.
Would it be possible to adjust the haptic?
This was another thing that we thought about, but I think the tilt is what created it. You know, so it was the IOL was torqued like this, and the ciliary body was stripped off the sclera by that. That's what we felt.
Well, the outcome was great.
It worked. You know, it was 2 surgeries, but it worked. These are good questions. Yeah.
Well done, Ghazi. So, if we don't have any question, we will take our next presenter. Thank you so much, Professor Ghazi, for your nice presentation.
Thank you.
So, our next presenter is Professor Jose, and here it is.
All right, thank you very much for the kind invitation, and I'm glad to do new friends. I'm going to present this case. I don't see anything.
Excuse me. Excuse me.
Yeah, that's the case. This case was sent to me. He had cataract surgery, extracapsular cataract surgery 3 weeks before. And let me stop here. Where it's. And this patient had the anterior chamber was completely flat. There's no anterior chamber. The intraocular lens was almost touching the endothelial, and there was a total choroidal, a kissing choroidal. So we started surgery doing an sclerotomy. I just put as a sclerotomy and to drain the blood. And after that, I can put for infusion in the anterior chamber. I'm going to put an infusion in the anterior chamber right now. Well, it was a lot of blood. Then the anterior chamber forms a lot, just a little bit, and I put a maintainer. Well, after that, you can see that the intraocular lens is luxated, so I take out the intraocular lens. And then we're going inside the eye to see what is happening inside the eye. This is to have also some retinal detachment over there, so I put some diathermy in the retinal tear. And just did a regular vitrectomy with perfluoroinectan and endolaser and silicone. and keep this patient aphakic. I didn't put any intraocular lens. After 3 months, we take out the silicone oil and put an intraocular lens. We put anterior chamber intraocular lens, the iris fixated intraocular lens. Yeah, and that's it, the surgery.
Thank you, Jose. So actually you dealt with the suprachoroidal hemorrhage and you removed the scleral fixation Yamani technique. Noman, you have any queries regarding the scleral fixation now? He was behind me from last 3 days. Why not Yamani? That's why not Yamani. Any question, Tamir? Yeah.
I mean, looks great, the drainage. The question that I had is that because you had the choroidals, so you drained most of it, but you still have some. So when you put the silicone oil in, because there are still some choroidals, there will be an underfill. So sometimes we would consider an expansile gas bubble so it can push a little bit more. How do you feel?
Yes, you're right. But in this case, because it has some folds and the retinal tear was superior, I prefer to put it in silicone oil because if it was something missing in the lower part, it's okay because the tear was up, was in the upper part of the eye.
Any more questions? If no more there, so
Well,
thank you,
very
Jose,
much.
for a very nice presentation. And our next presenter is Professor Walid from Tunisia, Al-Maghrib, Maghrib Al-Arab. So here you are. You go.
So it's a case referred to me for silicone removal and cataract surgery, combined surgery. So here we place, as you can see, there is a synechia between cornea and iris and cornea. And now we try to remove the synechia. We try to dye the anterior capsule. Then, as you can see, there is a synechia between iris and the cornea. We are helped with the OVD. Then we attack the synechia behind the iris. Then we do the capsulorhexis. It's easy. It's supposed to be easy to emulsify this white cataract, not hard one, but I'm trying to move the lens. I can't several times, but it doesn't come. And then I feel that's not, I don't have anterior chamber stable, so we are posterior PCR, and we have a tsunami of oil, silicone oil, and the lens drop down. So now I remove the silicone through the cornea. It's very simple, and keep the lens drop down. Now I do lensectomy with the vitrector. It's 23 gauge, so it's easy. I decrease my set. I increase my aspiration and decrease my cut. And I clean the remaining cortex behind the iris, and I try to find the sulcus to put the 3 pieces one. Then I have to verify the stability of the lens. I inject a bubble of air in the anterior chamber, and when I move the eye, the lens drops also. So I try to catch the lens, and then I check there is no stable sulcus. So I decide to do a very, very modified Yamani technique. So I engage the haptic and the needle in the cavity. So as you can see in the cavity, I do for the first haptic, then for the second one. We cauterize the extremity of the haptic to ensure the stability of the haptic through the sclera. We finished with the anterior segment. Then I try to go over to the anterior posterior segment. So when we see there is a flat macula, so I decide it's a long time for surgery. I decide to keep it and wait and see. There is a fibrosis around the macula, so I decide to keep it and wait. That's all. And for you, you attack the posterior segment after that or no?
Sorry?
You attack the posterior segment, the retina to flat the retina or no? You keep it?
No, I will try my best
Huh?
to attach it. So any questions?
So that's all.
Yes. Catch it.
Yeah, I think, there was no way for you to see the anterior segment before because of the white cataract. And I could see some rubiosis. And with this appearance of the retina, I think this suggests that this is a very sick eye and the visual potential is not great. So I would do what you did, is just leave it alone, minimize the damage, and see what happens. What was the vision post-op? Was there any meaningful vision in the eye?
It's scout finger.
Near face, very, very close.
Scout finger, 1
Yeah.
meter. So it's okay.
I mean, where there was lots of ischemia, the retina is distorted, so I agree, I would have done the same.
Okay. So thank you. So we will start. So next case is mine. So it's very simple. I will try to be very quick. Silica band intrusion. Is it there? Yes, it's there. So this is my case. This is brief history. 22-year-old male. He underwent scleral buckling. Right eye perception of light. Left eye is 6/6. Here it is. What you people will do? He is presenting like it. Starting from the left or right. Amjad, what you will do? This is silicon band behind phakic eye, 22-year-old male. Quick, we don't have a time. 1 minute for the question answer. Yes, Ghazi. You will take it out. How? So think quickly. We don't have a time. So here it is. Can we switch off little bit lights? Yes, Ghazi, how? What you will do? So B scan was done, and retina is detached. The silicon band has the swirling of co-right.
What is
here.
the vision like, Hakan? What is
Sorry?
the vision? What is the vision status?
I told you, perception of light.
So what is the fun of doing anything in this case?
There's a lot of fun. I will show you. There's a lot of fun. So next, Jose.
I will check it out.
I am now operating even
first
NPL
planner.
eyes. They
First
give me
planner.
PL. Yes.
I also get by pars plana.
You will remove the band?
Yes.
How?
Doing a sclerotomy by pars plana and take it out.
Sclerotomy. Tamir.
So the vision was light perception even before the intrusion, or?
I don't know. Patient presented with me like this.
So you would consider exploration. So I want to know from outside, how did it look from outside, and then decide what's the approach.
Oh, that's the wise decision. Yes, Walid.
I dissect the conjunctiva and I see what happened.
Okay, my inference was that I will go and do the peritomy. I will find the band over it, cut it and remove it. But I was feared of this choroid that has a churned around. So this is my one of favorite case. I name is as believe it or not. So this is per-operative image, silicon bond into the anterior highlight. This is a phakic eye, 22-year-old male. So you can see. So he got buckling 7 years ago, not much long time. It's an award-winning case. That's why I am the author. So I started the surgery and let me move a little bit forward. I did the peritomy and I start slinging the recti muscle to explore the silicon band over the sclera. I was surprised that I couldn't find any silicon band over the sclera. There is no silicon band over the sclera. Half is inside the vitreous cavity, rest I don't know. What you will do, sir? No, I am showing you all 4 quadrants here. Where is the arrow? Here is the only tip of the silicon band only. Sir, there was no visible silicon band over the sclera. So I changed my plan.
Go inside pars plana vitrectomy.
Sorry?
Pars plana vitrectomy.
So I changed my plan. I wanted to go inside. But till that day, I didn't find any case in the literature where people have performed this surgery. So this was my first patient and was my first surgery. So here it is. My main concern was how to cut it. It's tight like a rope, and there is no big scissor than 23 gauge. Even 20 gauge scissor if I need. So, but it was very tight, very hard. Even with the horizontal scissor, you cannot cut the silicon band outside the eye. So I was checking how tight it is. It is like a bunchy rope. So then I decided why not to waste a little bit more time. And I did it with the horizontal cutting scissor. Will you believe? I cut it with the 23 gauge horizontal cutting scissor. The main issue was it was just behind the lens. I was phakic, patient was young, and I didn't want to sacrifice the lens. So cutting was not issue. Cutting and saving the posterior capsule and not harming the eye was main concern. So here I started it. First I started to cut, it was nothing. Then I closed the prong and make a hole in the band. And then from the hole, I cut the upper part and cut the lower part. It took me more than 10 minutes to cut this silicon band. So here you see I am cutting it and just checking around it. How it will help? How it will help by manual? With what I will hold it. So it's just behind the phakic eye. It's not in the mid-vitreous cavity. It's coming from the ciliary body. So here you see I am cutting it. I spend a little bit more time. And here the last piece I am cutting. And here it goes. You see? It detects how much. So after doing this, job was easy, and there was a 180-degree joint retinal tear, the all area from where the band intruded. It cut the retina also. So I will be quick here. So I performed the vitrectomy, injected the triamcinolone, peeled the PVR membranes, injected the perfluorocarbon liquid, flattened the retina, and did the laser and put the silicone oil. And here you see, so retina got flattened, laser was done. How many of us has ever seen such case? Anybody? So how I knew that how to operate it. So this was just my inference how I went. So this is not the single case. I have 7 cases similar like this now. I am the hunter of intrusion now. So this is at the end of the surgery. So perfluorocarbon liquid and oil exchange was done.
Hakan, who is sending you these cases?
Sure.
No, who is sending you these 7 cases?
I mean, I never ask. Allah sends me. What I desire, Allah gives me. So here it is. So I will show you the post-op. Look at the post-op. This is wide field imaging. So where it's gone? Excuse me. Where my image is gone? Hello, Mr. IT, come here. Here it is. So here you can see the retina is flat. There is a little bit indentation in the superior part, but patient went very well. And everything, you will not believe, patient ended at 612 VN. So here is all images of the retina. This is first post-op day even. So we are following this patient from like more than 2 years, and thank you so much for this kind attention. If you have any question, so I am with you. So here is one more. And what it is, this is quiz for you. What it is, who will judge, he will get one more book. Switch off the lights, the image is not very clear. What it is, now see, is the silicon band sleeve over the retina in the vitreous, and the retina is attached. You see, it is coming from here, and it's coming from here. This is sleeve lying over the retina, like a pearl. This is not the only case, this is 2. I have a couple of more, maybe sometime else. So our next speaker is, if you don't have any questions, I think. So next speaker is Tamir. Tamir, can you join? Yes, sure. No, I can't. You switch on it. Little bit, yeah.
What happened to the band?
I left it.
You took out the band?
No.
You left the band?
Yes.
How about after you cut the band, the piece that was intruding, you left it as is?
Yes.
And on the exploration from outside, nothing was leaking?
No.
You just covered the conj over
yes.
it?
You know, I think
it's a self-closure. Self-closure.
Or
all the band retracted. Till the day I cannot find the edges of this band.
You know, or it's a scleral tunnel rather than suture, a scleral buckle.
Though the nature made a 5-step wound in the sclera.
Yeah.
So, follow the nature.
You know, they do scleral tunnels.
Do you think this sleeve case is bleeding, where the sleeve is inside? Should it be in a botany?
No, if you already had follow-up that long and it's good.
So
I learned not to argue with a good outcome. Okay, so just a quick introduction here is, can I get the...
Just a second, they are switching.
Okay. Oh, it's not... So the focus is going to be when we have retinal detachment with PVR, but at the same time we have a large macular hole. So whenever you have PVR with a large macular hole, you have to peel the posterior PVR. Whatever we do, any type of graft we do, if we don't peel the posterior PVR around the hole, it's going to retract and it's going to open again. So here, this is what we're doing. We peeled all the membranes and then we're going for a retinal graft. And then you can see post-op under the PFO how nicely it's completely closed. But there are many ways to address this. This is another case that had RD with PVR. And we can make the case much easier. So after peeling the membrane, we can delineate the graft at the edge of the retinectomy. And then once we fill the eye completely with PFO, we basically change that complicated cases of RD PVR to a simple macular hole with a graft. So once you delineate, you already have the graft attached to the retinectomy edge, so it's going to keep the orientation of the graft. And once we add PFO, we can then cut with the vertical scissor that last edge of the graft and move it to the macular area with the flex loop. But here, I said before that I leave the PFO in the eye for 2 weeks and then take it out. But for those cases, because of the PVR process, we need the silicone oil for a long-term tamponade. So ideally, we would do a direct PFO silicone oil exchange. So everything goes well. We did the PFO silicone oil exchange, and now the silicone oil is in the eye, the graft is in place. The problem is that when you have those cases of a very high myopic RD PVR, recurrent detachment in PVR, you peel all the membranes. We need bimanual access. The last one I could do it unimanually, but those we need bimanual access. It's very difficult to reach and put the graft. But once we put the graft over the area of the staphyloma, it is also very risky to do the direct PFO silicone oil exchange. So what I decided to do is, I said, let's leave the PFO in the eye for 2 weeks to make sure the graft stays in place and become incorporated in the retina. Then I can go back and do PFO silicone oil exchange. But at the same time, because of the PVR process, I started injecting methotrexate every week. And at 2 weeks, the edge of the retinectomy looked really good. So I said, I don't want to risk displacing the graft. Why don't I continue injecting methotrexate? So it seemed to me the advantage is that I'm injecting the methotrexate for the PVR process, but at the same time, I'm preventing any complication from the PFO being left in the eye for that long. So then by 4 or 5 weeks, I started seeing more bubbling of the PFO, so I felt there is no advantage of leaving the PFO anymore. So I decided to go in and remove the PFO, but because the retinectomy edge looked so good, I didn't put oil in the eye. And the retina stayed flat 2400. So one of the advantage here, or the concept here, is that we can possibly avoid long-term complications of silicone oil by, in those complicated cases, leave the PFO 5 to 6 weeks, inject methotrexate, and then out and done. So we have published recently about the value of injecting methotrexate even after removing silicone oil for high-risk cases. But these are the take-home messages, even for residents and fellows. Whatever you do or any pharmacotherapy you're going to use, it doesn't replace a good procedure. You have to peel what you can peel. If you need to do a retinectomy, do it. Consider methotrexate for high-risk cases, even in cases when you are removing the silicone oil, because the redetachment is as high as 25%. If you have a large macular hole, you need to do a direct exchange, you can do it. For high myopic, where it's risky, you can lose it. Or for other PVR cases, to avoid the long-term complications of oil, consider leaving the PFO in the eye, do methotrexate weekly for 5 to 6 weeks, and you can avoid using oil. Questions?
Nice talk, Tamir. Any questions? Yes.
Know more about the PFO safety, because what we have been seeing and what we've been taught earlier, that PFO is very toxic. It has got a pressure effect, and it can just give you a gangrene of the eye. It causes gangrene of the eye. So how safe PFO is nowadays after your evidences, that 2 weeks, 3 weeks,
Yeah.
1 month, 2 months,
No,
how
so-
long we can leave PFO?
Yeah, so for the regular cases of macular hole with the transplant, I leave it routinely for 2 weeks and take it out, and I didn't have any problems. There was only less than 2% or 1% that had a little bit more inflammation, so I use higher dose of topical steroids. But for those cases now with RDPVR, you know, I have few cases now that I left it for 5-6 weeks, and I think what's helping me is that I'm injecting methotrexate every week. So I'm reducing any potential inflammation or any complication from the methotrexate. But once you have a good procedure and the edges look good, at 5 to 6 weeks, that's good enough.
There are a lot of papers coming up nowadays having inferior retinal detachments, reed detachments, and which they put on perfluorocarbon for 5 to 6 weeks and then doing the lasers and then taking it out and having very few reactions. So there are
The
lot of
addition of methotrexate can help, and we know all the complications of oil, so that could possibly be an option.
Thank you, Tamir, for a nice case. And at this, we conclude our session of challenging cases. And Numan, Dr. Numan, yes, you can proceed with the proceedings. Sir.
You did very well in time, man. This is the closing session now, and it's a time to award shields to our speakers and our guests. So the first person I'm going to call is our chief guest, Honorable Major General Retired Professor Mazhar Ishaq. Please kindly come. Dr. Sharif Hashmani, kindly come and hand over the shield. Mazhar? Professor Mazhar Ishaq. Please stay here. Huh? साइज की टोपी दीजिए Mazhar Sahab यहीं ठहरे. Next, I would like to call Professor Tamir H. Mahmood to come and receive his shield and certificates of appreciation. Please, come forward. Certificates लाओ, certificates लाओ, सारी चीजें एक साथ हैं. तीनों चीजें एक साथ हैं. Dr. Waleed, please.
Yes, sir.
Shah Sahab.
Sir.
अब जो शील्ड आएगी ना सर ने देनी है आप शील्ड दिलवा दें शील्ड दिलवाएंगे आपको नेक्स्ट पेशेंट नेक्स्ट को next is Dr. Jose Antonio Roca. Please. The next is our friend Dr. Nicola Ghazi. Professor Mohammad Hussain Khakan, please. Professor Idris Sethi, please. Dr. Rahman Siddiqui, is he around? अभी दो रहे Dr. Amjad, please. Dr. Noman Hashmani, please. Is Dr. Nasser here? You kindly please come and give the shield to Dr. Noman Hashmani. A video competition was held during this Congress, and quite a few people participated in that. And the winner was? And the winning award was given to Dr. Saleh Naz. Is she here? Is Dr. Saleh Naz here? Okay, we'll send a shield to. Shield? So, may I request the chief guest of this occasion to kindly say a few words.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Misbah. And it's really been an honor and a privilege to attend this conference. It's not my first time. Sharif Hashmani has, it's not requested me, has always ordered me to come over here. And as I've seen, we are coming here since 1917. And I must say that even being in a private organization, he has that vision and this ability to go for the best. And I will just give you one example that about 10 years ago, or about 15 years ago, we were about to start with the femto cataract. And I work in one of my hospital institution, and when I asked the company that why have you not giving me the machine, he said this was a promise that the first machine has to be given to Sharif Hashmani because he said that is the only way he's going to take it. So it has to be the first one. So if you remember, so I said that for me that doesn't really matter, but better get it up. So he's one who looks after, who wants to go for the new innovations as soon as possible. And I think so it runs in the family, and we are very happy to see our next generation coming up with the event of Noman coming up and taking over, and we hope that he's going to follow his father's legacy in letter and spirit. I'm really grateful for all the foreigners who have come from all over the world, from Lima, where I would love to go, and from America, and from Tunisia, and from Abu Dhabi, and from my own city, Rawalpindi. And then I can't leave Khakan, the man behind the gun, I would say, as we in army say, that it's always a proud moment to see somebody who have seen him from the very beginning of his career joining us and now leading from the front. And I fully hope that you will carry on this legacy. You will keep on carrying on this, bridging and getting all our, I would rather say that he's putting Pakistan into the map of ophthalmology of the world. With this word, I'm really very grateful for all of you, for the spectators to come, for the organizers, for holding this such kind of meeting, and it's always a pleasure coming here. Thank you very much.
Any of our distinguished foreign guests, would you like to say a few words? Any one of you? Tamir.
Yeah, well, at the conclusion of the meeting, on behalf of everyone, our friends, the international ones and the local hosts, it's been a fantastic day. We met many friends here in Pakistan, and we had great discussions today. And I said, like, when I was coming here, I only knew one in Pakistan, my friend Hussein Khakan, and I was very excited to be here. But now I have so many friends here, and I met so many over the last 2 days. And I hope in the future we would be able to visit and host you in our countries too. And thank you very much for the hospitality and everything that we have experienced here today.
Thank you, and Jazakallah for your kind words. Ladies and gentlemen, this has been a very successful Congress. We have been busy for the last 3 days. But actually, there have been a lot of people who have been busy for the last 3 months. And there were several committees which were to work day and night to make it possible. I can't really take all the names, but I want to thank all of the committee's chiefs and the participants, and their able leader, Mr. Sikandar, who have done a very excellent job to bring this conference to a success. And this would not have been possible without the help of our sponsors. The Medstech, the Roche, the Rodenstock, Barrett and Hodgson, Latif Brothers, Sante Private, Amir Deen, Sorabji, and Chaigon, and Rainer. And I must thank also all the participants here who have come, taken out a lot of time from their precious time to be here and listen to us patiently. And finally, I would ask all of you to give a big applause to Arslan Hashmani, who has led all this campaign as a leader and brought it to a very high success and at a very good note. Thank you very much. May God bless you all. Thank you all. Thank you very much. Now the cameraman wants a few pictures.